Florence Nightingale was not the first, we are not the first people to face grim conditions in our work, as I showed you above. And back then, what was needed then was pure air, pure water, effective drainage, cleanliness, and light. And my question now is, what is needed now in healthcare? Once we get rid of the got it, I guess I could do it here. I'll show you 4 dots that I'm hoping we can fill in today about what is needed now to heal our employee experience. So let's shine a light on things like the lady with the lamp. Here we go. So if we're gonna unlock voice, we're gonna have to change some conditions. So the first thing I want to do is look at our current strategy for voice, almost universally. There it is in its glory. We tell people to speak up. How well do you think speaking up works in your organization? So who here thinks that people are speaking up more than 50% of the time? Think of those board meetings, chairman's meetings. Does anyone think people are speaking up more than 50% of the time? Oh dear, no one. Less than 50% of the time are people speaking up. Okay, all right. So if you had a factory and you had a gate that opened and your gate only opened 50% of the time, so only half the workers could show up for work, would you keep this gate? Is this a Six Sigma situation? No, it is not. So, however, I don't want to blame anyone. This is the strategy that has been handed to us, and there was no other strategy out there. So we know speaking up, and we all know this, it doesn't work and it never will. So what in the world are we going to do? If you find your voice, that small amount of people that find their voice to speak up, what happens? Falls on deaf ears. So essentially, we have a pretty big problem. And I framed it as the elephant in the road. So before COVID, all the hospitals, you know, from the Joint Commission, we're going on our high reliability journey. And I said, I don't know how to tell you this, but I don't think your journey is going very far because you have an elephant in your road. And that elephant in the road is the amount of silence and leaders not listening. And we need to figure that out. Now, Ina said to me this morning, well, you know, leaders, they're very interested in the money and also power. Power is what makes things move. So my message to leaders is, when you're working, and why are we having these problems in the backdrop is, we are thinking linearly, okay? And we think we make a plan, we do work as imagined, and you're gonna just speak up if there's a little problem. But the truth is, our work is so complex that real power in that wonderful wild world I showed you is the ability to learn. It is not compliance, it is not control, it is how fast you learn what is truly going on and how quickly you can adapt. So let's shine a light on our current strategy and its 5 foundational flaws. First up, we spent all this time and money talking to the wrong people. When you think about it, it's quite overwhelming because really only the leaders, or I'm going to say people in power, leading shifts. If you are the valet with the elderly couple, you at the door, you really are the person in power, frequently the nurse, and it's shifting. You know, suddenly the chief of surgery is with the board and well, now he's not in power. So when you have the power in the room, you're going to have to be the one. Most importantly, it does not address the underlying factors that are driving silence. So according to the research, these are our 3 things. We're battling fear, feelings of futility, and powerlessness. So until we can remove these thoughts from our employees' minds, we will continue to be stuck. If I speak, will I be helped or harmed? If you have an uncertain person in an uncertain environment, this is very, very dangerous. Nothing ever changes. They give up and they're preserving their energy. They've stopped speaking up because it didn't work, or powerlessness. I just don't feel like it's my place to say this. We're going to have to overcome those. It has a very narrow view of purpose. Speak up implies there's a problem, somebody's made a mistake. You know, speaking up never gives you that warm, fuzzy feeling, does it? Meanwhile, we need voice for innovation, for teamwork, for so many other things in an organization, but we speak up really implies, well, we'll be hearing from you if there's a problem. Meanwhile, we'll be in a strategy meeting. Language is unhelpful. I realized I think we could possibly subconsciously be reinforcing the hierarchy with the up part. So that's something to really think about. Not to mention, it's an imperative statement. It's a parent-child non-conversation. 2 words, speak up. Finally, I believe it's unfair. I think it places all the responsibility for upward communication on those of lesser power. So this is what we have, and I'm sure there's more flaws. I don't know which one is worse. But in the end, I said, what is the problem with this speak up thing? And what's missing is, and the reason it doesn't work, it does not align with the nature or the needs of people or complex systems. So this is why it's failing so badly. So we all know those universal, inescapable needs, they're not going to change. We can't change them. We can only come to work as a human. We have not been treating people like that, and you can only cheat Mother Nature for so long. Secondly, complex socio-technical systems have their own special needs, and that's about where we all work. So after studying them for a while, I realized, I think these are the essentials. But these are up for debate. But I think in a complex socio-technical system, you have to have that capacity to notice, share, and even welcome weak signals of trouble. We have to have effective sense making. And if you haven't studied sense making and some of the work of Carl Weick, or I could give you a much easier to read version, sense making is the child that got left behind. We talk about decision making, decision making, decision making. If you go back to these cases, you will see they made perfectly good decisions for what they thought was happening. And instead they had misunderstood their world. And sense making became a real passion of mine. And that's actually what prompted me to look at ambiguity and then stumble across how badly we need diverse perspectives as we work. Finally, we need the capacity to tap expertise, improvise, and adapt quickly. And this is all founded on trusting relationships, which we are sorely lacking. So I came up to this assertion. I think it's time to move on from telling people to speak up. I think it's outdated and ineffective. And we've made advances in many other areas, but not with how we strategize our knowledge flow. So I created a model I call Speaking In. I have a registered trademark because if I didn't, someone else would get one and then I couldn't. However, it's a touchy subject because it's way bigger than me. I want to share this message, so I'm going to equip you enough to go out today and actually start leading like this if you so choose. And I'm going to tap some smart people to help me figure out how to share a message with the world, keep it pure and good, and still make enough money so I can finally go work on human trafficking. So for leaders who's it for? It's for leaders who embrace the idea that learning is power, believe the quality of the employee experience matters, and want to take that next logical step towards aligning their strategy with the needs of people and systems. It's for people who believe your greatest resource is the health and knowledge of the people in your organization. Finally, we are learning this the hard way with the nursing shortage, and it's a very, very, very sad thing. So this is what Speaking In looks like. It means that when you're that person in power, and eventually everyone understanding that we can do this, but leaders have to lead. We need to intentionally include, invite, and then appreciate diverse perspectives. And if we leave any of these out, we're leaving ourselves at risk for blocking our knowledge flow. So there's 5 shifts that are embraced in the Speaking In model. First, and they each tap a very surprising power and complexity. So our first shift is person to purpose, okay? Not speaking up to Bob, who's having a bad day. I'm speaking in from my unique perspective around the purpose of the organization, because the only thing stronger than a bully in an organization is the purpose and the values of that organization, and we need to keep them flowing. So we're going to tap the power of language by switching to in, and the power of contribution that's going to happen for that person around purpose. We're going to switch from a me to a we mentality and realize that for the leaders, diverse perspectives do a few things, including reduce blind spots and bring expertise, and for the workers, gosh, I hate to use that word, for the other people in the organization, that starts to engender the belonging and the contribution that everyone's after. A next shift is periodic to continual. Speaking up is very much understood to be an occasional thing that happens. We need to have a continual speaking model in our mind. Why? Our plans are imperfect. We have to that, and believe it or not, that is the core of high reliability organizing, saying as good as our plans are, there's still a dark space around them, and we need to be ready for it. We must fight our overconfidence. We need continual sense making. Others can see what you can't, and most importantly, we have to overcome the power dynamics. We are not intentionally, as leaders, paying attention to how difficult it is to share your voice when you think that there's risk involved. So we're tapping the power of intention. Next, we're going to, by leaders starting to intentionally include and invite, we're going to tap that power of inclusion. And now, instead of those three bad feelings in the employees' heads, we're going to have people saying, you know what? It's safe to share here. I'm not at risk. Hey, they listen here. It's not futile to speak up. And my perspective matters. I am not powerless in this organization to create change. We're going to shift from telling to asking. So the power of invitation is really, really, really huge. And when the research is already there from 2006, and we're not using it. So here was Ingrid Nembhard and Amy Edmondson, of course, reporting leader inclusiveness, words and deeds that invite and appreciate can take nature off its course, helping to overcome status's inhibiting effects. So we already know this. We also know this from Elizabeth Morrison, that the powerlessness can be reduced when the individual expects the voice target be open to input. Why? No one wants to be the messenger that gets shot. And we need leaders who say, oh, it's my job to make it clear I'm open to input. A next shift. Challenge to contribution. No matter what you think of that information, we need to acknowledge the fact that somebody shared it. And I believe this moment here, when somebody is sharing their perspective, we need to think of it as a gift. We have to immediately convey that we're thankful for it. And also the final piece, assure them we're going to take good care of it. We'll get to that in a minute. I believe that this moment is the most powerful moment in your organization. How we receive that gift of knowledge from another. And this determines everything, whether you're going to build the trust, whether you're going to get more truth. And if you can get on a positive cycle of receiving input as a gift, I think you'd be amazed at what becomes unlocked in your organization. So the good news is you can acquire the keys to unlock your greatest resource. And according to my studies, it'll come in the form of attitudes, questions, and actions. I could not get another key on there. And of course, all of these things are founded on what we, our assumptions, which are our beliefs. So I believe that transformation starts with the individual. And luckily, Deming agreed with me. That's a joke. But that is the people who have to have new thinking. They will then transform the systems, and then the new experience in the system will then transform even more people. So this is my little transformation worksheet. If I believe these things, who will I be? What will my attitudes be? What kind of questions will I ask, and what will I do? So in terms of some key assumptions to just equip you, if you say, oh, you try the speaking in thing. If you do in fact assume and believe more is possible than I can plan for or imagine, that will create some respect for how other people will be involved in addressing the uncertainty. And if you believe employee experience is the lifeblood of your organization, that will lead to working with these attitudes. And I already know from meeting you that most of you have these on your hearing already. This is not a problem in this room. You've all been demonstrating this through your life and your work. So the foundation of the questions, practicing speaking in means that you learn how to continually be asking what I call the fear-reducing invitational question. So if you see this question here, where these folks are standing around a pool, but some things are unclear. And what the leader is doing, he is saying, or she, what do you see? It would help me to know. And they are signaling ahead of time that that answer is going to be helpful. And the question itself is reducing fear. So I'm going to give you 3 questions that I devised. I want you to picture yourself around a hospital bed. This is a resident. This is the patient should be lying down. This is the nurse, a family member, and the patient. So think of how many situations might be transformed if, in fact, these questions were asked, and they go in, they deepen at each level. First, the resident knows to ask, is there anything else you think I might need to know? I'd appreciate it if you shared. And maybe it's just, oh, did you see that potassium that just came in? Oh, did you know that my mother actually never wanted this type of surgery? Oh, there's just some interesting information floating that I didn't know. How about this? It would be helpful to know, what are your concerns, questions, and ideas? Oh, it's going to be helpful if I ask this question? I didn't think it was going to be helpful to ask this question. I thought it was going to be annoying to ask this question. So now this resident has unlocked some of the inner thinking of the folks. And third, and this question is from Clean Language. If you haven't checked it out, I suggest you do. My favorite question. What could help me is considering, what would you like to have happen? And in this question, you are tapping latent expertise in the room. And sometimes that is even the answer to that can come from the parent. So those are the key questions you can start using today. And I'm sure many of you use them. Next, the key action of appreciate and take care of the gift of knowledge looks like this. Thank you, I'll take good care of this. And then get serious in your organization with how you actually take care of it. I didn't get a garbage can made yet, but I'm talking with some construction companies, and they want to talk about the fact that workers raise a concern and the supervisors basically throw it in the trash. The other bad things that we can do is suppress it. We've all seen it. We sweep it under the rug. We encapsulate it in a small report we hope no one ever reads. Worse yet, I think, we do a public relations job on it and we call something other than it was, and we ruin trust in our organization. Next, these are all possibilities that are helpful, would be a local fix, a global fix, or inquiry. The most beautiful question for inquiry I ever heard, and it was around a discussion about just culture. He said, I think the answer, I can't remember his name right now. He said, I think the answer is not prescribing anything, but sitting around an incident and saying, who and what does this incident call us to become before we start prescribing things for folks? So I ask you, what kind of conversation will create the conditions that we need to heal the employee experience, to deliver the care we intend, to overcome the challenges of complexity that are only going to increase? So in January, I'm going to have a 5-day free challenge where it's going to be some inspiration, it's going to be some learning, and it's going to be some real-time practice. I can't wait to hear your feedback, please, of all kinds. I invite you because it will help me to know what you think. There's my email. Funny that my name is spelled with an I-N. Maybe it's providential. Thank you.
Are there any questions for Ms. Newman?
I was running away.
I think that quite inspirational, actually.
I will tell you this, that I'm very excited about. In December, 12th through 16th, worst timing ever, I'm going to take speaking in, meet with the evidence-based practice people from Ohio, and I'm going to go into their immersion process. Because let's say I've done a lot of research, but my academic ducks are not in a row. They're swimming in circles. We'll get there. Any questions you have, I can certainly answer later. I know we want to stay on time.
So not to be negative, but I can see this working kind of for mid-management down, but how do you propose to kind of get it to a higher level so it's working throughout the entire organization?
Well, yes, that's a very good question. And right now, I'm just really seeking the leaders who are ready for change. Everyone, I don't believe that in an organization, every single person is going to say this feels good, and there is some inner work to do. But I do know there are leaders who hit their burning platform, and they're like, okay, how do we have to shift this organization? You know, and I have personally sat with a leader who said the worker was injured, and this was the CEO, and he's like, okay, what have I done to create a culture where this could happen? You guys need to tell me. So it's possible, it's rare, but I do imagine a trickle down effect. We can have leaders asking this to their, you know, the C-suite starts and we trickle it down, and people are like, you know what, we're supposed to actually ask. But the first thing we have to do is make space for those diverse perspectives. And the first is in our head, then in our meetings.
So Lauren, first of all, thank you. This is a wonderful presentation. And my question is, have you tied this to financial outcomes for the facilities? Because I know that's, you know, that's a really, really big.
Yeah. So, and I didn't have time for that, but very, very recent survey, and I don't know who did, but very legit. They were saying, well, how many of you didn't speak up and know that it cost your company more than, you know, $25,000? And the numbers were way up there. Every time somebody speaks up, they know it saves the organization $7,500. And that's as much data. I need more help. Does someone want to pull that together? But yeah, and you know, when we look at the reputation, the failures, it's going to be a hard number to calculate, but the cost of the incidents, the cost of the reputation, the cost of and you know, my hero now is NASA. There's a guy, Chris Hansen, and we've worked together on helping people navigate uncertainty. And, you know, when you fail in public enough, you realize we have to change, and they're there, but we're not there. But I also believe, and I'd be happy to, I have a personal okay from him. I said, you know, I think that the only industry that healthcare is going to be willing to look up to and be led by in terms of culture is NASA, because I don't think that there's going to be enough respect for other industries. And he has put out his complete willingness to share with healthcare their shift in thinking and behavior around creating a culture where people can speak. So, just put that out there. Yes.
Okay, so I've been in those leadership round days where everybody's kind of encouraged to speak up. But the moment one person does, there are consequences. And I've always thought about it is that we typically do our job because we want to make sure our line manager is happy enough to make sure that we get by the year and get a good evaluation, get an increment, and keep our jobs, right? But at the end of the day, that's not working for the system. So my question for the model that you're introducing, and it's a great model, how are you linking it to performance management? In what sense? If, for example, each and every tier in any organization are supposed to be kind of working towards the same target, aka safety and quality indicators, be it a starting nurse, be it a technician, be it a pharmacist, be it a doctor, they're all supposed to work against targets. And those targets are quality in nature, safety in nature, and hence whenever somebody speaks up, they're associating it to their performance at the end of the year and that of their boss. So that they are all talking the same language.
Yes.
That impacts the revenue, the financials, the quality, and all that. Have you thought about merging the performance management aspect of things versus the model of operations so that nobody would worry that they're going to lose a job at the end of the year?
Yes.
Because they spoke up throughout the year.
Right. So we have to shift what we call good performance, and we have to shift what we measure. And Joint Commission people, someone said to me, well, if you were the Joint Commission, what would you go in and ask? And I said, I would ask one question: show me how you learn. And I think that what the high-end leadership needs to be saying, come, show me what you've learned, tell me what problem you've solved, instead of how good can you hide the problem? So once we reward problems, once we normalize error and struggle and imperfection, we are imperfect people with imperfect systems and imperfect information. Until we embrace that and reward the act of learning, we will constantly see measure the miss instead of measure the ability to learn. Oh, my British friend has his hand up. I was afraid of these questions, I gotta tell you.
Hello there. So it was a good presentation.
Thank you.
There was a case study in the UK on YouTube. I mentioned it earlier at breakfast, but it was just a routine operation. I don't know if anyone's seen it, but it's about a person that went for an operation, and it was just a routine one. I mean, there are risks in all operations, but this was minor compared to the big ones. And she got anaesthetized, and they tried to tube her, DT tube her, and the anaesthetist and 2 practitioners were unable to do that. And 20 minutes had passed. One nurse tried to speak up, but she held back. And a healthcare assistant, which is like a nursing assistant, tried to get an ICU on the phone and could see that the patient was, the sats were going down, dropping quite badly, which went to about 70%, maybe less. The patient died in the end, it was 20 minutes without oxygen, after being anaesthetized. Her husband followed the investigation after about 5 or 6 years, got all this information, and then spread it across everywhere else. Since then, there's been policies where speaking up is more safer for healthcare workers, because what was learned from that isn't just the fact that there were tunnel focus, tunnel vision, looking at trying to get that tube in and not oxygenating the patient, but it was also the fact that there was 2 other healthcare workers that could have said something, tried to say something, and because they were intimidated by the doctors and the people, the practitioners and whatnot, they didn't want to get into trouble. But speaking up is very important, and I think that if policies were more out there for organisations, I think that the workforce would feel safer, and your model would fit quite well in that as well.
Yeah, I think it's the model and the mindset is a piece of this. There's many parts, but I think shifting how we think about the purpose and direction of voice is an essential element. And language is, in terms of a lever and creating meaning for what I'm doing. Okay. Oh, what does speaking up mean versus what does speaking in mean? This can be 2 different things. So that's really, we want to manage meaning. Okay. And, so I don't want to take any more time. That's what we're up against, managing the meaning. And we do have to start with the leaders. And please.
Wait. After Caroline. That's one, yes.
Thank you again, Lauren. Please join me in welcoming Dr. Claire Sorensen from the United States. And she's going to be speaking to us today on the impact of increased telehealth needs on healthcare worker well-being and burnout. Dr. Sorensen.
Sorry, guys, this is completely the wrong presentation, so I'm just going to go off the cuff. It'll be fine, I promise. So I'm Claire Sorensen. My background is neonatal and pediatric ICU nursing, and then I moved into a nursing leadership role, and now I work at the Joint Commission. I'm on the international side with Antigone, who had the pleasure of meeting yesterday. And I think Most people in this room probably have familiarity with Joint Commission. I think unfortunately, most of you have had relatively negative experiences with us. So hopefully we've turned that around a little bit and you see that we're actually here to collaborate and learn right alongside of you. I tell everybody on the international side, we're a bit more fun. We like to create a problem solving. We lean very heavily on risk assessment rather than check boxes because we don't have to answer to CMS. So that's pretty exciting for us. So just like Antigone yesterday talked about our CCPC updates, one of the things that we are introducing is actually a certification program for telehealth. So burnout and compassion fatigue are sort of my clinical passion. We all know that burnout and compassion fatigue are really taking a huge toll on our healthcare systems. It's losing boatloads of money, and we need to address it if we're going to have a successful healthcare program that continues to exist. So if we can just step back for a second, how many in this room are practicing clinicians? Good. And how many are in administrative or managerial roles where you have clinicians who report to you? Fantastic. And who else works within the healthcare system in some other way, whether it's a consulting position, supply chain, anything else? Right. All right. So how many of you have been impacted by burnout in healthcare systems? Those of you who haven't raised your hands, I want to talk to you afterwards because we need to figure out what you're doing right. So how many of you who are in a clinical role or working in a hospital or other healthcare system in some way, shape, or form have some sort of telehealth or telemedicine system that you all are working with? Fantastic news. You guys already have a piece of what is going to improve burnout for your staff in place. Well done. So if we think about the impact of burnout right now on healthcare, it is just absolutely staggering. And I was talking to Leanne this morning, and one of the things that she and I both kind of glommed onto is 20% of our nurses are leaving within 2 years of entering the profession. 20%, that's 1 in 5. That is absolutely ridiculous. Now, if we look at all of our nurses, so we're talking about our LPNs, for those in the US, those are our licensed practical nurses who often are in our support roles, your registered nurses, your advanced practice nurses who work in a provider position. We're talking about 39% are leaving. 39%. It's crazy. It's absolutely through the roof. If we look at who is experiencing burnout in our nursing practice, 60% of people are saying they are experiencing burnout. If we look to our physician colleagues, 62 to 63%. Now, we're not even going to talk about the people leaving the profession right now or leaving their roles. If we just look at the productivity of those people, organizations are, and forgive me, I don't have my numbers, but it's upwards of $20,000 a year that you are losing on productivity for one clinician. Every nurse that you're having to replace costs your organization roughly $56,000. Every physician that you're having to replace costs you between $500,000 and $1 million. Once you start looking at onboarding costs, sign-on bonuses, the revenue that's lost to your organization, how many of your organizations can sustain that? How many of your organizations are using temporary staffing to fill in those nursing gaps? If you replace one of those staff nurses, one of those staff FTEs, if you figure in the US, it's a 13-week temp contract is sort of the typical time. That's 4 temporary contracts for 1 annual FTE. You can save by hiring 1 full-time nurse to replace those 4 temp nurses, you're saving $260,000. Bonkers, right? Absolutely bonkers. That is, so if you look back at how else this impacts your organization's finances, because right, we're all here, got to figure out ways to save our money, right? We talked about that in efficiencies and supply chain and people. We can't sustain it. Our organizations are bleeding staff and they are just pouring money down the drain because we're not fixing the root problem. Now, I'm here for JCI, so we're going to talk about our products a little bit, right? Have to do that little song and dance for you. One of the things, though, that telehealth has done is it's actually decreased burnout in our staff. So I'm going to tell you about that, but first we're going to talk about the human impacts of burnout, right? We talked numbers, but how is that actually impacting our people? Who here has personally experienced burnout? I definitely have, right? So burnout impacts you physically. I found myself on blood pressure medication. I'm a tiny person. I eat healthy. I exercise. I chase my kids around. My blood at the dentist to get some lighting. It was 180 over 120. Started blood pressure meds next day. Thank you very much. Since having left the bedside, I've been able to come off those meds. That's how the bedside was impacting me. Yeah. Which is sad, right? Like I'm somebody with 15 years of clinical experience. I've got a doctorate. I love the work that I do. I'm a clinical expert. I love it. I love being the resource on the unit, but I couldn't sustain it anymore for my own health. People are gaining weight. We're talking about our chronic conditions. It's exacerbating those. We're talking about mental health. Folks are getting depressed. They're getting anxious. We're not even going to talk about the post-traumatic stress syndromes that come out of it and the secondary traumatic stress and the compassion fatigue and the moral distress and all of those other things. Those are all impacting your healthcare workers, and they're leaving because of it, because they can't sustain it. They just can't. And it's unfair of us as leaders and as the healthcare think tank leaders, which is the whole reason here today, to continue to expect our people to do that, right? We're all not just cogs in a wheel. So if you take out that cog, we're just going to throw one back in there because you're going to hire that agency nurse or you're going to find that locum physician. And that's not fair to that person because you're putting them right back into the same position, right? So what can we do? Oh, before we get to what can we do, sorry, forgive the scatteredness again, no notes, wrong presentation. My bad, you emailed me a second time and I was like, no, I already sent you that. It's been a week. It's impacting our patients too, right? There's lots of nodding. Again, we're all leaders. We've seen the incident reports. We know that our infection rates go up. We know that our pressure ulcer rates go up. We know that our fall rates go up. We know that our Prostany scores go down. We know that our leapfrog scores down. We know that our safety grades go down because you just can't be everywhere and you can't be everything for everybody, right? And so if you're running on empty already, you're coming to work because your manager called and said, we're down 5 nurses. Can you please come? You're like, well, I feel obligated to, I guess I'll show up. Just keeping that cycle going, right? So now back to what can we do? One of the things that we did during the pandemic that was really, really successful is we implemented a lot more of telehealth services, right? We all have a lot of the infrastructure already there where, I don't know, I'm still waving this around like I'm using it. We already are using our electronic health records. We're already having those face-to-face over Zoom with our colleagues. Now we are just going to make that a consistent framework. And a lot of places did that, and it was really successful. There was a lot of survey work that came out from the American Medical Association and others that your advanced providers liked telehealth. They liked it. They were like, I think there was a study that came out, it was between 70 and 80% of physicians believed that they could get the exact same quality of an exam from telehealth as they could physically in front of the patient. Now, obviously, there's things that you can't assess via telehealth, right? We know that there are some times where your patient's going to have to make that trek into the clinic or into the hospital, and you're going to have to assess them in person. But your providers are liking it. It gives them a better work-life balance, especially your ambulatory and your primary care physicians, right? Because they can stay at home. You just cut 1 hour, 2 hours off of their commutes. It used to take me over 1 hour to get to the hospital when I was doing bedside work. You're working a 14-hour day already. Now you're tacking on 2 hours, and then you're telling me I have to go home, put my kids into bed, walk the dogs, maybe eat something that hopefully not over the sink like a rat, right? We've all done that too. And then turn around and go back the next morning after 4 hours of sleep. It's not sustainable. So if you can give that, 1, 2, 3 hours back to your providers by removing that commute, that's fantastic. Telehealth also You can do your telesurgeries, your telediagnostics, all of that. It's actually improving your care systems as well because you're increasing your collaboration between organizations and inside of organization. Patients like it too. They're not spending an hour plus on the road to sit in a waiting room for 40 minutes, to maybe have 5 minutes with their provider. Because you're taking all of those late shows, no shows, double bookings out because you know your people are actually going to come. And that decreases the load on your providers too, because if you've double booked your appointments, because you as an administrator know you have a 40% no-show rate, so you're gonna double book that, what happens when your patients actually show up? You just doubled your provider's workload for that day. And that doesn't even talk about the documentation piece, right? Which brings me to my next point, which is we do have to be careful that we are not inadvertently creating more work with telehealth. We have a tendency to do that. We put a fix into place. We think it looks really great. But oops, forgot about this thing. And that has been one critique that's come out of the clinician side of things is, well, we're already doing all of this interfacing on Zoom or on our secure platform. And now I have to go document it. So how are we streamlining? You know, I know for those of us in the States, we're a very litigious group of people. So we have to document every single little thing. Maybe let's look at bringing back charting by exception. Right? And that's something that would be easily implemented into your telehealth platform. Which brings me to why JCI is involved in this, right? JCI, so we have to talk about our products a little bit. We are rolling out a telehealth certification program. The standards are in their last round of publishing proofreading. Thank the stars. They will be published on January 1, effective July 1 of this coming year. There's a survey process guide that went along with it. As Antigone said yesterday, we're working really hard. It's actually Dr. Perlin's one of his top things that he's having all of us do with our little marching orders to eliminate that duplication. So rather than laying out a lot of the same expectations that we already have in our accreditation programs, these are just sort of bonus fun add-on expectations, right? So what does that mean? It means you already have to be accredited as an organization. It applies to all of our programs. You can be an accredited hospital, ambulatory center, primary care center, home health organization, long-term care center. The only one it doesn't really apply to is lab, because there's not a ton that you're doing on a telehealth platform for lab. But if you've already met your accreditation requirements, you're already an accredited organization and you want to have your telehealth services accredited, we say, great, we trust you. We trust your leaders, we trust your organization and your people. You've already done the accreditation piece, so we're not going to look at it at all for telehealth. Kind of cool, right? Live your best life, come talk to us about telehealth. So we're looking at things, we do still have a couple of the international patient safety goals in there because some of them still apply. You know, how are you identifying your patients? How are you making sure who you're talking to is actually who you're talking to? How do you make sure that this adult with a child on the visit is truly the guardian for this person? Those sorts of things. We're talking about access. So that's your patient platform. It really helps, we all know, for our hard to reach patients who are out there in the boonies. If they can't make it in, it increases their access too. We're talking about very specific things related to care of patients through telehealth services. So how are you doing those diagnostic procedures? How are you making sure that your providers actually understand how to use your telehealth? So we do talk about training and privileging quite a bit. Because there are different things. If you want that solid clinical exam, you want to be within those 80% of providers who agree that you're getting a good physical exam, how are you making sure you're getting it? And that's not stuff that's taught in nursing school. It's not taught, I don't think I've never been to med school, but I don't think it's taught in med school how to like point a camera at your patient in a correct angle so you're not looking up at their chin when you're trying to see a wound down on their knee, right? We've all had those double chin Zoom talks. They're no good for anybody. How are you making sure the lighting is good? How are you prompting your patient to do that? And if you're doing a teleconsultation with an ICU in another country or another state, how are you as the provider making sure that you're getting the clinical information from the other team that you need? And how are you exchanging that securely? Talk a lot about the security about all of this. A lot of it. Very important. We talk about cloud-based storage and fragging and all sorts of technical things that I did not ever expect to learn as a NICU nurse, let me tell you. I was like, let me just go like learn how to bundle up all of my babies and start the world's tiniest IVs. That sounds good. I didn't think I was gonna have to be thinking about cloud-based storage, but here we are. We all have our journey, right? So why are these certification standards important? I know we've been talking, and those of you who have had casual conversations with me on the side, I'll be the first person to tell you, JCI, we do not tell you what our ROI is very well to the customer group. We know that, we're working on it. This, I think, is a really easy one because I just told you your providers like it. I just told you how much your organization can save if you stop turning over all of your staff. So the quality comes from the standard. You guys are already doing excellent quality work, I know, because you're here, so you obviously care what you're doing. But this just puts structure around it, just like most of our standards and our measurable elements do. So right now what we're doing is we're training all of our surveyors so they're aware of the new standards. Many of them were involved in the development. We went to subject matter experts for all of this content all over the world and involved them in the process. And right now we are also piloting this with 3 organizations, one a hospital, one an ambulatory center, and one is a home health organization. And they're from 3 distinct regions around the globe to make sure they function as we want, because we don't want to give you a product that's no good. So that's my spiel with no slides. I apologize for my scatteredness. Can I answer any questions? Perfect. Fantastic.
I think we're scheduled for a coffee break right now. It says we have some fruit and yes, some coffee. Let's take about 15 minutes and we'll come back. Thank you. Dr. Sorensen? Dr. Sorensen?
I would like to also analyze.
Dr. Sorensen? Dr. Singh?
Just a quick one.
Oh, that is.
And you tell us. It is the our child's going to your side. That's a good order.
I think that's one of them.
Yeah.
That was technically.
Are you ready? Are you to go?
I am good to go. Okay,
Where's the point?
thank you.
I wish you all the best.
Thank you. Hit it, Barbara.
Okay, so he's going to.
I'm next, is all I know. They changed it, they just told me. Run. Somebody was remembering this person for Zoom in.
Yes.
Carrie White. Not ready or because it would be what is. So I'm ready, you are, hit it. What she has to say. If you'll just give me 5 minutes. I don't have to.
Ladies and gentlemen, if I could rein everybody back in, please. It's my very distinct pleasure to introduce to you, excuse me, is Leanne Beeman from the U.S., who's going to be talking to us today about self-care for healthcare, the enormous benefit of health and margins.
Please take note.
Yes. There were 100 little babies laying 3 and 4 to a cardboard box strapped in the belly of a gutted cargo jet. It was 1975. Saigon was falling to the communists, and I was accidentally caught up in the Vietnam orphan airlift. Now, some people say, oh, Leanne, you were so brave to have done that. I like to think that bravery played a part, but the truth is naivete and faith played even more. Because, friends, I was no hero. I was just this ordinary person caught up in this extraordinary circumstance. And yet that lesson taught me lessons, that whole adventure that changed my life and may change yours. Because we don't have to be in Vietnam to be in a war zone, do we? We all have war zones in our lives. I know this one for me began when I was just a little girl. I have really vivid memories of Thanksgiving clothing drives at church where my brothers and sisters and I, all 8 of us, would try on our hand-me-down clothes and take it to the clothing drive. And I trick-or-treated for UNICEF and learned that 2.5 cents could buy a carton of milk and save a child's life. And I was still a little girl when I decided I was going to adopt a child someday. And so certain was I that on the very day that Mark and I took that romantic walk next to the creek in Iowa, he asked me to marry him. I said yes. And I told him of my dream to adopt a child someday. So that must have been what was on my mind that day when I was walking in the mall in Iowa City, and I came across a bake sale for Friends of Children of Vietnam, a national organization raising money for the war orphans. Well, I wanted to do my part. I wanted to make a difference. So I stopped to buy a dozen cupcakes. Understand, that is all I ever intended to do for the orphans of the world. But then I found a brochure. Oh, I should read about it. Oh, there's a meeting next week. I should go. Now, do you ever have things that start really small and you get way involved and you have no idea how that happened? That's why you're here today, isn't it? Yeah. That's what happened to me. I went to the meeting and there was a half a dozen moms sitting around a chrome kitchen table. They told me about the needs of the orphans and I signed up. Well, wouldn't you know, with just a few months, the president of that chapter moved away. I became the chapter president. Our basement, the Iowa headquarters of FCVN. We put drop boxes in grocery stores and had slideshows and did everything we could. And we shipped 5 tons of supplies from my basement in 3 years. So maybe that's why the national office then in Denver called and asked if I'd be the next escort to fly to Vietnam and bring 6 babies, keyword 6, back to their pre-assigned adoptive homes. I had 24 hours to decide if I would fly to Vietnam in April 1975. There were so many reasons why I wanted to say, yes, I'll go. I knew that Vietnam was a destitute nation that had been ravaged by generations of war, and the children were living in these horrific, impoverished conditions. And the American servicemen that had done so much good in Vietnam were gone. And I remind every audience, the good American servicemen and women have done all over the world. I wanted to say, yes, I will go, because I knew that the American servicemen had left their impression in Vietnam. Can you see the bunny ears behind the one little kid's head? Not a Vietnamese thing. Unfortunately, the American presence left more than that. There were 50,000 Amerasian children left behind, half American, half Asian. And in Vietnam at the time, children of a mixed race could never be accepted in society. And the children that happened to be half Black were even more ostracized. That race was just so foreign to them. This was a little baby that was left on our doorstep, which was commonly done, nurtured by our staff, and thrived. I wanted to say, yes, I'll go, because I knew that the children that were crippled got no money at all from the Vietnamese government. As a matter of fact, the other orphans were only allotted 11 cents per day. And I knew that the crippled kids were relying completely on organizations such as ours for their well-being and their welfare. I wanted to say, yes, I will go, because I knew that the children, the precious, precious children, needed help and hope and health and happiness and homes. These are a lot of reasons why I want to say yes. These were 2 little reasons why I wanted to say no. I can't do that. Angela and Christy were only 2 and 4, and they and my loving husband, Mark, were the #1 priorities in my life. I'd have done nothing to jeopardize that. So as I was making this big decision, I called the US government and they assured me the war is far from Saigon. It's not going to get worse. You should go, you'll be safe. Mostly I considered, Mark and I had started to make that dream come true. We had applied for adoption of a son through this organization. Now expected him in maybe 3 years, but I knew it would mean something to him someday to know I'd been there. So after a lot of thought and prayer, I called the headquarters in Denver and said, I'll go. And between the day I said, yes, I'll go, and the day before I got there, the bombing went from 100 miles from Saigon to right outside the city limits. And when I arrived at the airport, I was greeted with these words, have you heard the news? Last night, President Gerald Ford okayed Operation Baby Lift. You won't help us take out 6 babies. You will help us take out 300. That's what I said, 300. Now, I was a nurse. I was working pediatrics. Nothing had prepared me for this. I walked into the 2-story center that normally just housed 10 babies, those that were too sick to be in our foster homes. Once we had all 300 kids in one great big building, and then they got the measles. And many died because there's no immunization. So we put ads in the newspaper for breastfeeding women. So now, though, bombs are dropping, we can hear them. Our building shook a few times. So they're gathering the babies in from all of the foster homes and other orphanages. And I go to the downstairs where every inch of floor is covered with a mat and a baby. And I went upstairs and there were seas and seas of babbling, burping, bawling babies. The workers would care for them and then lay down and sleep a bit and then wake up and care for them some more. This is the first picture taken of me in Vietnam. I'll never forget. I was holding this little girl with a shaved head. No doubt she'd had a scalp IV. And I said to my friend Carol, who was with me, take this, my first picture here. Well, the next morning at breakfast, Carol and I were given our assignment for the day. We were to walk into the warehouse and pack for 300 kids. And can you imagine how I felt when I walked into that warehouse, brushed some dust from the top of a box, and saw my own handwriting? This is a box we had sent from my basement a few months before. And here I am packing the same clothes. I recognized them, but this time for a baby going home. And I thought then, if every good worker could see the results of his or her action like I did that day, what a fire that would light. Well, then on the 3rd day I was there, I got another assignment. At breakfast that morning, the director, Sherry, said, Leanne, you've probably figured this out. I hadn't. Because of Operation Baby Lift, you don't have to wait 3 years. You're going to be assigned one of these 100 babies that are gathered here. Now you can wait and we'll assign one from across the desk in Denver in a few weeks, or you can walk into the next room and choose a son. And I walked into that room of 100 babies. And across the room, standing next to a crib, was a little 9-month-old boy. Pinching the toes of the baby inside should have been a hint. But that little fella took one look at me, and he got down on his hands and knees and he crawled right across the room. Into my arms, my heart, our family. We had a son. This is Mitch on my right knee. Now, it's my absolute conviction God created this child to be our son. No clue why he was conceived in another womb in another land, because I know with all my heart, God made him for us. And if I had a doubt, it would have been erased, because the week I got back home from Vietnam, Carol came racing to my house one day waving a photograph. Leanne, do you remember the first picture you had me take? I said, oh, I'll never forget. I was holding that little girl with a shaved head. She said, well, I have that picture here. And there's only one other person in the background. 3 days before he picked me, just waiting for his mama. But now, getting all these babies to the airport on day 5 is not so easy. Did you even know you can fit 22 in a Volkswagen van? As a matter of fact, apparently there's room for 2 more. So according to my sitting up baby next to that little one dangling from the seat, I don't know. Sometimes people said, Leanne, why didn't you wait for better accommodations? I'm just saying bombs are dropping. We had to get as many babies, especially the Amerasians, out of there as fast as we could. So we went to the airport where there's a C-141 cargo jet, huge empty airplane that tanks could drive into, but not today. Today they had 22, we had just a few toddlers that could sit on the side, but most of them were babies, and they had 22 cardboard boxes all in a row. We put 2 to 3 babies in a cardboard box. But you can see, believing in seatbelt safety, we took a strap from one end of the plane over the 22 boxes and secured it on the other. There were 9 of us to take care of 100 babies. Imagine your worst shift ever. But it was joyful work to take these babies to freedom and to families. Well, we came home and lived happily ever after, and my kids grew up. Oh, I had to put this in there. Once in college, came home from college and they were in the same position as they were. Is that just too cute? I had to put that on there. And my kids did grow up. And then my kids had kids. And my baby girl adopted a baby girl and a baby boy. And then on the 25th anniversary of Operation Baby Lift, I was invited to a reunion and got to stand before 100 young men and women, many of whom I helped to bring out. And also on that 25th anniversary year, President Gerald Ford heard I was going to be in the same town he was going to be in. And he asked if he could meet me. He asked if he could have his picture taken with me. I said, I don't know, I'm kind of busy. And when people see this fantastic adventure, they say, wow, Leanne, that was some adventure. That is the truth. Wow, Leanne, you were so brave. That's not the truth. Things happened to me there that brought me to my knees. I was no hero. I was just this ordinary nurse and mom and wife caught up in this extraordinary adventure. So Mark and I went about our lives merrily raising our 3 children, and I was working at a doctor's office during the day and at the hospital every Friday night. And when Mitch was 18, I knew it was time to tell the story because even he didn't know it. And it took me several years to learn how to write a true personal story. And I wrote the story of Operation Baby Lift called This Must Be My Brother, never guessing the world would care. But indeed they did. Nursing organizations began to ask me speak on lessons I learned from Operation Baby Lift. And I wrote a speech, later a book, and built a career around balancing life in your war zones. And the lessons I learned apply to the war zones and in healthcare today. I mean, they're kind of the same things. That's why the lessons I learned apply. I mean, we have way too much to do and not enough resources to get it all done, and not enough time and not enough support. And we give 100%, and some days we give 110%, but it's like it's never enough. We can't ease all the suffering. So that's why the lessons I learned, I want to share with you. That's why I'll be here till about 6 o'clock tonight. No, actually, in the next 25 minutes or so, I'm going to share with you the lessons I learned, because in order to cope in our war zones, we've got to be strong physically, mentally, and spiritually. And to be able to do that, we need to nurture ourselves in these 3 ways every single day. We can't just wait for weekends to catch up, to sleep in late, eat a big breakfast, or go to church. We need to take time every day, even in 15-minute increments, to nurture our bodies, our minds, and our spirits. But so often, those of us who work in healthcare are so benevolent that we take much better care of people than we do ourselves. As a matter of fact, we treat ourselves in ways that we would never treat a patient or somebody we love. We'd never deny a patient food or drink. How often do we do that to ourselves? We know how to eat, right? How often do we eat over a sink like rats, as Claire said, in a hurry? There's so many things in life we can't control. What we can control is what we put in our mouths. We know we're supposed to drink 6 glasses of water a day. How simple could that be? But how often do we deny ourselves food and drink? Sometimes we forget to exercise. That's hard for me. But isn't it good to know that 45 minutes of brisk walking has the same cardiovascular benefit as jogging? And now we're running out of excuses because they find that it's cumulative. You can do 15 minutes here, 15 minutes here, and it all adds up. How are you going to pay attention to getting even 15 minutes of increments of exercise every day? And sleep, that's the big one I nag about. No, I don't nag. I tell my husband, I don't nag, I advocate. I advocate for sleep because we're becoming a sleep-deprived nation. We're a sleep-deprived world. Science has proven the human body requires 7 to 8 hours of sleep in a 24-hour period. If we're not giving it that, we're depleting our immune systems. We're actually increasing our blood pressures, increasing chances of depression. One study showed that lack of sleep shortens our lifespans. And it's universally accepted now that it increases our fatty deposits. That's when people pay attention. Yeah, shortening lifespans was one thing, but fatty deposits? When people say, I'm going to bed. We set alarms to get up in the morning. I suggest we set alarms to go to bed at night. We need to turn off electricity, turn off technology, and get our bodies the sleep it needs. And we need to take care of our mental selves. The first mental balance tool I advocate is breathing, that slow, deep, easy, rhythmic breathing. I know somebody did a session on yoga yesterday. They teach it in yoga, they teach it in childbirth. It's so simple. We just count it, but taking time every day to stop and breathe in 2, 3, 4, and out 2, 3, 4 for 3 or 4 minutes at a time. And it releases stress and endorphins in our brain. I read in a scientific journal, and recently a chemist, a physiology chemist, said it was true. Endorphins have the same molecular makeup as morphine. We have this on tap. And forget to utilize it. Breathing is your first mental balance tool. And my second mental balance tool is positive thinking. I believe in the power of positive thinking and visualization. I read that book by Dr. Norman Vincent Peale when I was just in my 20s. He said, you get what you expect, you get what you visualize. And it's proven to be true. And then Bernie Siegel is a physician that took it to another level. He realized that people with positive thinking and visualization were getting better when other people weren't. He quit his day job to do scientific research to prove that what you visualize can actually change your body function. One of his first study was a 30-year-old woman with abdominal cancer and given only 6 months to live. She wouldn't accept it. She said every day she was going to visualize that her cancer cells were carrots and her white blood cells were rabbits. And for an hour, every day she visualized rabbits eating carrots in her system. And in 3 months, her tumor was gone. Now, is that a cure for cancer? No. Is it another treatment, another additional thing we can offer? That's why they use it in sports. Half the basketball team shot free throws, the other shot visualized doing it perfectly. And at competition, the results were the same. An American prisoner of war was detained in Vietnam for 6 years. One of his methods for coping was in his mind every day. He played 18 holes of excellent golf. Mercifully, he was rescued, brought home, and began to heal. And on his very first outing, he went to that golf course and shot way under par. People said, how could you do that? He said, oh, I've done it thousands and thousands and thousands of times. Your mind is a computer. You control the input. How can positive thinking and visualization change your health, your happiness, and your workplace? Now, there's a third mental balance tool we sometimes forget to use. This good nurse didn't forget. She was from North Dakota and transferred to Texas. A culture shock, she said. In North Dakota, she heard people say, how you doing? In Texas, she heard them say, como estas? It was a largely Hispanic population. She loved her job in post-op recovery. One day, the OR nurse wheeled the man into her cubicle and gave her a report. Mr. Martinez is a 60-year-old Hispanic male, had abdominal surgery, general anesthesia. His vitals are fine. He's stable, but the man will not wake up. That's why we kept him back there so long. Well, the good nurse, of course, did her assessment, and sure enough, everything was absolutely fine, vitals and all. Mr. Martinez, Mr. Martinez, Mr. Martinez. He wouldn't wake up. She waited 15 minutes, repeated the assessment. Everything was great. Mr. Martinez, Mr. Martinez. Finally, her coworker said, you're driving us nuts. Shouting his name. Why don't you wake him in his native language? So they told her what to say. She repeated it over and over in her mind until she got to the bedside. She put her hands on the man's shoulders and shouted, Bésame, Mr. Martinez, bésame. Well, don't know what surprised her the most. Mr. Martinez sitting straight up and quite alert, or the hysterical laughter of her coworkers. She said, what did you have me say to him? They gave her the translation. It was, kiss me, Mr. Martinez, kiss me. Laughter, that's our third mental balance tool. And I think in healthcare, we forget to laugh. We would never laugh at anyone. But to a degree, we have to laugh at circumstances, laugh at ourselves. Laughter is the best medicine. That's why Professor Frank is going to give a presentation on it later today, showing that it really is. There's an association of therapeutic humor that does research to prove laughter boosts your T cells production. It lowers your blood pressure. It makes you healthier. Kids know that. They laugh 400 times a day. Do you know how many times adults laugh? Somebody said 11. Somebody told me 4. And you know people who can't meet that quota, don't you? So yeah, I want you to think about it and make a list. What makes you laugh? Write it down. Movies, cartoonists, the comedians. What makes you laugh and laugh and laugh until, as my girlfriend said, till tears run down your pant leg. Think about what makes you laugh and incorporate laughter into your life every single day, because it is the best medicine. And are there people that make you laugh? And are there other people that just seem to suck that joy right out of you? Unless you're married to them, try not to spend so much time with them. And instead, surround yourself with people that bring laughter into your life. And I just did a great plug for you, Professor, and you missed it. The importance of laughter. It is the best medicine. And I have a fourth and final mental balance tool. Besides the slow, deep, easy breathing, besides the positive thinking and visualization, besides the laughter, the fourth is forgiveness. Because we waste a lot of our life, a lot of our health, when we fail to forgive. So starting today, we forgive. First of all, ourselves, for any past mistakes or regretted decisions. Starting this morning, we forgive ourselves. Because friends, that's who we were then based on what we knew then. It's not who we've chosen to be today. So starting today, we forgive ourselves. And starting today, we forgive somebody else. No matter how horrific the offense, and I know some of them are truly horrific. But what took me too long to learn is if you do not forgive someone, it doesn't hurt them. It only hurts us. So why would we allow someone who caused us so much pain? Why would we give them the power to continue to hurt us by giving us sleepless nights and upset stomachs and headaches and high blood pressure? We need to forgive them whether they deserve it or not. We do. Bernie Siegel shared a story. I've been very blessed. I wrote Chicken Soup for the Nurse's Soul. Some of you might know that series. And actually 3 of those books and 13 other chicken soup books. And the 2 stories tell the messages, don't they? And Bernie Siegel shared a story of a woman who was, a man who was working in this long-term care facility. And every day it seemed it was his job to lift Miss Sally from the bed to the chair because Miss Sally hadn't walked in 6 years. One day as he was lifting her, she looked at him and said, "You look like a man of faith. Does God really forgive everything?" He said, "Yes, ma'am, he does." Later, he was lifting her again and she repeated, "Are you sure about that? God always forgives?" "Yes, ma'am, I'm sure." Before he left that night, she looked at him a 3rd time and said, "Can you promise me that God always forgives everything?" "Yes, ma'am, I promise." "Well, when I was just a teenager, I stole all the family silver and I sold it so I'd have enough money to get married, and I've never told a single soul to this very day. Can you still forgive me this late?" "Yes, ma'am. Just ask." Well, he went on home, and next night he went into work and was immediately called into his supervisor's office, who said, "What did you tell Miss Sally last night?" She simply asked if God forgave. I assured her he always does. Why? "Because at 3 o'clock this morning, Miss Sally came walking down the hall. put her teeth and her Bible on the nurse's desk, said, "We won't be doing these anymore." Walked back to her room, laid down, and died. And almost every time I tell that story, someone in my audience tells me one just like it, because friends, forgiveness is free. So starting today, besides yourself, who are you going to forgive? Now, it's that third part of our lives we have to keep in balance, and that is our spiritual selves. Anytime I give a presentation to, no matter if it's to 30 people or 6,000, people come up to me and whisper two things, and I know what they're going to say. Thanks for talking about forgiveness, and thanks for talking about spirituality. The number 2 Googled word the first 2 months of the pandemic was prayer. Number 1 was hand washing. I believe that we cannot do what we do and sustain ourselves without that spiritual balance. That's why I advocate that everybody take 15 minutes a day for prayer or meditation or reflection. And I know what you're thinking now. Yeah, right. Where am I supposed to come up with 15 minutes, Leah? You already told me now I have to stop and breathe several times a day, and I have to start taking these short walks several times a day, and I have to go to bed earlier. So where am I supposed to come up with another 15 minutes? And it was hard for me, but I knew it was lacking. So I started to set my alarm 15 minutes earlier. And you'd have thought I was setting it for 3 a.m. I moaned and groaned, but soon learned that time is an investment. Even in my hotel room today, when I don't start my day that way, I'm less productive, I'm less happy, I'm less focused, I'm not the best me. Do you remember maybe 10 or 15 years ago, we talked a lot about holistic care? And I'm sad that I don't hear about that anymore. Back in my day, when we charted for a patient, we charted on our objectives, right? How to care for their minds, their bodies, and their spirits. And we can't give from an empty well. And somebody told me that, I'm trying to get that word back again. Somebody told me this is coming back. We're looking at holistic care again. It's not just alternative medicine, it's caring for people, mind, body, and spirit. So we can't give from an empty well. And that's why I created Self-Care for Healthcare, because when I created that speech and then I started giving it and I wrote Balancing Life in Your War Zones, hospitals started hiring me to do recruitment events. And to this day, when I give a similar presentation to this, 30% of the people sign up. They want to work someplace that cares for them, right? And then hospitals wanted me to do half-day workshops. Sure. Then we now do full-day workshops. Okay. Then they started buying the Balancing Life book for everybody in the company, or everybody, all the nurses in the hospital, and they wanted more. So that's when I worked with experts on how adults learn and healthcare leaders throughout the country to understand what program we can create that will actually change thinking, that will change behavior, that can make people healthier and happier. And wouldn't you agree that a nurse and a caregiver that's not exhausted physically, mentally, and spiritually is going to get much safer patient care? So the Self-Care for Healthcare, the smart people, the people that taught me how adults learn, said that first they have to see a video of me every month. And I'm all about stories, as you can tell. And so everybody, and it's a 12-month program because it takes 21 days to change a habit. So we spend a month on each of these things, and every month they get a video of me introducing that month's lesson. And they get Self-Care for Healthcare book, 12 chapters in the book, one for every month of the year. Every chapter begins with a story. And then a lesson, one on breathing and all these things I just spoke to you about. And then at the end of every chapter is questions that they answer in longhand. Because the smart people said they have to see you in a video, they have to read something, they have to write an answer or type it. That's what makes it stick. And then they need some incentive to stay with it every week, so they get a Monday morning motivation from me. And then I put it all on an app. I listen to all the reasons people say, I don't have time for this. So now I put it on an app and it's at their fingertips. And I say, if you don't have time to read it, I read it to you on the app. And then I worked with ANCC and got 26 contact hours. And Colorado National Association said that's the most contact hours they've ever. But wait, there's more. Finally, I did a research project on it. And now it's evidence-based, and the results were statistically significant. Doesn't it make sense, though, that when people care for themselves, mind, body, and spirit, they're going to deliver better, safer patient care? And I wanted to present here today because I know you, and I've met some of you, and you are so busy caring for everybody else. I hope that you will implement these tools to care for you. And then you can share them with your staff and the people that you lead, but you can't give from an empty well either. So I ask you to take a step back and take a look at your life. Do the mind, body, and spirit need a little help? And if so, then I want you to ask for what you need. Lovingly, not painfully, but ask. First of all, of yourself. Give yourself permission to care for you. Maybe you need to ask a family member, a coworker, a church community. What do you need to nurture your body, your mind, and your spirit? And then you should be more like a toddler. Anybody have a toddler? Did you notice a toddler asks for what they need until they get it? I want juice, I want juice, I want juice, I want juice, till somebody gets a kid juice. We need to ask for our juice. To care for yourself, mind, body, and spirit. And when you do this, my friends, you will be happier and healthier. And then you can give this to the people that you care for. And when you are strong physically, mentally, and spiritually, you will continue to do the great work that you're doing and continue to make such a tremendous difference in the world. Thank you. Oh, I'm supposed to ask if there's any questions. Any questions?
Somebody has a question.
Yes.
When will we be able to purchase your book?
The Self-Care of a Healthcare book comes with the program, but we do small groups as well as on my website, selfcareforhealthcare.com. The book doesn't come individually because I work with those smart people on how adults learn. It comes with the videos and the app and everything is a package.
Okay, thank you.
Certainly.
So you said that you don't exercise a lot.
Yes, I do. I just don't like it so much. It's a hard discipline for me. It's a really hard discipline for me.
Why is it?
Well, I don't like gyms and it's very boring. I like to be outdoors.
Okay.
So I try to walk every day, even if it's for 30 minutes at the end of the day, but I'm not as disciplined about it. I hike in the mountains every Wednesday and that's great. And I do my workout on the bench every morning and I don't like that either, but I do it.
But you know what, I have something for you.
Okay.
You and your husband, right? Put on your favorite music and do chair dancing.
Oh, I love that. You should see me rock and roll when I clean the house. Totally. Bob Seger, old time rock and roll. I'm there, girl. Thank you.
Yeah.
Any other questions or anything? I must be very thorough. Yes.
It's not a question. I just want to thank you for presenting this topic because I think it's so important for us to be reminded that we need to take care of ourselves and we don't do enough of that.
Thank you. It's my mission in life. And it is my hope that I'm so blessed that my chicken soup books have reached 3 million nurses. And it is my absolutely mission. And I believe a ministry in my life to get this program out to help the masses. So many people say, I really want to take care of myself. I just don't even know where to start. And with all humility, I say, you know, this is it. If you simply do these things, they work. Yes.
Not a question. I just wanted to say thank you so much for sharing this. You seem a brave person, but I think you're one of the right things.
Oh, you just blessed me beyond measure. Thank you, dear.
And I know you keep saying that. I haven't had that.
Thank you. You bless me. With that, I'm going to leave. That's okay.
Miss Leanne, there is a question online. Please say again. There is like a question online via Zoom. So yeah.
I'm sorry.
This is a question via Zoom. That is one.
Oh, the question via Zoom.
Yes.
Where can I get,
the
oh, the question via Zoom was where can I get the self-care healthcare book? And it's on my website, selfcareforhealthcare.com. Thank you.
Thank you.
Thank you, Leanne. Our next speaker today is going to be Ms. Janelle Ali-Dinar from the U.S. And I'm going to pass the stage to her to deliver her speech on public health, health equity and disparities, innovation programs, research, evidence-based best practices, healthcare retention, resiliency, in a post-COVID workforce shortages, clinical gaps, and global programs, etc. Please welcome this student.
How do I do? Yeah.
This one.
Forward it.
This one. Yeah. 1 second.
Okay.
Yeah, please try.
Okay. Perfect. Thank you. Well, great day to all of you who are present with us and those who are on Zoom. And Barbara, that was a mouthful. I really tried to encapsulate everything plus the kitchen sink, or in terms of a woman, everything but the kitchen sink, as we know how our purses can be. I specialize in a lot of different things: rural health, indigenous health, tribal health, and a lot of having grown up into healthcare as a CEO and as a vice president of strategic planning. I get the honored point. So as I zoomed in on what I was going to talk about, I decided in a post-COVID world, we don't have enough about wholeness, health, and healing. So I get the opportunity to be a vessel of Leanne's light and love and all that she shared before. And myself with Leanne and a team of team members virtually across the United States, we are healing one mind, one body, one spirit at a time and causing this great ripple effect. So indeed, I'm going to do all the touch points that you mentioned, but as I really I honed in on this. Boiled it all down to self-care for healthcare, increasing capacity of care, compassion, revenue growth, and future healthcare sustainability. Now, I first was addressing it, is it a moral need? And across globally, there would be a lot of initiatives that would say yes or no. It comes down to, in some places, very politically active and motivated. It would be, is healthcare a right, or is it something that is equitably sustainable, or do you get to choose it? So now there's a lot of conversations that can happen in that. So I'm going to reel it back in and talk about self-care for healthcare and healing. So first of all, I want to acknowledge the immense work that you've all done. You all have sacred stories, some of which will never be told, some of which that will be honored, some of which will probably be revealed sometime in the near future. But whatever those sacred stories are internally, whether they were things that you lived through and COVID, being that only member present when someone was passing or suffering with COVID, or working with family members in the aftermath, wearing many hats, working on many floors. That job description was any and all assignments not in your job description that you were living day in and day out, breathing in, breathing out. And you were there for long beyond your 8 hours or 10 hours or 12 hours. You were putting in your own residency hours. And then you went home and you had to distance yourselves from your families. And you became your own vessels of survivability. Now, who are you as vessels of thrivability? So I really want to honor each of you, who you are in this universe, because you have been placed at a point of time by the Creator to be an answer for part of what your role is in purpose in this universe. And some days we get up in the morning, if we've only had a couple of hours of sleep or no hours of sleep, or things tugging at our heartstrings, or people tugging at our bedside, we don't often get a chance to champion and remember that we are light, love, healing, and we have so much to express and do. But do we celebrate it and elevate it and recognize it?
Probably not. And especially again, in a post-COVID world, it's so important to recognize your truth, your purpose, your honored story, and who you are as a gift to this universe. In fact, most people would say, even if we feel like we have a small role, there are no small actors, there are no small roles. We all play, unbeknownst to us, giant roles in this universe. So I want to thank you, Zoom and here, for all your good and gracious work. So before I talk about self-care for healthcare and some of the things that kind of ride as pieces and parts of what Leanne had mentioned, it's important for us to step back because sometimes we've worked in our own prisms and we got tired of watching all of that news that was on about the ups and downs of what country and what was happening real time. And some of us never even saw the news. It was happening to us. We were at the front lines, but we weren't knowing what was really truly being told in the numbers. And there's probably still so much more to find out about the numbers because we need more time to recognize through evidence-based research and practice and surveys to really get our arms and heads and hearts around all of those numbers. But if we go by the World Health Organization, as of November 2022, we see that 628,694,934 cases of confirmed COVID. That's just one case. There have been many of them that have had COVID more than once. And this also does not take into context long COVID. And there have been, of course, 6,576,800 perished souls who have been reported as deaths through the WHO. Now, there's a lot, because I have an academic research background, that there's a lot of text. And you think about your own stories that would resonate more as emojis or as other experiences. But hopefully there are gems that you can take back and you can really feel reinforced. I think the telltale on this one is the 2022 Lancet Journal eClinical research that shows that we will have a shortage. And many of you yesterday, today, and tomorrow will touch on the healthcare shortages across the world. 18 million healthcare workers by 2030. That will cost us $47 trillion on the globe. And those projections were made before the pandemic. So they want to say that if you extrapolate those numbers, that you would at least have to double that 47 trillion. Now, think about who we are as countries across the world, how that far goes beyond any GMP that's out there. And finally, we know that obviously the bottom word is that all of this is unsustainable. So according to the World Health Organizations, it's not just those who work in healthcare, it's those fringe ones. If you ask somebody 2 years before COVID and said, what's my role in public health? What's public health? You would get so many different answers. Same way with population health. It's so personal, but no one ever saw public health as instrumental, as that integral role that tied it all together. But today we do know that public health people are also our heroes. But if we take a look at the ones who measure that in public health, they have noted that the self-care stress in the next 5 years, according to 6 international surveys, will cost us over $100 trillion. So self-care, much like public health, much like population health, it has just this moving like mercury. You can't really catch it. It has a moving definition. So self-care means it is the world is the best of you instead of what is left of you. Self-care means giving the world the best of you instead of what is left of you. You really got to chew on that for a little while. And you've probably already been doing that, but never really resonated it down, boiled it down into one really captured thought. So the pandemic COVID stress, if you take a look at the 2020 to 2022 Nursing Standard National Medication Association survey, 8 out of 10 nurses reported that their mental health had been negatively impacted by COVID. 6 out of 10 nurses reported a negative impact on their physical health as well. But it was only after they were asked. They weren't writing it down. They weren't sharing it. And some of these numbers are probably even larger because on any given day, burnout, resiliency, onboarding, offboarding, they're all changing. This is just as near and close as we can get it. 9 out of 10 physicians reported that their mental health is negatively impacted. and 10 out of 10 reported negativity out of their physical health. But again, it's very difficult for nurses and physicians to share those vulnerabilities because somehow I'm coming to you and you're going to say you're fragile and vulnerable. How does that make me feel as a patient? But that's what self-care for healthcare is also trying to do, much like telehealth, much like a lot of different models, is to say we are fragile as a human race. We are also sustainable, thrivable, and so smart collectively that our vulnerabilities are also strengths. We just need to get outside ourselves and what insurance and carriers might rate us or say about us because we exposed that we have a need. But it's there. And sometimes that transcends when you don't say it out loud and you keep it inside. It's depression, it's repression, it's aggression, and it can also be suicide. So self-care for healthcare creates these healthy opportunities to put those disparities away and to really start talking about it openly, because we're only going to solve it one person at a time, but collectively the power is exorbitant. So self-care, again, much like some of the things we'd already talked about, it has some moving definitions, but according to the American Nursing Association's Codes of Ethic and Medical Association, it is really about A through D. It's promoting one's health and safety, maintaining competency, preserving the wholeness of one's character and integrity, and continuing personal professional growth. It is what transcends and keeps our healthcare systems and our patients safe, healthy, and it promotes well-being. So for any of you who are studying health, wellness, and promotion, self-care for healthcare is a great future for you to emulate as well. And it's a natural part of caregiving. Again, we spread it, we share it, we spread it like peanut butter and jelly, but we never do it for ourselves. So today's discussion, now since we passed through a few of the slides, it's really to talk about what are those healthcare environments, to reduce those disparities and stresses in a post-COVID world. It's to optimize self-care as self and what I can contribute to the team. Now, many of you are either JCO or you have patient-centered medical home models. So again, you know, put the patient in the center. You ask him or her, what are your role? What's your role? What's your goals? What can we do to get you back to the health that is the well-being that helps you feel and be your best? But do we ever round with ourselves? Do we ever say, this is what I need to do my own best at self-care? It's kind of like asking for your juice without saying it out loud. We don't often do that, but self-care for healthcare is an opportunity to do that. And then, of course, to reduce burnout, to increase resiliency, and to build team engagement. And of course, the one thing we'd already talked about, we do not have a sustainable workforce. So we have to think about who do we have today that we need to keep? Who do we need to help elevate and reinforce so that those universities and those communities are filled with those next healthcare workers? It's part of our role as paying back, paying for, and paying forward. So reinforcing recruitment and retention and building the passion. So self-care for healthcare is almost in every state in the United States. In some states we're there more than once, and this could be the implementation of the entire program of self-care for healthcare. It could be many of the speeches and presentations and options that Leanne speaks about. But these are just some of our heavy hitters, if you will, our joint celebrative partners. So anyone from MD Anderson to Cleveland Clinic to Novant Health to New York Presbyterian, and a lot of VA systems, which is really important with everything that's happening in veterans care. So we believe that self-care for healthcare, because we've demonstrated it through evidence-based medicine, that we've demonstrated it through, and we had this long before we ever knew it would be implemented, but for many healthcare systems, they see, oh my goodness, I don't have to reinvent the wheel. This fits within my pursuit of magnet. This fits in between the leapfrog. This fits within a lot of the excellence programs I'm doing. So I kind of get a twofer or trifecta deal out of it. So just know that your work is being duplicated across the board if you are one of those healthcare systems. It's a compass for the future. It's the solution for global healthcare and well-being, and it empowers teams to be their most resilient. I might also say one of the most beautiful things about self-care for healthcare is that it's something that you can do around the kitchen table. You know, so we don't get a chance to really talk around the kitchen table. We don't get enough to do around community gatherings, but you can take this outside of healthcare. You can take this into the communities. You can take this into the churches, the mosques, the synagogues. You can take it globally. And that's what's so beautiful about it. So one of our best quotes of supporters is from the Cleveland Clinic. It is, "For such a time as now, these difficult days, nurses," and it just happened to be that Leanne is a nurse. And so a lot of what we do is with nurses. Nurses need to hear Leanne's extraordinary power and results of self-care for healthcare, to live the words of encouragement and of faith, and to embody the inspiration and the wisdom. I might say that beyond nurses, the next who are asking for it are physicians. And again, much to what we say, our physicians are our grand healers, but they are owning up and asking, how can we implement this? And how can we share this with our other team members that we count on? So our priorities within self-care for healthcare are to revitalize your mental, your physical, and your spiritual well-being. It is that mental health is one of the first and most sustainable pieces and parts of who we are. And so if we can treat you mentally and be able to help you feel transformative, that will also help with the messaging. Again, going back to the American Nurses Association, there's an urgent need to improve nurses' health, particularly in the areas of physical activity, nutrition, rest, safety, and quality life. Self-care practices are especially crucial for those post-COVID-19 pandemic people that have been exacerbated by the importance. And again, we were doing this long before COVID, but it just is now the calls and the need are on the increase. So self-care for healthcare and any of your patient quality initiatives, your patient safety initiatives, again, if you're JCO or patient-centered medical home, or you're pursuing an IS 9000 series, again, it wraps around within that. But some of the top 5 that it really focuses in on are providing those adequate staffing support mechanisms to prevent staff burnout, encouraging and facilitating clear and frequent communication, working across, not silos. It's rotating high stress assignments and those mental health breaks. It's implementing more flexible scheduling. For those of you who were on the first line, open line all the time, you never got to do what many workforce industries, and they were remote. They got a chance to be Zoom experts, but so many of you didn't get that chance. But telehealth is obviously one of them, but flexible scheduling and integrating more certification and wellness programs is also part of this and important in what they've identified. And then it's easily accessible through those mental health resources. We talked about, this, is it a moral obligation or responsibility? And if any of you are aware of the social determinants of health, those 21 considerations that are out there that are moving across the globe, do I have food security? Do I have health security? Do I have, am I domestic violence? Do I have a home? Any of those things that we often, because of pride, that we would never want to own up to, they're also asked within this. And that helps fill with the self-care for healthcare, those gaps in health literacy, and really transcend that value of appreciation. Also, it's okay. We're taught about that we should be we, and we should be we because we're all in it together. But if I can't serve, the creator and then serve me, I'm an empty vessel and I can't do anything. So in that sense, you do have to see yourself as a gem, as a diamond in the rough, diamond in refinement process. And you need to recognize that it's okay to say, I need me. And to be my best me is to say I can be self-promoting, and I can have that I need to be self-educated, I need to be self-empowered, I need to be self-encouraged, I need to be self-reliant, and still have a we. But that's my asking for my juice and expecting the best of it. All right, so just very briefly, American Nurses Association risk appraisal. So again, for many of you that are trying to implement any type of model, go back to those appraisers, those people that are doing the risk mitigation in your hospitals. They're the ones who know how much it's costing your hospital and your healthcare system for onboarding, for burnout, for risk management, for quality care, and any mistakes that take place. So again, a great opportunity. We also work with the Watson's Philosophy of Science of Caring. Many of you have heard of that, and Leanne is a very good friend of that. So if you have other programs that you're implementing, these are all good sisters to one another. So again, from a global standpoint, it's forgiving yourself. It's being able to have those boundaries to say no. It's asking yourself for what you need, putting yourself first, and being okay with being alone. We get so asked by so much to serve on another board, and we want to give ourselves, and yeah, we've all got resumes, we still want to build, but sometimes we need to say no. And we need to choose where we're our best selves, where are we our best experts, and lend those helping hands. So also it is taking a look at those healthy habits. And so these are some of the challenges also that self-care for healthcare has kind of percolated to the top in some of healthy discussions. Is you see that people are more open to talk about what maybe during COVID their drug usage, or their vaping, or their smoking, or through some of the other things, like we talked about storytelling. Storytelling is now a leadership component. It's actually even taught as part of curriculum and a major in some universities. So the art of storytelling is so empowered. Massages, other things that you do. I mean, many of you have your nails done and you have these beautiful little cuticle stories that are told, the things that make you feel good about you. And then, of course, exercising. All right. So one of the other things that Self-Care for Healthcare has been able to do is that, as many of you within your workplaces, in and outside of the size of healthcare, is looking at if there's insurance costs, or you want to put together some wellness engagement opportunities or some empowerment opportunities. You take a look at, what are some of the prizes? What are some of the fun things that you can do? And rather than things to be in silos, you want to find ways where there's some comparisons and contrasts, and you can really elevate the results. So we find that Self-Care for Healthcare is working within a lot of programs within their insurance, so that they can provide the program, helps drive down their costs of care. It helps increase retention and engagement. We do know that it works within the Lyme app. It works within Virgin Pulse very nicely. So something to think about, as it just not being a nurse or a physician. It's every person in direct patient care, anyone who works in the organization, and as a health well-being program, you can use it. And then again, much like the social determinants of health, all of the quadrants and the 360 of the 8 dimensions of wellness that Self-Care for Healthcare speaks to. Then again, just a little bit about burnout, because some people are still asking about what is burnout. And, burnout, again, like population health, it's the things that we're not ready to own up. It could be somebody else's definition, but not ours. But burnout is really what has been measured over a 6-month period. And it is measured by insomnia, long-term stress, emotional instability, alcohol or substance abuse. And if you've had a diagnosis, you might have been pre-diabetic, then now you're full-blown diabetic, or you might have had signs of heart disease, but now you're full-blown, or some other type of chronic disease. And then the response then is all of us as an organization, from the C-suite or from the leadership suite down to those who support us in nutrition, in maintenance, all of those doors could not be open one day without them. But to have those healthy conversations about what can we do to promote and build one another. And then, of course, the universal mind, body, spirit injury that Self-Care for Healthcare addresses on the moral injury event scale, the appraisal scale, the system scale. So if any of you are kind of relatable with some of those more engineered words, those acronyms would resonate Self-Care for Healthcare as well. The burnout of mind, body, soul, and the obesity. We find that obesity, out of nearly 5,000 nurses that were just asked in 2022, the response rate being 15.5%, that they noticed that their BMI is 27.2% on average. That's almost 54% overweight or obese. And then 93% of nurses acknowledging overweight, obesity, simply not just because of the cortisol levels that are higher, and often that's more in those who work nighttime that don't have the circadian rhythms, have gotten their sleep cycles off, but just this is post-pandemic. This is everybody's cortisol's on the rise. We're all, having to be much more cognizant, mindful of choices that we make in food and in sleep and all those. And again, so those are some of the tee-ups that we teach for self-care for healthcare. And then there's your burnout checklist. Some of us can find ourselves answering to many of those. Hopefully not all 16, but for those of you on Zoom who can see that, hopefully there's some treasures in there that you can recognize in yourselves and others, so that when we have those conversations with one another, we can be more aware of what one another's needs are. And again, this burnout is based more on 6 months and 12 months. And again, then taking a look at why self-care for healthcare is such an answer is that we look at the turnover costs are 16 billion or 16 trillion globally. Again, look at all the GMPs added across the globe. If the G Summit would have discussed some of that, that would have been some real hair-raising things. May not be able to do a lot about peace, but we could maybe have done a lot about self-care. And then how does that affect your individual workflow and productivity? Again, answering those carriers that have some of those unhealthy numbers, but can help because a lot of times your C-suite or your leadership suite will say, don't have the money for those programs. Well, it's not that you don't have the money for the programs. You can't afford not to have these programs implemented. And so there's some of your math for you. And then this is how you can ease your own burnout. Leanne spoke to many of those things. Hopefully we could find ourselves in all 12 of that. You may not want to find yourself in all 16 of the previous, but if you could find yourself in all 12 of these would be some healthy habits. And to the young woman that's sitting here in this up at the front, I love what's on the back of your jacket. It is rule your health. And, so those are some of the things that you do to rule your health. And then again, Leanne had mentioned this, but in self-care for healthcare, we have the program curriculum. And these are the things that we know have worked nationally, but they can work internationally also. The Monday morning motivations, surveys. Survey fatigue is real, so we want to be very cognizant of that. But we do a pre, a middle, and a post so that you can see how results are. And then meetings with Leanne, and then we can customize those according to how large or where you're located. Internal respites and themes, the mobile app. It used to be, if you didn't have a website, you weren't really alive. Now it's if you don't have a mobile app, you're not really alive. So this mobile app has all the bells and whistles of the program within it. Journaling, so important. We got to take it from here and in here and in here and put it on paper. It's part of that living legacy. And then mapping, correlations. We have the 26 contact hours, which are so important. If you're going to do the work, you might as well be rewarded on another level. And then the research, the evidence base that we spoke of. Again, betting self-care, which is becoming very much, it doesn't resonate any longer as an acronym. It's full-blown self-care is becoming a very widely used inside and outside of healthcare. So again, like patient-centered medical home models, we like to believe that self-care is people-centered, approach-centered, and well-being centered. And then these are the things you get to take with you as living legacies. You get to increase morale, increase engagement, increase resiliency and joy, recruitment and retention, decrease the burnout, because again, we all know can't pour from an empty vessel, decrease those sick days, hardwire your wellness incentives, again, in your programs, transcend the workplace, as I noted before, into your families, into your communities. And so these are some of the patient program outcomes: better patient care, better quality of care, improve patient outcomes. And again, for all those other surveys that you're taking, all those other programs you're pursuing, that helps it. Your culture building, your triple and quadruple aims, your recruitment and retention, and your increased reimbursements. And then again, works very well within the magnet, and of course the pathways to excellence that's more with the magnet. And this also aligns with the wellness programs, health coaching. Maybe many of you have health or executive coaching, leadership mentoring, and professional development, your HR recruiting and retention campaigns, and then the onboarding of your new employees, new hires. You find that anyone who's been in the generations for 20 or 30 years, we were used to not being offered these options. We were used to, you arrive, you take care of yourself, you don't ask. And that was just the way the generations were. That's where our parents raised us, our grandparents and families. But now the younger generations are asking because they've been hardwired in a different world of technology and the way everything is immediate, that they do ask, what's in it for me? What am I getting? What are you investing in me? And that's okay. And that's good. But I'm glad to say that we can deliver on that. So it's important to, with self-care for healthcare, introduce it to that next new generation because it is a huge recruitment tool. And then as we talked about some of those, again, those were some of those more post and pre and post evaluations of things. We save our clients on average over $1 million by doing the right thing. And these are some of our results. A decrease by 16% in sick days, 21% increase in engagement, a 13% increase in nurse retention. See it in the turnover. 15% increase of participants agreeing to live their priorities. So really across the board, not just within your job description, but really in taking it home. And then employee engagement increases from the 50th to the 69th percentile. So those are some impressive gains. And again, these are just kind of how our surveys are, the questions that we ask, and some of the merits that we've been able to see as a result. And again, you know, these are things that are important that your hospital organizations would be asking if they were doing Gallup Strengths Finders even. So, I mean, they're not out of the box. These are things that are day-to-day, work to work. And then a year 2, because we offer 1 year, 2 year. We have at least one that was 3rd year. And then we have other ways of reinforcing it after that. But again, some hugely impressive results even from year 1 to year 2, especially that leadership cares about my wellness and life balance. So from your CEO, he or she caring down to where you are, 82% increase. That's pretty incredible. And then again, for those of you, those opportunities where you may have health coaches, it reinforces servant leadership, reduces the fatigue, or as we call being drained out, reducing those feelings of being overwhelmed. It builds the resiliency, or as we call in self-care for healthcare, the bounce back. And then it builds engagement, morale, and it helps you celebrate your cohesiveness. And we see the increased retention, especially 1 to 3 year nurses bedside and those adhering to the readiness from 8 to 12-hour shifts. And it also has impacted those that are seeking union. Many of those in the United States are unionized. So it's an important conversation within those as well. And then these are just some other programs that comes with our visits. We really get to know you before, during. We have those engagement leader, the surveys, the video invitations, the presentations, the mobile app, the guidebooks. We arrive, we tour with you. We'll be wherever you have us to be. And then you have a certificate of completion. And then this is just some, you know, it depends again on your size and whatnot and what the program comes with. Many of you had asked about, can I purchase the book? And Leanne does have a lot of her books. Leanne's written 13 New York Times bestselling author books, and she is a nurse. And so she does know what she's doing, but many of those are available on the website, but the Self-Care for Healthcare is part of the program. And then of course, then with the app and then a discount if you do the program a 2nd year. And then those are just some happy faces who are living the Self-Care for Healthcare truths and some of Leanne's books. So I thank you for your time and your attention and for you being part of the universal truths and the gifts that you come bearing to the universe. And hopefully you have seen some of this as reinforcement to your own liberation of self-care and healing. And hopefully maybe some of you find that, maybe there's something to this program. Maybe there's something that I would really like to apply. And Leanne and I would love to have those conversations with you. And we're all linked in together now through all the powerful work that Amal has done. And so I just thank you all and thank you for all that you do. Thank you.
Thank you, Jeanette.
I'm happy to entertain any questions. Perhaps I did everything that was in the kitchen sink and in the purse, and I've answered everything. Yes.
How are you getting to the government agencies? I am just so on government agencies because they have the majority of the money.
Yeah.
In the United States of America, the federal government is the largest contractor, period. What are you doing to, as of course, a women business enterprise or being a women-owned small businesses, to get a lot of those federal dollars so that you can increase this great work? Because the work is great. We just need to influence Congress that
Yes.
they're not the experts on this.
Right.
That the people who are in the trenches are the experts. How are you talking to government officials? Even with, I would even like to see if I could get a congressional hearing for you guys, if you would like.
We would love that. That's such a powerful question. And I don't know if you had completed the question or not, but it's a powerfully profound question. I do serve on a lot of boards at the federal level, and I do see ourselves as our voice box. We're going to have to keep asking for our own juice in funding. And so a congressional hearing would be wonderful to be able to speak to the group, but I have presented to CMS. I have presented to the NIH. I have presented to the CMS Innovation, because again, for many of you globally, you may not know that in the United States, it needs to be funded, and ACOs and integrated models of care are very important. And it's the loudest voice that gets the squeakiest wheel, that gets the most oil, and the most oil changes. So I have presented to many of those federal legislation bodies that receive monies for research and programs. We're also within the VA, and so we need to continue to be in front of the Veterans Administration to be able to say this is so important. We have all of our minority and tribal organizations that we are constantly in front of and looking for opportunities because we are their constituents. And they're only as good in their vote as what we are able to present in demonstrating what they've critically been able to help us with. But it's going to take, it takes under what Leanne said, it takes over 20 days to form a habit. It takes 7 times to hear something and it really be, hardwired in our brains. So to present, when you have so many people presenting and saying, I need money for this, I need money for this, it takes at least 4 presentations to each of these groups to say, on this date, we said this, we said we were coming back for this, and to be persistent. And the power of persistence really is what pays for this. So yes, we've been pursuing this, but we know our voice is not alone going to make the difference. But if we had the group in front of us versus just hodgepodge, it would probably help us even more. We do find that in the Innovation Center, they are wanting to give more monies to things that are stress related, work safety. We know within the physicians for the reimbursements that it's impacting. So we're making some headways on that. But again, until it becomes part of self-care, the governmental language, we still have a lot to do, but we're trying to do that. So thank you for recognizing that. And we'd be appreciated of any opportunity. Thank you. It's hard to give short answers when there's such a long need, so thank you.
Thank you so much for being here. For those who I haven't met, my name is Madeline. Towards the middle of the presentation, you mentioned, I think, 5 different aspects of retention and recruitment that you would recommend to hospitals in order to keep their nurses and reduce burnout. And so I'm just curious from your perspective, you've been able to implement this in 21 different hospitals, which is absolutely phenomenal, very important work. What do you see as the biggest barrier to achieving those 5 recommendations that you had earlier in the presentation from an administrative perspective?
Well, we believe, and great question. Thank you for that, Mel. Those in the C-suite, be it CEOs, COOs, chief nursing officers, chief quality officers, they have to walk the walk. They have to believe in it themselves first. They need to be able to say, CEOs aren't just CEOs, they're chief example officers. So anyone who's in a C-suite, who's in the position of power in terms of making those decisions, especially about budgets, they need to be the empowerers. They need to be the emulators. They need to be the ones who walk that. And so we're very fortunate that when we, prior to us even launching, Leanne and I make it's not about a sale. It's saying you need to be willing to live it, emulate it, share it, grow it. And because all eyes are on you. And if they know that they are not being supported by those that make those decisions, it makes it really difficult for them in their 1 and 2 year, or I'm just, how many times do we hear a person say, I'm just a, you're never just a, but you may not have the credentials behind your name or the title in front of it, but you still make a powerful difference. But who do we look to? It's not just who do we report to as a supervisor, it's that we look at that C-suite, the CEOs. So the point being is that before we launch, we make them make that commitment and we present to them first so that there are no surprises and they know what they're signing themselves up for. And we find less pushback because they want to, and especially in a post-COVID world, they want to emulate that they are change agents. And that's the best, most profound, powerful way to do it is just to do it. It's no simpler way than Nike, just do it. And they do it. But that's a great question.
2 questions.
Sure.
First one is the fact that during this year, I was part of a great team and they were putting a wellness roadmap, not only for caregivers, but across the entire organization. And the initiatives were around behavioral, psychological counseling. Very anonymous, you don't need to worry about it. Confidentiality is there and just gush it out. Now those subscriptions or the interaction on that platform was very minimal. And then when we deep dived into it, we realized fear remains there. Individuals were very adamant not to speak up in a way of what truly is their pain points, because they always feel that everything is never anonymous and never confidential. That's one thing that we've realized is a true issue when it comes to well-being in corporations. The other aspect of it is that many of them realize that it's so awesome that you're putting all those nice, they call it lovely initiatives. I don't know why they refer to it as lovely initiative, assuming that we're not truly profoundly trying to resolve things for them. And when I say them, meaning anybody working with the executives in a way or another, or in any aspect or dimension, has to look at the entire population of the workforce. And the reason being is that how would I go back to my home and have to deal with a screaming kid that I don't have enough means to offer a nanny or a babysitter? And this whole virtual schooling that happens to be a really true issue for a lot of moms in the workforce. And then others that have to suffer from domestic abuse, as you correctly mentioned, but in a silent manner, and it comes in varying levels. And many of them are ashamed to even speak up about it because they're very strong in the workforce and they come across as, leaders of their path and their careers, but back in their home, they've got issues. How do we find that middle ground? Because organizations, executives, and enough are trying their best to roll out wellness programs in the organizations they kind of relate to, but how can it be effective? That is truly, how can we do that? Wellness is a requirement. We know that. It's just that even if we outsource it, let's assume an international organization goes out and reaches out to self-care. What kind of programs are really the ones that are going to make a difference? I think is my question.
Wow and wow on multiple levels. That was such a great question and such curious examples of things. I almost think that there's an academic research component there. I'm going to say that the power of us collectively within this room, it's going to take a motivational flow, an ebb and flow of all of us to be able to do it. Now, maybe there can be opportunities within self-care or healthcare to help demonstrate that. But much like what Madeline asked, it's that you have to one by one speak to it as it resonates with them, with the VP of strategy, with the COO. How does it affect my margin, my bottom line? How does it affect my safety? How does it affect insurance costs? You know, all of those things. We are finding that people are being much more mindful about opening up. And you know who's been the leaders of that is the newest generation, where they hide nothing, no filter. Okay, so you got to find the middle balance on that also. But you know, whether they're on TikTok or wherever they're at, they're not afraid to share. And somehow that is reverberating back upstream to parents, to communities, to organizations to say, you know what, I do need to have a healthier dialogue. I think that in the more personal realms with domestic violence, with the fear factors, how is it being reported? I think when we use the social determinants of health and how there all are things that are PHI, HIPAA privacy, and where you know you can be sued if you don't keep it private, outside of the hackers getting in and the cybersecurity. But when you are able to say, this is my moral obligation to you, and this is my financial obligation, and this is my privacy, that helps. But it's going to take a repeat and a repeat and a repeat through these types of organizations as ourselves and much of the work that you're doing to tear down those barriers. Women have a real opportunity, you two men, but women in this particular have a real opportunity globally to finally unite. Women are the worst to one another. We can be crabs in the bucket. How dare one woman get ahead of one another? And we have to own it and claim it. And if we're going to give birth to those next generations, we have to be better self-care providers for ourselves to get that ebb and flow going. And we need to see that our work is creationally unified and not meant to work in silos. We need to flicker the flame that's inside of each person's soul. And you can't do that by working in silos. You need to work across the board. So one thing that when you said virtual, there's a positive and a negative on that. Part of the virtual is that I'm just virtual. I'm not really invested in it. You'll never touch me. You'll never really own anything that's sacred in here. So what I'm sharing is from a distance. But on the flip side of that, many people like that because it helps cushion that barrier that I otherwise couldn't garner by having an immediate face-to-face. I may not be a touchy-feely person, but I want to share with you and I want to unload. People do want to unload. That's why the social determinants of health was founded, is to create opportunities where people don't want to have that safe dialogue and they will never volunteer it. But we have to earnestly, authentically transcend it in multiple languages to be able to say, I speak to you, I hear your voice, I want to honor you. What's your sacred story? And when we honor it as a sacred story and not abuses and trials and tribulations, and put it as your sacred story, that you get to own it and tell it how you want to, but help you survive it and thrive it. And that might be part of the narrative. Anyway, thank you. Thank you all.
Thank you, Tina. And we have a.
Perhaps the best one.
Okay. We have joining us now from New York City, Dr. Jeffrey Berrien, where he is the founder of the Happiness Center. I'm going to pass him to the stage to deliver his keynote speech. Don't believe your thoughts, the key to happiness. Thank you for joining us. I can't hear you. Let's see.
Oh, okay,
It's
now.
online.
Yes,
There you go.
thank you so much for having me. And it still says that I'm muted. Are you able to hear me?
Yes.
Yes, we can hear
Okay, great,
you.
'cause it's not allowing me to click unmute for some reason. I'm very happy to be here with all of you. I want to start out by apologizing if there was any confusion about the time. But the point is that I'm here. I seem to be frozen on the screen. Are you able to see?
Yeah.
Yes,
Yeah.
we can see you.
Okay, because for some reason on my end, it's frozen. I'm very happy that I was able to follow the speaker who just spoke. First of all, I can't emphasize enough the power of nursing. I will be getting to this later in my talk, but when I was in the hospital with COVID double pneumonia, and I love the concept of hearing the words post-COVID, a post-COVID society, because when March of 2020 hit, on March 11th, the day they declared it a pandemic, that's the day that I came down with COVID double pneumonia. And it was mostly, I would say it was mostly due to the nurses that I was able to survive. It was a very, very difficult time. COVID was new. It was, it was misunderstood. Nobody knew really what was going on. And I was sick for 2 weeks before they took me in an ambulance to the hospital because they were warning people not to go to the emergency room if you didn't have to, because COVID was so dangerous. And I tried to put it off because I had a heart condition, and the last thing I wanted to do was go to the hospital, but after 2 weeks, I couldn't help it. And when the ambulance crew came to get me, there were 2 men dressed in hazmat suits. And one of them took my hand and he said to me, "Don't worry, you're going to be okay." And I can't tell you the power of that little act of kindness. Nurses do that all day long. When I was in isolation, they were only allowing one person in my room at a time. And a nurse would come in and they would do the same thing. They were dressed in hazmat suits. And several of them stayed at my bedside to encourage me that I was going to get better. So I can't emphasize enough the power that nursing has, very often more than physicians, because physicians would come by once a day to check on you to see how you were, but the nurses were there all the time. Pardon me? So I don't know if people are hearing me. Am I coming across? Because for some reason I'm still frozen on my end. I don't know why. It would
We're
be.
in agreement with your statement about nursing being present.
I'm sorry, I couldn't hear what you said.
We are in agreement with your statement about nurses being present more frequently than physicians.
Thank you. Thank you so much. So I want to explain the topic of the title of my talk, which is "Don't Believe Your Thoughts, the Key to Happiness." And people will be like, well, how could I not believe my thoughts? The interesting thing is that you created all of your thoughts. And your thoughts are not necessarily based on your experience. They're based on your interpretation of your experience. So in my own life, and I use that as an example very often, I was a very severe stutterer. And I started stuttering when I was 6 or 7 years old. And I stuttered through my 20s and beyond. Even after I was a doctor, I was still blocking on certain words. And when I went to college, I made myself run for the president of the school, of the freshman class, because for some reason, I was always battling fear in my life. And that's another topic that you had touched on, because for the last 3 years, we've all been engulfed with fear and stress. And for some reason, I always knew that I had to challenge my fears. I don't know where they came from, but I was surrounded by fears. And so I made myself run for the president of the freshman class of this huge college. And I wasn't even able to say my name. I could never say Gurian. Most stutterers have a very hard time saying their own name. And my feeling about it is because your name is your identity. And if you're not happy with who you are, it's very difficult to tell people your name. to put yourself out there. So I had other students introduce me to students I didn't know and say, this is Jeffrey Gurian, he's running for president, you should vote for him. And I told myself, if I could win the election, I wouldn't have to stutter anymore because it would show me that people liked me. I guess I had a feeling for some reason that I didn't really fit in and that people didn't like me. I don't know what would give me that thought, but I'm going to get to that. Anyway, I won the election. I was the president of the freshman class and I still stuttered. And it was a great lesson for me because it taught me that outside validation in life doesn't work. It doesn't matter how many people compliment you and tell you that you're wonderful and talented and fantastic. It matters what you think of yourself. Everything is about thought. One day I realized that I didn't stutter when I was alone. I could go into a room by myself and I could speak perfectly, which applies to a lot of people who stutter. And I was given the grace to figure out that you can't have a disability based on your location. If a man has a limp, he limps in every room of his house. He can't go into a room and close the door and walk perfectly. But if I could go into a room by myself and speak perfectly, then theoretically it means that there's nothing wrong with me. And I was holding thoughts that were not valid for me. And I want to put out there that each one of us is holding thoughts that are not valid for us. From the time we're children, every time someone hurts your feelings or breaks a promise to you, or breaks up with you in a relationship, or lies to you, or hurts you in some way, it stays lodged inside of us in our heart chakra. And I call them heart wounds. And those heart wounds affect every decision that you make. They affect your self-esteem. They affect your self-confidence. Because every time you're called upon in your life to make a decision, you think about what to do. Who else's thoughts can you use but your own? And we tend to believe our thoughts. And if some of your thoughts are not valid, if they're negative against yourself, then your decisions are not going to work out, which is the reason why people have the same patterns in their lives, the same bad job that doesn't work out, the same bad relationship that doesn't work out. And the only common denominator is you. You're the one who keeps appearing in all of these different situations. All the people are different, but the same result happens. So it's based on thought. And so this led to my first book. I've been fascinated by this for a long time, that what thoughts am I holding? Because in order for me to conquer stuttering, and as you can see, I've been given the gift of being able to become fluent. And one of my avocations that I work with stutterers all over the world to teach them how not to stutter and to use the power of your mind to change negative thinking to positive thinking. That's a critical aspect for me. I spent 20 years on the board of the Association for Spirituality and Psychotherapy. And I was also so glad to see in the last speaker that one of the things that she mentioned was spiritual, because all of my work is done on a body, mind, spirit approach. I spent 12 years as a clinical professor at NYU in the oral medicine and orofacial pain program. And I was treating the physical symptoms of stress that manifest themselves in different ways, very often with a TMJ connection. And for anyone who's not familiar with that, the TMJ stands for the temporomandibular joint. It's the joint in your jaw that allows you to open and close your mouth, that allows you to speak and eat and do anything that's involving your jaw. And in times of stress, which we've all been living through the past 3 years, people tend to clench and grind their teeth. Many of them do it without realizing it. And it causes what people think are migraine headaches. In this country alone, there are more than 150 million people who suffer with what they think are migraine headaches that are really what we call musculoskeletal headaches that come from their jaw, from clenching and grinding their teeth. Because what most people don't know is that the muscles from the jaw attach in 3 regions. They attach in the temple region, behind your head in the occipital region, and even down in the shoulders in the trapezius region. So if you wake up in the morning and your neck hurts, probably the last person in the world that you would think to tell would be your dentist. Why would you ever tell your dentist that your neck hurts? So people go around and usually they won't ask the physician. So unfortunately, many dentists don't make that part of their examination. They don't ask if you have neck pain or shoulder pain when you wake up in the morning, or if you have a tightness in your jaws. And most physicians are not familiar with those symptoms. So very often it goes undiagnosed. And so all of this goes back to thought. Our negative thoughts were given to us most of the time in childhood by people who may not have had your best interests at heart. Sometimes it could even be from parents. Some of us came from families where they were not particularly supportive of us. Some people had very difficult childhoods. They were told that they would never be successful, that they could never accomplish their goals. And those are the things that cause what I call heart wounds. And they stay lodged inside of us until we are able to release them. And that was the purpose of, I started writing books on happiness. I wound up with 8 books. I never thought I'd have even 1 book, but life is very interesting on the paths that it takes us. So I am also in the comedy world, and my first 5 books were on comedy, but my last 3 books were on thought, mindset, and happiness, how to change from negative thinking to positive thinking. And the first book was called Healing Your Heart by Changing Your Mind, a spiritual and humorous approach to achieving happiness. And I hope you can see this. I can't tell because my screen is frozen. So I'm just speaking into my computer, but it's a picture of a meditating dog. And it talks about all the ways that we have to change our thinking. When I was taken to the hospital for COVID double pneumonia, they wheeled me into the emergency room, and they wheeled me into a cubicle next to a woman who was screaming, literally screaming with every breath that she took. And I was so sick and so weak that my first thought was, why can't they move me someplace else? There was no place to move me. They had run out of rooms in the hospital. They were putting people in the hallways already. It's unimaginable, the stress and the fear and the tension that was surrounding people. And what I had to do is I had to practice what I preach. I had to step outside of myself, and instead of worrying about me, because the natural tendency is to ask yourself, why me? Why is this happening to me? But the answer to the question is, why not me? Whoever promised me that my life was supposed to be perfect and that nothing was ever supposed to happen to me? So I had to step outside myself and start thinking about this woman and how scared she must be, or how much pain she must be in order to be screaming with every breath. And they were actually thinking of sending me home until they x-rayed my lungs. I asked for a cardiologist because I was concerned about my heart. And they told me that there were no cardiologists available. A pulmonary specialist came to see me. They x-rayed my lungs, and he said, I'm sorry to tell you, you have COVID double pneumonia, and we're going to find a room for you. And they emptied out the cancer ward at NYU Langone Hospital. They emptied out the cancer ward to make room for the COVID patients. And for the first 2 days, they put me in isolation. And on the 3rd day, they put me in a room with 3 other very sick men. And it was very interesting to me. All 4 of us were very different backgrounds. The man next to me was an elderly man from China. The man across from me was a man from India. And the man on the opposite side of the room was an Orthodox Jewish man from Israel. And all of us were suffering with COVID pneumonia. And again, it was very easy. It would have been very easy for me to feel sorry for myself, but I had to remind myself from a spiritual perspective that everyone has a path. And for whatever reason, this is my path. I can't choose to only believe in certain principles when it feels like my life is going perfectly. It's when it feels like nothing is going right in your life that these principles are very important. To understand that for whatever reason, I have to go through this. This is my path. If I'm in a negative space, my immune system is not going to function well. If I'm in a positive space, if I can manage to stay positive, my immune system will function better. Luckily, I had put myself on Z-Pak. As a doctor, I always keep antibiotics in the house. And on the third day of COVID, it went to my throat. And as soon as I get a sore throat, I start myself on antibiotics. And I had Z-Pak, not realizing that it's also specific for your lungs. It protects your breathing. And usually the course of Z-Pak is 5 days. I stayed on it for 10 days. I was able to continue breathing, but I was getting every other symptom and I was getting sicker and sicker. And no one could visit me. You have to be alone. And my children would call me and say, can you still breathe? And I would say, yes. And they'd say, maybe it's not COVID. But the fever didn't stop and the nausea didn't stop from morning to night. And the body pain didn't stop. And when I got sweats, the fever didn't break. And so I had to work very hard on staying positive. And through grace and through the help of the nurses, mostly, I would say, even more so than the doctors, you know, they gave me hydroxychloroquine before they politicized it. And the drug turned the corner for me between that and the Z-Pak, and they gave me zinc. And by the third day, my oxygen was staying to 96%. And they said that that was enough that they could send me home the next day if my oxygen level stayed that high. And it took me literally months to recover. Now, I had a very similar experience about 7 years ago in terms of taking negative thinking and turning it to positive thinking. I had never been sick in my life. And all of a sudden, one day, I got a heart attack. And they called it a widowmaker heart attack, which is about one of the most serious kinds that you can have. And obviously, they took me to the hospital. It was not easy for me to get there. I don't know if any of you have heard about New York City. I'm sure, well, I know you've heard of New York City, but New York City can be a very wonderful place. It could also be a very cold place. And I was in the street when I got this pain in my chest. And I thought to myself, I should probably tell somebody, but it's kind of embarrassing to tell people that you think you're having a heart attack. But I said to myself, you know, I'd be awfully stupid if I just died in the street and didn't tell anybody. So there was a police van with 4 policemen in it. And I knocked on the window and I said, I'm sorry to bother you, but I think I'm having a heart attack. And the cop said to me, well, I think you should go to the hospital. And I said, well, that's why I'm telling you. I'm not just telling everyone. I assumed that they would say to me, get in, and they put the siren on and they drive me to the hospital. But that's not what happened. The cop said to me, he said, we're stuck in traffic. It'll probably be faster if you walk. So I said, well, where's the nearest hospital? And he didn't know. None of the cops knew where the hospital was. So he took out his phone and he started looking for hospitals. And he said to me, do you have Google Maps? And I said, no, I don't have Google Maps. What I forgot to add was that it was pouring rain and I'm standing in the rain with an umbrella. And as silly as it sounds, I don't like to go out in the rain because of my hair. I know that sounds very stupid, but it's the truth. And so I was asking the cop and he tells me to download Google Maps. And at that point, it turned into a ridiculous movie. And I literally walked away because it sounded very foolish to me that I'm telling cops I'm having a heart attack and he's asking me to download Google Maps. But I could only get another half a block. And there was another cop directing traffic. And I said the same thing to him. I'm sorry to bother you, but I think I'm having a heart attack. And he said to me, stand on the side. So I stood on the side a couple of minutes and I said to him, are they coming? And he said, oh, I'm so sorry. I didn't call them yet. No, it seemed like no one was taking it very seriously. And what I figured out afterwards was because I was very calm. I wasn't panicking. I used my spiritual principles to again remind myself that if it was true that I was having a heart attack, which I was, that for whatever reason, this is my path. And it doesn't serve me to panic or to run up to people in a panic. And because I was so calm, I don't think they took it seriously. a fire truck finally pulled up. He finally called, and a fire truck pulled up because in New York, firemen are usually the first on the scene because a lot of them are EMTs. So the truck pulls up and the guy says to me, "Who's the patient?" And I said, "Me." And so 4 or 5 guys got off the truck, and he said to me, "Climb up on the truck." And I said, "Seriously?" He goes, "Nah, we're just kidding with you," just like that. And so everyone took it as a joke. When they finally got me to the hospital, they didn't treat me till the next day. And what I learned afterwards was that when you have a widowmaker heart attack, they're supposed to unplug your heart within 90 minutes. But nobody diagnosed me. Luckily, they put me on blood thinners, and that's probably what saved me. The next day, when they put me on the operating table to unplug my heart, I wasn't fully asleep. I was watching on a screen what they were doing, and I felt them unplugging my heart. And because I'm also in the comedy world, I said to the surgeon, "I feel you in my heart, not in a romantic way, but I feel you in my heart." And the whole surgical team started to laugh. And he's like, "You're the first patient that ever joked with me during heart surgery." And because I try to stay positive no matter what's happening in my life. He came to my room later that day around 5 o'clock, and he said, "I have to hug you. You're a miracle." It turned out I was 95% blocked in the major artery to my heart. And I said to him, "No, I have to hug you because you're the miracle. You're the guy who figured out how to save me." 5 days later, I was back on stage performing. And the owner of this big comedy club said to me, "What, are you crazy? You just had a heart attack." And I said, "Yeah, but it's hard to get a spot here. I don't want to lose my spot." And so everyone laughed. And I told the story for a while about this crazy incident that happened to me having a heart attack. But it all comes back to your thoughts. After what we've all been through in the last 3 years, it's no surprise to me that many people are suffering with depression and all kinds of emotional illness. People are not, we're social animals. We're not made to be isolated. I stayed home for many months, but I was taught the power of kindness, which is another thing that I love to talk about. A woman in my building found out that I was sick. I live in a very big, a 36-story building. And this woman found out from one of the doormen that I was in the hospital. And she contacted me and she said, "You must tell me what food you need and I'll shop for you." And I was very embarrassed because I'm very used to giving in my life. That's my nature. I'm an empath, which is how I got involved in healing in the first place. I feel what you feel. There was a time in my life, if I was with you and you were sad, I was sadder for you than you were because I overfelt my feelings. And this woman insisted that she buy me food, that she shop for me because she didn't want me to leave the house. I was too scared to leave the house anyway. And for several months, she left food outside my door. I would give her a list of things that I wanted and she would shop for me and leave them outside my door. And one day I said to her, "What did I do to deserve you?" And she said, "You're helping me become a better person." And telling you that story almost brings tears to my eyes because it was so meaningful to me that there are so many kind people in the world. Very often, the world looks like a very cold place, but there are many people in the world that are very kind and caring. And she proved that to me. Literally months went by where I didn't leave the house. I was engulfed in fear. I kept thinking that if I went out, I could catch it again because they said there's no guarantee that you can't catch it. Now we know that you can catch it. But again, this was March of 2020 when people didn't know anything. And so while I was home, I'm an A-type personality. I always feel that I need to be creating things. So I was home for months and I said, "What can I do?" And I said, "I'm going to take my experience and I'm going to write books about it." And I wound up writing 2 more books during the time I was in the house, which I call my happiness series. And the second book, which a lot of you might relate to, is called Fight the Fear, Overcoming Obstacles That Stand in Your Way. And because as I said earlier, I've been battling fear all my life. I came from a very loving and supportive family, but very overprotective. I was not taught that the world was a safe place. Unfortunately, today, it's not a safe place. But I wasn't taught that the world was a safe place, and I grew up with many, many fears. I was grateful that I grew up with the knowledge that I had to confront my fear, because fear is a bully. Fear wants you to stay in bed with the covers over your head. It tells you that you can't achieve anything. It tells you that you can't bring into your life the things that you think you want. When I grew up, I had such negative feelings. I thought that I would never have a profession. I thought I would never be successful. I thought I would never be married and have children. I don't know where these negative thoughts came from or who gave them to me, but that was the main reason, I believe, for me stuttering. And as you can see, I no longer stutter. You can't even shut me up. I can speak a very long time and I don't stutter, and I'm very aware of that. But what I found is that fear is pervasive and it stops people. I have fears of traveling. So in 2019, just before the pandemic, I took on what I considered to be my greatest challenge. And I went to Japan all by myself. And to some people, that may not sound like a great challenge because some people love to travel. Traveling is very difficult for me because I battle severe ADHD, which I was diagnosed with. A lot of people just say they have ADD because they're confused. The doctor who tested me said to me that it was amazing that I ever got through school and graduated in the top half of my class. He said to me, you must have had to work 10 times as hard as everyone else, because despite the fact that I'm facing fear with many things, I never let it stop me. I don't let it stand in my way. If I did, I would still be stuttering today. So I went to Japan. I signed up for the Japan Society. For some reason, it was always my dream to go to Japan. I don't know why. I have very strange dreams. And I studied Japanese level 1 3 times. And they tell you that everyone in Japan speaks English. It's not true. Don't believe it. I got there. I got two years in a row. A friend was supposed to go with me. And both times he canceled out. And the third time I said, you know what? I'm not going to let fear stop me. I don't need anyone to go with me. I'm going to conquer my fear and go myself. It was my first time on a plane for 14 hours. I must have gone into a dream state because I don't even remember how terrible it was, but it was 14 hours, a direct flight. Oh boy, I performed in 2 shows while I was in Japan. I conquered the Japanese subway system. I was literally lost every day, and I have fears of being lost. And being lost in Japan is a whole other story. I don't know if any of you have been there, but when you take the subway, it's not enough to know what stop to get off. You have to know what exit to get out. And my first day, I was stuck underground for an hour. I didn't know how to get to the street until I found one person who spoke enough English that they were able to tell me how to get to the street. After that, I went to different places every day. I went from Tokyo to Osaka to Kyoto. I spent 2 weeks in Japan, and I performed in 2 shows. I found 2 spiritual meetings. I connected to people, and it was an amazing experience for me because I didn't let my fear get the best of me. So I wrote this book, Fight the Fear, overcoming obstacles that stand in your way, because so many people that I meet are battling fear. And the last book I read, and I guess I'm supposed to end soon, but the last book I wrote was called Facing Adversity, Stories of Courage and Inspiration. For the last 20 years, I've been collecting these stories. These are true stories of real life people who were faced with tremendous difficulties, who overcame them to lead happy and meaningful lives. And I'll give you 2 quick examples. A little 3-year-old boy was playing hide and seek, and he hid behind a tractor that was running, and he put his hands in the tractor and it cut off his hands. And his father saw it happen, and his father happened to be a surgeon, but not that kind of a surgeon, not a transplant surgeon. And he rushed the little boy to the hospital, and it was a holiday and there were no transplant surgeons available. So the father put together a team of 9 people to do surgery that he had never done before. And he successfully reattached his little boy's hands and put them in casts. They took the casts off after 3 months, and the hands they were alive, but they weren't functional. The grandfather was a martial arts master and trained that little boy every day growing up to reuse his hands. And today that little boy is a famous spinal surgeon, and he runs the spinal surgery clinic in a hospital in Colorado. Now, he was going to be a hand surgeon, but I've done surgery. I know what a steady hand you have to do surgery. To do spinal surgery is a whole other level. This is such a gift from God to be able to have your hands cut off and to run a spinal surgery clinic in a hospital was unbelievable. And then there's a story of a man, and he doesn't mind saying his name because he puts himself out there. Nick Vujicic was born with no arms and legs. And at 10 years old, he tried to commit suicide because he was bullied so badly. And I don't know what that's about, but some children, they tend to have a mean streak. A lot of people have a mean streak where they bully people, which causes the heart wounds that I mentioned earlier and why I say don't believe your thoughts. So he was going to commit suicide, and then it came to him that he couldn't hurt his parents that way. He grew up with no arms and legs, and today he's an internationally known motivational speaker who's married to a beautiful woman and has 4 children. 4 children. Meanwhile, the singles bars are filled with tall, handsome guys with all their limbs who can't get a date. And this man is married to a beautiful woman with 4 children who has a huge career. He lectures all over as a motivational speaker. Those are the kind of stories that inspire me. I'm not in the book. I wrote about my story with stuttering and the heart attack and COVID is minor compared to what these people came through. And it just shows you, it proves to you the power of the mind and the power of thought. Self-pity is one of the worst things that you can indulge in. When you start feeling sorry for yourself, your immune system goes down, you get depressed. You know, anytime I ever did that in my life, the universe put someone in front of me, some poor unfortunate person that was in very bad shape. And I had to ask myself, why do I need to see that to feel grateful for the things that I have? So I teach people to create their own happiness centers. And I'll end on this, that where you live, every place around, everything you see where you live should be something that makes you feel good when you see it. In my apartment, you would think little children live there. It's filled with balloons and crayons and toys. And because balloons are a symbol of happiness. So when people come into my apartment, they're like, is there a party? And I say, always, because I'm very connected to my inner child. Your inner child is alive and well inside of you and needs to be nurtured. And you need to stay connected to your inner child. So bright colors make me happy. So my carpeting is white and my piano is white and my car is white. And I have beautiful colored things all around and pictures of people that I love who care about me. When I was in the hospital, they announced it on the radio on Sirius XM that I was in the hospital. And I started getting literally hundreds of messages from people I never knew that were sending me prayers and wishes that I would get better. And I was too sick to answer anybody. But again, the power of kindness. I'm a very big believer in the power of prayer and the power of thought. And when so many people are thinking about the same thing, I truly think that it has an effect. So I'm sorry if I went over my time, but when I start to speak, because I don't stutter anymore, I have a lot to say. And I would like to stop now and open to any questions that anyone has. But I thank you again. I'm very grateful for having the opportunity to share these things with you. There's so much more to say about the power of thought, but I think I made my point. So I thank you so much for allowing me to be here with you today. And thanks to Frank Chindamo for inviting me.
Thank you, Dr. Zimmerman. We're going to see if we have some questions here today. Anybody have any questions to Dr. Gurman today? Ah, Frank. Why did I think Frank would have a question?
Because I have a lot of things that I need to learn, that's why. So, hi Jeffrey, how you doing?
Okay, Frank, how are you?
I wish you could have seen the audience and seen how you completely captured people, and he's looking at my butt. This is terrible. You could have seen how enraptured everyone was, but I did want to add a comment that I've read a couple of Jeffrey's books, and they are wonderful and short and fast and easy to read. And so I highly recommend them. That's it. All right. Sorry about the butt.
No, thank you, Frank. I wish I could see. It's a crazy thing. It's exactly what happens in life. At the last moment, something unexpected happens. My screen is frozen. I'm afraid to even do anything because I thought it would cut off our session. But I haven't seen one thing. I'm just speaking into my a frozen screen. And but again, I had to process that because there was a time in my life when I would think, well, everything is going wrong and I should just stop. But you can't do that because life throws obstacles in your way that you can't expect, and you must overcome them. And I want to give a shout out to LaughMD. I'm so proud to be on the board of that group, bringing comedy to sick people and to people in recovery, because the 12, I do a lot of work with 12-step programs that are very powerful spiritual programs. And they teach people that it's okay to be happy, that you don't have to rely on outside sources. So just wanted to give that shout out to LaughMD, very powerful, and I'm proud to be part of it.
Well, Doctor, thank you so much for your presentation. I wanted to ask you, if you got a call one day and they said that based on your work of kindness, that they were giving you the Nobel Peace Prize, would you accept?
Would I accept? I would accept humbly. Who wouldn't accept the Nobel Peace Prize? I mean, that's a beautiful thing. It's more important for me, though, for people to embrace that concept. Kindness is so powerful that it would be a much nicer world. You know, I always talk about the difference between spirituality and religion. And we have a very multicultural background of people that are part of this conference, which is wonderful. But religion can be wonderful, but it tends to divide us because it puts you in a category. And spirituality brings the whole world together because all it asks is that you believe in something greater than yourself. If you think that you're controlling everything in your life, that's what leads to emotional illness, because we tend to blame ourselves. Too many people are living in the past thinking of what they could have done and what they should have said, and they're worrying about the future, and they're losing the now. They're not present for the now. So again, kindness is so important, and it's part of the spiritual world. And that's why I was so glad to see that mentioned in the presentation before mine, because you never know whether to bring that up or not. But all my work is done on a body, mind, spirit approach. The heart is the most powerful organ in the body, much more powerful than the brain. And you can tell, it's the reason why people hug each other when they're in a group. They understand that you're transferring positive energy from one person to another. And that's what healing is about. So if anyone wanted to give me the Nobel Peace Prize, I would gladly accept. Is there anybody else that has anything they'd like to add?
Yes, doctor. My name is Leola Williams. I am a registered nurse, one of the nurses that you are speaking about so eloquently, about doing so well for our patients. But I may add that you are absolutely correct, that laughter do you good like a medicine. So it has been proven that people who have had different kinds of diseases and blood pressure problems and all these kinds of things, that through laughter, they have come through without being medicated. Thank you so much for what you do.
Thank you very much. It's not just a cliche that laughter is the best medicine. Laughter is a healing force. Not only does it release endorphins, but it brings people together. When you can have people from all different backgrounds laughing at the same thing, that's what heals the world. I have a friend named Russell Peters, who's a very famous comedian. And when you go to one of his shows, there's people from every country, and he imitates every accent, starting with his own Indian accent, and imitates every accent, and everyone loves him. And the whole audience is laughing together because he's not making fun of people. He's pointing out our differences and also how we're all the same. People all over the world, every country has people who are funny and people who laugh. That's all people want. People just want to be happy. And using comedy and humor is a way to bring the whole world together. And so that's another reason why I'm so grateful to have an opportunity to speak to you all today. Is there anyone else that would like to ask a question?
Hi, Doctor. Yes. My name is Fatima. I would like to ask you, you just mentioned that there are a few moments in life when people can't move on. As you said that something they should have done, they did not do at that time. So can you share something, if you have experienced something like that, overcoming a regret, as you're talking about spirituality and religion? Can you share something from your life? Have you mentioned anything in your book?
From my own life, yeah, I share a lot of things. Are you asking? I'm not sure that I heard everything, but are you asking for a personal experience of mine?
Yes. How did it work for you?
I'll share something very, very personal with you.
Thank you so much.
You're very welcome. So I went through a divorce that's very painful because I have two children that I love with all my heart. And the woman that I was married to, who I'm very grateful to for giving me my children, she remarried and she adopted two children and she had another child of her own. And those two children needed to be adopted and that little girl needed to be born. And that could not have happened had I still been married to her, had I stayed. So in retrospect, and I should add that today, we're all great friends. I have a very big extended family. I celebrate all holidays with my ex-wife and her husband and all of our children. And when my parents were still here, they would come with us and her parents. I have a very big extended family as a result of the things that I'm sharing with you, of a different way of thinking, because too many people end relationships with hatred and with bad feelings. And you know what? If you don't have children, maybe you never have to see that person again. But to me, in my mind, children are the greatest gift that anyone can give you. So how can you hate the person? My children wouldn't be those people if it wasn't for that woman's DNA, for her double X chromosomes. So I'm so grateful to her, and I tell her that all the time. And so that's a very personal example. A lot of people don't talk about things like that, but I feel that if I can share stuff about myself that you can identify with, that it will help you be able to share. Most people keep things like that to themselves, but I'm very proud of it, that I wound up with a very big extended family because of the principles that I talk about in my books. And I write about that in my books, about how to change your thinking. Because again, many of us are holding thoughts that are not valid for us. And those thoughts cause us to make bad decisions in our lives. And that's why so many people look back and think what I should have done and what I could have done. I have no regrets when it comes to that. I have a wonderful relationship with that whole family. And the alternative would have been horrible for me, because you can't do that to your children. You can't put them in a place of choosing between which parent they like best. And unfortunately, that happens much too often. So I hope that was an answer to your question.
Hello, Dr. Karen Walker here. I just wanted to just give you a comment, and certainly thank you for sharing a lot of your experiences. I've been in the cardiology field for over 35 years. And when you talked about you having a heart attack on the street, you can also add to your repertoire that
because you were thinking positive, and you talked about, you know, you having a 95% blockage in the LAD, the left anterior descending artery. And you probably went to the cardiac cath lab and they utilized a drug-eluting stent to open up your artery. That's the only way that you were awake during the procedure, right? And so when you went to the emergency department, because you were thinking positive, you really didn't exhibit any signs and symptoms. So the EKG was not indicative of ST elevations, if you will. And so
It was a non-ST, it was a non-ST wave. That's what they called it. But
there you go. And that was probably because you were thinking positive, because if you went through the ED and they did the 12-lead EKG and they saw the ST elevation, then certainly you would have been rushed directly to the cath lab. So certainly, you know, you can add that to your speech. Thank you.
thank you. And I'd like to add one thing to that. When I got to the hospital, they kept me in the emergency room for 9 hours. They couldn't get me into the cardiac unit. And it wasn't until midnight that night, from 3 in the afternoon until midnight, they kept me in emergency, and they wheeled me against the wall and where nobody could see me. And a nurse gave me a button. She said, if you need help, press the button. And I pressed the button and nobody came. And finally, I had to stay positive through that whole thing. I was advocating for myself the whole time. And it wasn't until the next day. And maybe you would remember, what is the chemical that they find in your bloodstream that they look for? I think it starts with a P, that tells them that you're having a heart attack.
It's roughly troponin.
Pardon me? I'm sorry, I couldn't hear.
Troponin.
Troponin, exactly. So it's supposed to be 0. My troponin level was 24 by the time they took me in. And they said that's how serious it was. So it was because I was able to stay positive. I really attribute a lot of it to that. Their skill helped. The nurses were great, but I had to fight to stay positive. And I never thought about the alternative. I was joking with people, and, you know, and here I am. I'm still here. So thank you very much for your comment. Troponin, exactly. Anybody else? Thank you.
Thank you, Dr. Gurian.
You're very welcome. If anyone has any questions, I always like to include my email. People can write to me at jeffrey@jeffreygurian.com. I welcome any questions afterwards. jeffrey@jeffreygurian.com.
Thank you so much for your time.
You're very welcome. Thank you for having me.
That's JEFFREY@JEFFREYGURIAN.com.
Right. And all my books are on Amazon if anyone is interested. They're all available on Amazon.
Thank you.
You're so welcome.
We're gonna break for lunch now. Lunch is right next door. And if you don't mind bringing your lunch back in here, we're gonna have a working lunch today. Thank you.
Yeah.
So once again, ladies and gentlemen, if you will step next door and select your lovely choices for lunch, bring your lunch back in here. It'll be a working lunch today. Excuse me, we'll have a presentation by Mr. John Melton, who is presenting a workshop on bodily mind. Thank you.
Jesus Christ.
Can we stand in front of this really quick for next or not?
Not right now. Yeah,
I will just help you.
okay.
Oh, I think.
I need to see the presenter view.
Oh.
I would do it in front of there.
No.
Oh,
That's right. We want to. I'm sorry.
So this is a presentation, right? So there is a sound. Actually, I have converted into presentation mode.
great.
So is there a audio, sorry?
There's videos all through it.
Okay, the video will run. So
I hope so. Let's try it.
so
So.
No, I just.
it's working, right?
Okay.
Do you need any more help?
Well, no, it's not working. No, it's not working. You shouldn't see the presenter
Yeah,
on.
it will go.
Okay, how do you make that change?
There are many slides open. Close everything.
That's a smart idea.
Now I look in.
Like, you know.
Yes. Now it's okay.
Oh, cool. Okay. All right, let's just double check one more video.
No, you have to do this.
Just this.
Oh,
So now it's his
all right, cool.
presentation.
Sure, let's just play one more video.
Just so that this is really.
So how do you make the video play?
Video, this one?
Yeah, just tap it.
Yeah, tab it.
Okay, I'm gonna sign in with my account, which doesn't play commercials.
So you can plug in your laptop if you want to.
No, this is fine. This is good. But I'm just gonna sign you out and sign me in on my YouTube account because my YouTube doesn't play commercials.
Mhm.
Okay? So do that while he's doing his thing.
You can take this laptop because he'll be using his own mic.
Okay, great.
Some of it you can't fix, there might be a motion.
Nice, Jack. I say I went with the right choice. Thanks.
Okay, very good.
Yeah, coming to that.
But are you at answer now? Because I was asking Carol separately.
I was going to see all of them. I think you're away. All you want to ask is.
What's your idea? You're on show.
It's an hour and a half. It just takes. But we have to do it.
Yes, please.
We have to go. It's 6:30. Yeah. We have to be there. We have to be there.
Talking about now.
We really need to be. Yeah. Or else. Yeah.
All right, fine, I'll go with you. You're making me. Can you make your name good? Well. Make me do this. Choice here. That hurt. That hurt. Yeah, that hurt. You just kidnap it. You invite me. You just kidnap it. You don't need to be polite. Why are you doing this to me?
Yeah,
First you want me to go and you don't.
so if I
First you
do
make
this,
me
can
go
I just
now.
know?
All this inconsistencies are blowing my mind.
You should.
Why?
No, you have to do the thing that's like.
Because you don't know it's a great.
Do not take it. You want to tell.
Aren't you? Something. She's saying to you.
Make sure. That's it.
But you are, FYI, we're 7. I need a confirmation. Okay, 7. I'm fine. 7. No. Yeah. And,
You ever have a lavalier? Oh, no, that's fine. I'll use it. Yeah. I want to go around. Okay. Turn around. Yeah. That's the side it'll go.
8. 9.
Wait, what about Lisa?
And then.
Yeah, what's up? No, just look them down. I just look in the emails. Look at the picture. Okay, hold on. Glad you knew. So you. Yes. So Barbara, Lisa, Kim, London, and then Carl, Lauren, Lauren, Super, the hut, and the hut. Okay, hello. Okay. And to go there, we get that come and let they go to. I'll just do the order. Let's look at this. I hope so. I just order the order as well. Because we're finding out right now.
Okay, we're gonna get started in here.
2 Ubers, okay.
I can have your attention. First of all, as was mentioned a little bit earlier before we just broke to get your food, we're gonna do more of a working lunch here, which simply means that I'm going to give you just some awesome information that can help you out for anything you're doing as far as work here in the United States. As I go through this, if you have any questions, then when I'm done, you can answer any questions. I'll answer any of those questions for you. But as we get into this, I would like to welcome you here on behalf of Legally Mine. My name is John Melton, and I grew up in California, grew up in Southern California. Grew up in the 60s and the 70s, and I've seen a lot of changes out here. I don't live in this area anymore. I did go to a university, and I went there to get an education, and I happened to play football while I was there. And then same time, I was able to meet my girlfriend who's here to help me. And her name's Julie. You can see her in the back there. Julie, raise your hand so everybody can see you. She is She's been my girlfriend for a lot of years, and fortunately, she's also been my wife. So we've been married 40 years, and we have 5 children. All of our children are married, and we also have 16 grandchildren. And I can tell you that if you've ever heard that grandkids are better than kids, it's true. It's fun to love them and hug them and then send them home. A lot of fun. In fact, I'll even prove it to you that I do have that many grandkids. That's us and all those grandkids. So a lot of fun. It's exciting. We have heard that we have a couple more grandkids on the way too. So we just tell our kids, keep having kids, because it's easy for us to have kids now. Anyways, so I have had a number of experiences over my years. My background is mostly in business. My degree is in journalism, but my background is in business. And in my experience has been finding out some of the things that work and don't work when it comes to business and things, how to be protected. Today, what I've been asked to do is share with you what we do as a company. We're a legal services company, and to share with you what we do and to help you in a few different ways. I'm very curious in this group because it is a lot of people from a lot of places, it looks like. And as I've talked to most of you, how many of you, I'm just curious, how many of you actually work in the United States? Raise your hands and let me see. So 1, 2, 3, 4, 5, 6, 7. Okay, so we got about 12. This obviously is going to pertain mostly to those that actually work in the United States, because I don't know international law. I don't know anything that happens outside of the US. But if you're working here right now, you need to pay close attention to this. And if you are ever planning on working in the United States, it would be really good for you to pay attention to some things I'm going to share with you. For a number of years, what we have done has been able to help those in the medical and the dental world. We have been doing this for about 15 years. We have about 14,000 clients all across the United States. We work every state. We enjoy doing what we do, and we're very good at helping people with a couple of different things. The objectives today are real easy. One, I want to show you how to put more money in your pocket, and I have never had anybody argue with that. And the second is to help create legal strategies that are going to help you keep what you actually earn. And this is a major problem here in the United States, more than any other country in the world, and I'll tell you why. This is more of a rhetorical question, but I could say, do Americans like to sue? And I think everybody here understands that they do. You can't go into one city in America today without seeing these billboards everywhere, on the back of buses, on taxis, everywhere you look, these billboards are everywhere. The reason what that's caused actually is an epidemic here in the United States of lawsuits. The United States has about 5% of the world's population, but even with 5% of the world's population, we have 90% of the lawsuits are actually here in the United States. Last year alone, we had 100 million lawsuits. And it's kind of scary when you think about it, because if you take 350 million people and you got 100 million lawsuits, that means 1 out of 3.5 people are going to be sued statistically. And that means if you look to the person on your left or the person on your right, one of you three are going to be sued. If you're actually in the medical profession, if you're doing anything with medicine, you're going to get named in most any lawsuit you'd ever go up against. So what we do is we just say, listen, we know that there is, if you were taking the grand scheme of things and you have 350 million people, then 1 out of 3.5 might get sued. But this is a very small subset that we're actually talking about here, and that is those within the medical profession. Because the medical profession is the most sued profession in the United States. And that means that you got a target on you. Now, let me explain why that is. It's actually fairly simple. Attorneys today are not going to sue somebody who's homeless. They're going to sue somebody who's broke or appears broke. That's not who they go after. They want people that have money. And I can assure you of this. If you have a doctor in front of your name, they think you have a lot of money. It doesn't matter what you have. They think you do. The other thing that's kind of interesting is going through this, when they come after an individual and they're looking at that individual and they're in discovery trying to figure out what you might have, they will do deep research to find out anything attached to you. Our job is pretty simple. My job today is just to show you how you can be homeless and penniless, according to the courts. But you still own everything. You still have control over everything. You can grow your business into a massive business. It's just that by the courts, they won't be able to come after any of that if this is done properly. So you can actually beat the odds. Now, I want to break it down real simple, tell you how lawsuits work. The reason I want to bring this up is I want you to see the basis of why we do what we do. The main thing is there's two elements to any lawsuit. And I can tell you this, that the first one is the cause. There's not a lot we can do about cause. And the reason we can't do a lot about that is because some people will manufacture lawsuits. So there's just nothing we can do. If somebody doesn't slip and fall, can't stop that. However, we can really control the motivation. What do you think motivation is for a lawsuit? Now you got it, right on, it's money. So here's the problem, we always need to control that aspect. And we're gonna break it down so that it becomes very simplified for you. But I can assure you, in any college you went to, and anything you've ever studied, whether it's being a physician, or whether it's being a nurse or a physician's assistant, doesn't matter. I can tell you that right now, they don't teach these kind of things, and that is, we break it down with money and assets, two simple ways. First is, we're gonna talk about safe assets. The second is, we're gonna talk about risky assets. So everybody in this room has probably both of these, but the way we do this to protect you is to break those two things down. So safe assets, I'm gonna give you a list of some of what we consider safe assets. Here's what we would consider safe assets: investment accounts, bank accounts, jewelry, artwork, precious metals, other types of valuables might be in your home, cryptocurrency. Those are all safe assets. Because all those assets right there cannot create their own lawsuit. We can actually group all those together. So we would put those into an entity and we would group them together. Having said that, those are the safe assets. Now, the question is this: with all these attorneys that are out there and the way that they try to protect people, why is it that a lot of them put them in the wrong type of an entity, or an entity that won't work for what they're trying to do? And most of the times because they're not specific. They have not spent the time and the effort and have as many clients, especially in the medical world, that we do. We're the foremost expert in the country. But I can tell you that as we do this and do it the proper way, especially anybody working in California, there are specific things that have to be done the right way. If not, it can absolutely blow up everything that you have. And the money that you would owe in taxes alone on just property is crazy. So what we got to do is we got to find the right entity to actually put these in. Once we put them in the right entity, then what we want to do is try and help you protect 98% of your safe assets. This is pretty wild when you think about what you have, because these are all the things: the money, the retirement accounts, cash, those types of things. But we also want to do it and give you the key to that safe, not let anybody else get in that safe. So how do we do it? Back in the early 1900s, there was an entity created, and it was called an FLP, a family limited partnership. Not known very well. Most people never used it, but it was set up to help the transfer of wealth from parents to children. The great thing about this is that it helped them so they didn't have a massive taxable event when that transfer was made. However, nobody was really using the FLP. And then in about 1960, the guy that actually started this company, he is known as the father of asset protection. And when he started this company, it was back in about 1960, he found this. These FLPs, he started to use these for his clients. He was an attorney, just a brilliant attorney. And what he started to do was figure out a way that he could protect them, 98% protection, and yet they still had access to everything. So the FLP is built this way, and I'm going to show you how this works. Family limited partnerships are very unique in the sense that, number one, you have limited partners. Now, the cool thing about it being a limited partner is that you cannot be sued in any state in the United States as a limited partner. Reason why: you have no control, you have no liability. So nobody can actually get at any access to anything for a limited partner. Could be yourself, your spouse, or your kids could be a limited partner. On the other hand, we are going to have what's called a general partner. Now, as a general partner, a little bit different, because they have 100% control and 100% liability. So everything would fall upon them if there was a lawsuit. Having said that, there are certain percentages that each have to have. It used to be the minimum that a general partner could own is 1%. It changed recently, and now it's 2%. So this could be yourself, your spouse, or even a business partner, but a general partner would have to have 2%. If you have a limited partner, obviously, they're going to have 98%. Now, here's the thing that's pretty crazy. If you think about it, $1 million, let's say, is in that, being protected. That means that if an attorney goes after your $1 million, most they could have access to is $20,000. Most attorneys are not going to do that. When they find this in discovery, they're going to go, "Oh, we're suing these guys. There's no money there to get." And so it stops lawsuits right there at that point. So what Jay did is that he started setting up all his clients with these FLPs. Because really the legal world hadn't really caught up to what was going on, he was getting taken to court all the time. First 12 clients he set up on FLPs, he got taken to court, lost in court, took it to the appeals court, and it was overturned. And on the 13th time, the same thing happened, but it didn't get overturned, so he took it to the Supreme Court. And he said, what do you think? Supreme Court, they actually ruled in a 9-0 vote that the FLP is an actual entity that should be allowed, and they backed it on a 9-0 vote. So we know that they are very, very protected. When I have people that come up to me and say, should I try and use an FLP? Is an FLP really good? Absolutely. You can't get any better than what that is as far as protecting your safe assets that we talked about earlier. So now we know that those will work. When this was passed, then what happened is the states, they always want to get their hands in things. And they said, well, we want to take part of this. We want to do something here. So they said, no longer can you be a general partner and a limited partner. Well, that's an easy fix because all we do now with our client, we actually create an entity, a management company. And who do you think can own the management company? You can. Here's what we would do though. We do this with our clients is we create a management company as an S Corp. An S Corp is the best way to do this, to be able to get tax deductions. Is there anybody in this room right now that you own your own practice or own your own business? Raise your hand, let me see. Okay, is there anybody in here that is a W-2 employee? Raise your hands, let me see. Okay, this works for both. Now, this S Corp is one of the ways that you can actually, if you've never taken advantage of the tax deductions that are out there. For instance, you hear people saying, well, my business, which is their only business really, and they're the only members of the business, my business paid for me to come out to this conference here, and they get tax deductions. Well, the same thing is true with you if you're a W-2. We can actually show you how to do that, and I'll talk about that in just a second. However, what we're trying to say right here is that this management company is going to be an S Corp. In most cases, you yourself can be the owner. You can have your spouse be an owner or a business partner of that. So in essence, you still are the general partner. It's just it has to go through this S Corp. Now, having said that, if you are a W-2 employee, I don't know if you've heard this before, but let me show you something that's kind of interesting when it comes to this. Has anybody ever heard about the farmers in America, how they work at a loss every year? The way it works is this. They have learned how to use the system so that they can show a loss on the books with the IRS, but they can buy a brand new truck every 2 years. They can buy brand new farm equipment worth $250,000, $1 million. And the reason why is because they have learned the system and how to use the system. So in essence, what this does, if we do this the proper way, which we do with our clients, is that we can set it up so that you can use the system. You can actually use what they put there on the books. And the way we do it is very simple. That is that as a W-2 employee, we can use that management company and show a loss on that management company. So if you are getting W-2 money right here, and this is the amount you're going to get after you paid all your taxes, you have an S Corp over here. Well, we can pay money from your W-2 money through the S Corp. When it goes through the S Corp, we can show a loss with the S Corp. That's not a problem. You can show a loss the rest of your life in that S Corp. But your loss with the S Corp is actually going to go against your tax that you owe with your W-2 money. So that means that instead of paying the amount of taxes you normally would pay, it decreases the amount of taxes, which increases the amount of money that you get by showing a loss with the S Corp. So this is what we do. My suggestion to you is whether you ever use us or not, doesn't matter. Anywhere you go, this is the best way to set it up. If you want to get those tax deductions you've heard of, and you've never been able to do it. And I'll show you some today, some tax deductions going to blow your mind. So safe assets, we know we go to the FLP to do that. Let's go ahead and talk about risky assets. Now, this is where people get in trouble. A lot of times what I hear is people will say, oh yeah, I'm all set. And I go, oh, you're all set. What do you mean? Well, I had an attorney set everything up for me. And I go, perfect. How's things set up? Well, I got an LLC and I put my house in it, put my cars in it, and we're all set. I got another business and it has my building in it and my equipment in it. And so we're all set. And I go, perfect. Well, I appreciate you thinking that you're all set. And I think you had intentions to do things the right way, but it was done wrong. And I'm going to break it down for you and show you why that is done wrong. Almost every client we get, things are done wrong. And it's because they don't have the same kind of expertise or ability to do things exactly the right way. And it's very easy for attorneys because they're trying to turn clientele so fast, they're trying to do things as quickly as they can. A lot of times they'll go through template bases to build things. So let me give you an idea of what we do when it comes to these risky assets. These are different assets that you might have, whether it's office, equipment, boat, home, firearms, cars, RVs, any of these types of things are risky assets because every one of these can create a lawsuit on their own. So what do? We got to protect these in a different format. Because they all can create a lawsuit, we don't want them together. If they're together, then there's a major problem because a judge can connect all these together. So what do? We separate them. Now, here's what we would suggest. Very simply, we're going to create entities for each one of these. The entity we use is called the Limited Liability Company, an LLC. Anybody ever heard of those? Who here has an LLC? Okay, Jay Minton, the brilliant attorney that started what we do, this company, back in about 1974, he saw the FLP, he started using the FLP with his clients. And then he said, you know, for these risky assets, we really need to have some kind of an entity that actually would be really good, but it needs to be more flexible than an FLP. So he got with 3 other attorneys, they went up to Wyoming and they said, let's create something. And they spent a few days together and they created the first LLC. Jay Minton is the father of asset protection, started the first LLC. Within 3 years, every state in the United States had some form of an LLC. Today, there are 100 countries that have a form of an LLC. And this is literally put together for one reason, and that is asset protection. So if somebody comes to me and says, John, I got an LLC and I'm able to tax this, this, and this, or taxes this, it's nothing to do with taxes. All these are for is asset protection. Now, can they be taxed? Sure. They can be taxed different ways. If you didn't create your own LLC, or even if you did, and you went to a template base for the state, you went to LegalZoom, you had your niece do it, who's an attorney, but she practices family law. She probably went on a state website and got a template to actually build it. But when they're doing that, there's defaults on them. The software they put together has defaults, and the default that it has is you're going to be taxed as a sole proprietor. Now, if you don't know yet, you can find out pretty easily, but if you're taxed as a sole proprietor, this is costing you probably about $10,000 a year in taxes because you don't want to be taxed as a sole proprietor. You can designate every year how you want to do it. It could be a partnership, an S Corp, a C Corp. There's reasons why you might want to change to those, but ultimately, this is how it is taxed, and you can change that every year. Now, the proper use of an LLC, pretty simple. If you have office equipment, if you have an office, multiple offices, if you have a home, if you have rental properties, maybe you got automobiles, you got toys, it doesn't matter. These are all risky assets. And here's what a lot of people do. Most of the people I talk to, they put all of these multiple risks in one entity. And if they're in one entity, like I said before, this can happen very seriously. Happens all the time. Maybe you have some problem with your office building and somebody gets hurt in that office building. Well, you're in jeopardy of losing that office. But because they're all in the same LLC, a judge will connect all these together. And when he connects them all together, then you're in very serious, right at the crosshairs of losing every one of those. Now you might think, well, I don't think that's going to happen. I get it. And I hope it never happens to anybody in this room. But I can tell you this, it's probably going to. And I can tell you this too. It surprises you when it happens because some of the people that actually sue you might be your own staff. But ultimately what you got to understand is that if you're protected, it doesn't matter. You can sleep every night and sleep very calmly every single night because you know that your assets are protected. Nobody can take anything from you. In this situation right here, it could be avoided very simply. Let me give you an idea. I just heard a court case just recently. Young lady goes into the office, gets treatment from the doctor. Treatment was fine. Signed off on it, paid, everything left. On the way out of the office, a gust of wind came up and hit the door. The door hit her, knocked her down. She was out of work for a little while. She got a personal injury attorney. The personal injury attorney actually got her into court and they sued the doctor. And if you and I were just talking on the side, just friends talking, both of us would go, there's no way she can sue this guy. The wind blew the door. It's not his fault. But she actually, as a plaintiff, she got awarded $5.14 million. Now, here's the crazy thing, is that in this case, and I didn't go into the entire case, but I can assume just from what I read that he wasn't protected properly. And I can assume from what I read that he probably wishes he was. Because first of all, his one insurance policy covered $1 million. And then what happened is he had a second insurance policy, which was a general liability for his office building. And that covered another $1 million. And then the judge, because of the state he was living in, and this is in almost every single state in the United States, particularly here in California. If you have an LLC right now and you think you're protected, you go into court, the first thing the judge will do is they're going to tear apart your LLC. They'll dissolve it right away. And then every asset that you have that's protected in that LLC immediately gets put back into your personal name. If it's in your personal name, the judge can take a hold of that and do whatever he wants to do. In California, and in almost every state, the judge can actually take control of the entire LLC, take care of the financial things within that LLC. So in this case, the judge actually took all of everything that he owned and he put it up for auction, sold it, and then took all the money and awarded that to the plaintiff. And then he still owed $1 million after his whole life was turned upside down for something he didn't even do. But at that point, what happened is the judge was able to garnish his wages and said, you can make X amount the rest of this year and all the rest of the years until this is paid off with this plaintiff. And that was the judgment. Now, this is the problem. And this is something that everybody's susceptible to. And when I have somebody come up to me outside and they go, I wish I had seen you a month ago. I wish I had seen you a year ago. Or help me right now. I'm just saying that it might never happen to you. I hope it never does. But I'm telling you right now, if you don't want to work with us, you got to work with somebody and get protected. Because this industry is truly the most suited industry out there. Let me show you an idea of what we do very simply with our clients that we have, is we would take every one of these entities and we're going to put them in a separate one. And then once we put them in a separate one, if something happens with one, it stays within that. And that's only if they actually go to a lawsuit on this. But there's other things we do to even help you with that. So this is the proper way to use an LLC. Now, true asset protection. Again, like I'm telling you, and I've told you before, no matter who you have help you out with your asset protection, if they don't talk about a holding company, they have no clue what they're talking about. Every asset protection firm in the United States that handles clients worth $100 million or more, they're all going to talk about holding companies because it's the same thing that multi-billion-dollar companies do. In fact, some in this room have probably heard of a company that does this. They have a holding company, they have their LLCs underneath the holding company, true asset protection. Some of you have probably heard of Disney. Well, the way it works with Disney is very simple. They have rides at Disneyland. And you might have heard of things like the Matterhorn. That's one of the rides. If you went to Disney and you went and ride on the Matterhorn, when you're riding on that ride, it's a high-speed roller coaster, and you might be leaning one way, and the roller coaster hits another way and jerks your back, and you get off, and you're like, oh, I can't walk. My back's killing me. I'm going to sue them. Last week, I was speaking out in Florida, and I had a lady come up to me afterwards. She said, my daughter was down there at Disney World, and she was on one of the rides, and she leaned one way, and something hit her, and it broke her arm. And she wanted to sue Disney. But here's the problem. Disney has trillions of dollars. So they have a lot of attorneys, and they spend a lot of money to figure out the best way to do this. And here's what they've done, is they take every one of their rides, and they create an LLC for every single ride.
Wow.
Now, because everyone has an LLC, what happens is the law says if that LLC is not making money, if it's more of a dormant LLC, it's holding something, there's no money being exchanged, then you can't sue it. So for instance, when you get on the Matterhorn, how much do you pay the attendant when you sit down on the roller coaster? Nothing. That's the way it works. So you cannot do that. Every ride has it. You might think they're the only ones. Everybody does this, again, that knows about asset protection. You heard of Walmart. They have a parking lot and they have a store. Of those two, what do you think creates the most lawsuits?
Parking.
Parking lot does. And what do you think Walmart did with every single parking lot?
LLC for everyone.
Each one has its own LLC.
Wow.
Every single Walmart parking lot has its own LLC. How much do you pay to park at Walmart?
Ha.
Zero.
Zero.
So you got nothing you can go after with Walmart. That's the way that they set these things up. That's why we mirror exactly what they do. But we're not working with Walmart. We're not working with $100 million clients. You're our wheelhouse. You're our specialty. You're who we work with. We've been doing it for 15 years. Do you realize that in the 15 years we've been working with the medical profession, we have right now just over 14,000 clients, and we have never had one client lose a nickel in a lawsuit with anything we've set them up with. And I would say that's pretty good. Would you agree? So we feel like we know we're the experts. We feel like we can help people. It's just that now we have the opportunity to share with you what you can do. Or like I said, if you wanted us to help you, we'd be glad to do that. But I get a lot of people that say, why haven't I been told this? Why hasn't my accountant told me about this stuff? Why hasn't my attorney told me about this stuff? Most of the time, again, it's not that it's bad intention. It's just that some people just don't know. Some people, especially that aren't in law, don't know what they don't know. So let's show you how we can fix a few things and change things. The holding company is super important. And the reason why it's so important is because the legislation has changed in the United States in the last 20 years, drastically changed. It's different than it's ever been. And I can tell you this, that there's 49 states right now that a holding company is not necessarily the best one to be in. In fact, there's one that is the best. But here's what can happen in the state of California and in most states within the United States. A judge can take control of your company, the LLC. They can dissolve the LLC, take all the assets, put it in your name, and award that to the plaintiff. The judge can seize assets right out of the LLC. So in most states, this will happen. Most states, this could happen where they can seize assets right out of it. So if you have one LLC and you have your home in there and you have your cars in there, the judge can just pick and choose anything out of that and pick and choose what he wants to put up for auction and then award the money to the plaintiff. Or the judge can actually foreclose on a membership just as though it was a piece of land. And when they foreclose on the membership, they give the membership to the plaintiff, and the plaintiff now owns everything within that LLC. This is in almost every state that's out there. So all I'm saying is that why not figure out how to be protected and get somebody to help you? But there is a weak charging order in most of these states. Now, here's the reason why this becomes so important. Because a strong charging order, the strongest one is in Alaska. So what we do with our clients, and with myself included, is that we create these holding companies in Alaska. Now, you don't ever have to go to Alaska, because we can create one in Alaska, and then we can actually use wherever you live, and we would put the LLCs or whatever you have underneath that holding company in Alaska. So, having said that, because none of these fall into play in Alaska, because they do have a very strong charging order, let me show you how powerful this really is. The charging order is passed in each individual state, which gave the judge the right to force a distribution of the defendant's share of income to the plaintiff, just like I had mentioned with that case that I cited a little bit earlier. This is a major problem. However, this can be fixed. Here's the thing. This is what I call a trial attorney's deceit. Trial attorneys have a tendency to spin things whichever way they want, but you can also understand that trial attorneys and all attorneys, what they do is they leave loopholes into different types of things like LLCs, so they know how to get in there and break into it if they need to. Most people don't know that stuff. But with this right here, if you have an LLC right now, I can promise you, we see about 3,000 new entities a year from clients that we take on board with us. And out of those 3,000 entities we review, 100% of them are written wrong. They have some verbiage in it that's wrong. Let me give you one example, and this is one of mine that I promise you everyone here. Your LLC, if you have one, there's a pretty good chance that it's not worth its weight that it's written on, or the paper it's written on. It's a pro rata distribution clause. This is one. Let me show you how this works. This actually gives the judge financial control of the entity, allows the judge to distribute funds and garnish wages and give them to the plaintiff. So let's use as an example. Let's just say, what's your name?
Annette Davis Jackson.
Annette? Okay. So we have Annette, and what's your name?
So.
Suha? Suha's gonna sue Annette for $1 million. Now, I'm the judge in this case. So because of that, you want $1 million, right?
Sure.
Suha wants $1 million. Annette, you want to hear what we need. Alan, really want to go?
They don't need you. They don't need you.
And so in that case, if she is not set up properly, and I'm the judge, and I look at that case and I award actually the plaintiff wins in that, so I award her $1 million. My job is to get into Annette's pockets and take $1 million from her and give it to her. However, I gotta do that. The situation here, though, is that I can actually take control of your entity and I can actually garnish the funds that you are getting in there. And if you're making, say, $50,000 a month, I can say, well, now you're only gonna make $6,000 a month, and all the rest of the money you make, you have to give to her until she's paid up $1 million. Still on side on this. Now, let's take a step back and let's see if there's something we can do to protect on something like that. So in this case, if we actually went with Annette and talked to her and said, here's how you can be protected. Here's what you need to have somebody do for you. And as we go through that, we find that in her LLC that they have the wrong verbiage. So we would change it and amend it to what we call a non-pro rata distribution clause. Now, just that little change right there means that effectively that's gonna block me, the judge in this situation. So I can't do anything because it stipulates that only the general partner, Annette, can actually make a distribution or make a payment. And all that means is this: if she doesn't make a payment to anybody, I can't take a hold of any of the money that's in that LLC and award it to the plaintiff. Does that make sense? So are you ever gonna make a payment again? Never gonna make a payment again. Now, she's working, she wants money, but she just doesn't make a distribution again. She could make a distribution to her spouse. She could take down a no interest loan from her company, because you know the owner, who isn't, right? So she's gonna approve her own loan to herself with a no interest loan. She could do those every month if she wanted to. Doesn't matter, because she never expects to pay that back, and the company's never gonna come after her in a collection thing. So there's ways that she can still pay herself, but what that does is it changes and it blocks me. So now because of that, even though I awarded you the $1 million, you're never getting a dime. Does that make you sad? Well, guess what? It's actually gonna get worse for you. Because in this situation, what actually happens is, in the United States, there's this organization called the IRS. And what the IRS does, they want their hands in everything. And so what they do in this situation, if she wins $1 million, they want a part of that. But they found out that because of this situation I just described to you, she never makes a distribution to herself. She's never gonna get a dime, so the IRS never gets a dime of that. And they said, we don't like that. So they went to Congress and said, here's a bunch of money. If you'll change the rules and the laws so that there's a way we can still get money, we'll be happy. They gave them a bunch of money, they lobbied them, and then IRS said, 77-137, IRS ruling, so here's the way it works now, same scenario. She doesn't get a dime because she's never making a distribution. You still won $1 million. IRS says because you won $1 million, you still have to pay taxes on $1 million. Even though you're not getting a dime.
Play the video and present it.
Is that what happens if you're not protected, if you don't have to do this the right way, then you're susceptible to these types of things. What we're saying is that if it's done properly, no lawsuit wrap this up real quick, and let me do this. Let me just show you how we do what we do. So if you go to a regular attorney and have them do any of the things I just talked about, attorneys, the way they work is they say, you want us to build something for you, an LLC, an S corp or anything, we're gonna charge you this amount to do it. You want us to build a living trust, it's gonna be this amount. If they're gonna do legal work for you, like amend things for you, they charge you per hour. I mean, they can get very expensive, obviously. Here's some of the averages that I've seen across the country. They're skewed in some states, like in New York, I have people tell me all the time, I had a living trust fund, it was 15,000, 20,000, whatever the case is. California, doesn't matter, it gets expensive too. But if you were to do just one of these different things here, you can see it could be very expensive, $25,000 to $50,000. Now, when we come to an area like this, we come in here to teach you, come in to share this information with you. We like to do something nice for you because for us, the marketing dollars, it's better for us to speak to a large group than to do one-on-ones. So what we do is a little bit different. It's not what you normally would pay attorneys. The whole system is totally different for us. We figured out a way to make it work for us and for you. And the best thing we could possibly do is be focused on what's going to work for you the best and help you. So here's what we do. Living trust, it's not just one. The way we set this up, we create unlimited living trust for our clients. Unlimited family limited partnerships, unlimited LLCs, holding companies, modified verbiage, unlimited amount. Never changes. We can do that. Registered agent for you. And the way we do it is instead of a lot of money to do that, it's a one-time investment. Now, the investment is a lot less than you would pay normally, $13,400. If you were to come off the street, that's what the investment is. However, at this conference here, we do it totally different for you because we actually reduce that by $5,000. So the total investment to get into our program is $8,400. That's it, one time. Now, what we're going to do for you, in my opinion, is very amazing. Because like I said, we're going to build any of these you want in the future, as many as you want. So let me break down the 8,400 for you. Real simply, if you took 6,000 of the 8,400, that's the one-time investment to become a member of ours. And once you're a client of ours, it's a lifetime deal. I mean, as long as you're out there, we're going to be working with you. We have clients we've worked with for over 15 years. However, what we will do for you also is we have unlimited entity creation. So right now, we'll review anything that you already have created, make sure the verbiage is done correctly. If we have to make amendments, we'll do that for you. If anybody here is practicing in California, there's a lot of things we need to do specifically to tighten things up for you because we're very well versed in California. But at the end of the day, it is a one-time investment. That's it. Now, aside from that, the other 2,400 of the 8,400, that's a monthly fee. And the monthly fee is very powerful because of the things we're going to do. Understand that this is all a tax deduction, but this is the one time, and this, the first year, it's already covered. Everything's covered the first year. Now, after the first year, if you decided that you needed our services, you want us to keep helping you with everything, excuse me, you can turn that off if you want to, or keep it going. It's your choice. So first year, 8,400 covers everything. After the first year, put it on hold. If you decide after a year or two, you know what, I need to use their services again, then I'm going to turn it back on. And the services are it's simple to understand. We're the ones that are going to write your minutes for you. We're the ones that are going to fill out your forms for you. We're the ones that are going to teach your accountants how to do these things. You will have an estate attorney really on retainer that you can call anytime you want. They can answer your questions. Our main focus is to build this so that you have everything set in place where you have the asset protection you need for everything that you possibly have, safe and risky assets. And then we also work with the estate planning, and then we work with getting you all the possible tax deductions that are possible. We do all of that for you. We build it in a blueprint, and then we present it to you and say, okay, here's what we feel is going to be the best for you. And when we do that, we set it up legally so that you're all set with everything that we have. I want you to be aware of that because that's how we do things for you. But again, like I said, after the first year, if you want to turn off that monthly deal, you can turn it off if you want to. Most people like to use it. We also do a tax savings guarantee. And this just becomes a no-brainer. You probably know that you're going to pay that money to the IRS anyways, $8,400. They're not going to give you a single thing for it. However, if you were to take that same amount of money, invest in yourself, invest in what we can do for you, then what's going to happen is that we guarantee it the first year, we're going to get you all your money back. And if we didn't get you the $8,400 back, we cut you a check for the balance of whatever it is. We're very confident in our ability to help you. So that's what we have as a guarantee. Now, while I'm here today, pretty simple. We're going to help you out, answer any questions. We'll be out there at the table tomorrow. We're going to be out there at the table too. Anytime you want, come by and talk to me. If you got a certain situation you want to talk about, we can talk about it. but we treat every single client we have separately because their whole life is totally different. Once we create this, it becomes organic and moves with whichever way you need to move to. And that's the way we set up the program. Now, by the way, if anybody wants, you can text AHCS5. I know that they're streaming this or they're videotaping this. And if you were to get this number right here, 385-325-7644 and text AHCS5, you can get a hold of our office, talk to them, see what they can do for you. But while we're here today and tomorrow, you do get the $5,000 reduction and you get the full guarantee that we're going to get you all your money back. Okay. All right. Now that you understand that, thanks for your time. Did you enjoy everything?
Thank you.
Okay, good. Thank you very much. If you, again, anytime you have any questions, come on back. That's really what we had to say. Those that did fill out a card, those 288Gs, my wife will come by and grab those. You can set them on our table out there and we'll get those from you. Thank you for your time.
Thank you.
Oh, okay. You want me to come over there and get it from you? Oh, okay. Photo op. Okay.
Yes. Okay, you can use this one also. Or do you have a power bank? Oh, this is
This isn't insurance. This is strictly a plan so that you can get access. That's what it's for. So the requirements are such that if you meet the requirements that you need. Yeah, now I do. We need a light bouncers. I've been warm. I didn't make that. By yourself. All right.
Yeah.
Good afternoon, everyone.
There you go. Yeah.
Good afternoon, everyone. Hope everybody really energized for the talk that we had from John Lemon regarding saving strategy for Delegates. Next, our speaker for the day is
Excellent.
Professor Frank Scinnamo from USA. He's here to deliver his speech on if laughter is the best medicine, why not try it as a medicine? He's the founder and chief creator of Laugh MD.
All right, hooray. All right, everybody. I really thank you for coming here and for staying. I know this has been a long day so far, so I'm going to do my best to keep it light and to entertain you. I have flyers to hand out. I have a lot of thanks to all the medical staff here. I'm not in medicine. I was an academic, and before that, I was a filmmaker. And so for me, this is so thrilling. It's so exciting and interesting to be in a room with all these people who are so smart and know so much about medicine. So I'm really grateful for that. It's really exciting. I've taught at USC, I've taught at UCLA. This is my doctor, by the way, Dr. Morris. I don't have a lot of faith in him. The only thing he ever prescribes is a CAT scan. So I especially love two things, comedy and technology. So there's me also attempting poorly stand-up comedy, and this is me testing my shrink ray. So got the tech thing covered there. I also loved a few other things in my life. One is my dad, Joe Chindamo. The other is my stepfather, Bill Harrison, and then my youngest brother. And all of them died in hospitals. So hospitals are especially tragic for me. And speaking of tragedy, that's how TV works. All television, indeed, all entertainment rely on the age-old formats of comedy and tragedy, or as it's called in modern times, drama. The principal techniques are dramatic tension or comic relief. So do you want tension or do you want relief for your patients? Here's what they're playing on hospital TVs right now. I asked the docs at the hospitals my family died in if I could do anything to lighten the mood. I'd heard that laughter is the best medicine, and I was making comedy films, but that's not what they were playing. I mean, here's what they were playing on the hospital TVs. These are all clips from network TV and cable TV shows, and I'm going to give you a trigger warning here. When this gets too gross, just one person raise your hand, and I will stop it when one person raises their hand. But this is what was playing on hospital TVs. Obviously, this part will get cut out of the video. Okay, this is actually on hospital TVs, okay?
Someone in a hospital, most patients spend most of their awake time watching TV. The problem is that television has gotten so sexual, violent, basically anxiety provoking, exactly the opposite of what we want for our patients to heal. This is what they're watching.
So
You don't have to shoot them in the head. But warning, they may shoot you.
A bad day, long time.
just raise your hand when you've had enough. Done. Great. I hate it too, but that's what they were playing on hospital TVs, right? So raise your hand if you really thoroughly enjoyed that. Nobody, right? Okay, so I need your help again. We're pausing the roll here. Do that thing. Yes. You would think I would know what to say. I've rehearsed this 65 times. So we gave them this. Kaiser Permanente was the first hospital to actually air a comedy channel on their TVs. And yes, very appropriately, they advertised it in the bathrooms. That's why it's called stall humor. So talk about bathroom humor. There you have it. So the question is, which do you prefer, drama or comedy? Well, let's ask these parents. Which one made you feel better? So you're in good company. Did I skip over the funny babies? Oh, come on now. You got to see the funny babies. Let me play that.
On every vacation, I would love to do someone like you. Reunited fellow.
Man, what are you doing?
It's not like you have to trust that there's a hilarious baby on the screen here now. You said this would work. Remember? Okay, that's drama. Play it again, Sam. Okay. He's getting ready for a shredding party. Okay, that's drama. Very dramatic. Next one. Yes. Okay, this one's comedy. Let's play that one again. Hold on. So there's a drama and comedy all rolled into one. All right, so you just watched a drama video with the heroine and the girl fights, and you watched a comedy video, and which one made you feel better? The laughing babies, right? Well, we thought so, and you're in good company. So there's a ton, I need the speaker notes again. So there's a ton of evidence that proves this. Loma Linda University, University of Southern Florida, College of Family Physicians of Canada, National Institute of Health. I'm going to show you my favorite one, which is this one. This was done by Lee Burke over at Loma Linda University. And here's what they did. They took 48 patients. No, the speaker notes. They took 48 patients who had had heart attacks, right? Of those 48 patients, they had a control group who did not watch half an hour of comedy a day. And they had the test group who watched half an hour of comedy a day. At the end of 60 days, of the patients who watched half an hour of comedy a day, 2 of them out of the 24 had a second heart attack. Of the patients who did not watch comedy, 10 of them had a second heart attack. That's how powerful the difference was with just that one variable. So that's one of my favorite ones. And there are 500 studies that show that laughter is actually good medicine. In fact, we've done 4 of them with LaughMD. And in this one, because I was a professor at USC and now work with them on the idea of using this laughter app, the question was, does viewing comedy videos improve the patient experience? So the patients were asked questions like, did you enjoy the videos? Did you, if you had pain, did the videos help to lower your pain? And things like that, right? Well, here's the study results. You can see everything is pretty close to 100% positive. And even this one, where when you take out the patients who didn't have pain, 91% of the patients with pain said it lowered their pain. Now raise your hand if you're surprised. See, nobody is surprised by that. So again, I ask the question, if laughter is the best medicine, why don't we use it as medicine? I mean, 91%, that's better than aspirin or Tylenol or even pot brownies, he said from experience. So these are the 4 studies that we did. You can read them for yourself. But for healthcare providers at the USC Institute for Genetic Medicine, 94% of the healthcare providers we tested reported a reduction in stress levels after 60 minutes of comedy. Okay, who's got an hour to do this with? Nobody, right? So Chapman University, in 3 minutes, we were able to lower 30 healthcare providers over 30 days, an average of 13% less stressed in just 3 minutes. Now everybody gets a 3-minute break, right? So one of those little baby videos or one of these little silly cat videos will do the trick if they are collated and curated and delivered to you properly. So this was Chapman University putting it on the front page of their website for a week. And these were at UCLA, the staff voted unanimously to use LaughMD. And some of the staff comments include, "This is amazing. Thank you for putting this together. And we love the concept in the app." And this was only nurses voting, 18-0. This is a snapshot going way back to the very first American Healthcare Summit, just before they made this discovery. That would get a bigger laugh in caveman times. So if you're here at this session and you have continued to listen, you know that only early adopters are going to do this. Only real innovators are going to actually try this, right? So I thank you for being early adopters, and here's some scientific facts. Did you know that early adopters are scientifically proven to be smarter, taller, and far better looking? And that's you people. You can't argue with science. So why do this in hospitals, in dialysis centers, in cancer or drug and alcohol recovery facilities? Well, these are the benefits of humor for your patients. And I know you know this. I'm not going to read this to you because you know this innately. It's increasing your endorphins, your serotonin, your dopamine. It's lowering your stress hormones like cortisol and adrenaline. And so because of that, it's a natural fit for the healing environment. That horrible video I showed you is what they're actually showing on TVs, and yet they're not doing this. By the way, that's me before coffee in the morning. So, and yes, this is HIPAA compliant, and yes, this is enhancing benefits for the patients. But this is the benefit for you. So here's the staff at USC using this app, right? And so you're happier. We've talked a lot about staff burnout. We've talked a lot about nurses leaving. We've talked a lot about stress at the workplace. And what do you do to combat stress? You try to laugh. You can't be stressed and laughing at the same time. It's physically impossible, right? So it not only makes you feel better, when you apply it to yourself and the patients, it makes it easier for them to comply with things. It makes it easier for them to understand directions. We collect data as well. It's not just funny videos. We're also collecting data from patients in a HIPAA compliant manner, of course. And these are the benefits when you go back to your administrators. There's a lot of benefits that you can pitch to your administrators, especially my favorite one, which is LaughMD can pay for itself by collecting applicable, billable information for insurance companies. Make them pay, right? So here's how to do this at your facility. Well, rule number one, don't use Comedy Central on the TVs. Comedy Central is a comedy television network here in the States on cable TV. Most cable television and pretty much all network television, and I know because I work in television, we're now down to about 16 minutes of actual programming and 14 minutes of commercials, credits, and network promotions. So only about half of the time are you actually getting anything that might even be funny. And trust me, Comedy Central is not appropriate for a hospital setting. It's also not positive humor. It's mostly negative humor, insult humor, the kind of thing that doesn't produce those same biological reactions. So don't just do that. Here's why you don't want to just watch comedy on YouTube or TV, because YouTube, especially, the videos can be unvetted. And so you might find a funny video the first time you watch, but then the second video that you get recommended, maybe that's not as funny or not as interesting to you. The next video, I don't know what that is. And by the fourth video, you've joined Al-Qaeda. I don't know how that happens. So we're using positively based humor. Here's just one example of a channel that used to be very funny that was on YouTube. And it was this kind of hippy dippy guy that talked about, what if meat eaters acted like vegans, right? And within a year, he became radicalized. And here's his video called Why We Need More Guns. And it's not a joke. So much of this is happening that you actually need human beings to curate this. You need real people who understand comedy, who are expert in the field, and real people who are good at the data collection part of it as well. So we're a simple, affordable app providing the healing benefits of humor for patients, staff, and a facility's bottom line with data collection for improving outcomes. Here's what's on LaughMD. Little comedy videos, all of it. I'm not going to bother to play the video. Just come up to me and see me, because guess what? I will give this to you for free. Yes, this is a business, and yes, we do want to make money with this, and yes, we intend to charge the insurance companies and or the facilities, but in the beginning, this is free. So there's literally no reason not to do it. These are the kind of videos that we have on there. Yes, that's a cat in the toilet. And we even have a version of it for recovery patients. So our specialties right now, like at USC or like at C-Care, where we're dealing with oncology patients, because you're a captive audience, you're tied to the chair, right? You're in an IV situation. Or bedridden patients in a hospital. Again, you're a captive audience there. You have to stay there. So oncology, dialysis is another one. Those are our best ones. But even in recovery, this is a product we have called LaughMD Recovery. Even in recovery, they take away your phone. You know this, they take away your tablet, right? And imagine if you could be given a different tablet that gives you funny videos, gives you activities that you can do that will improve your healing. So if I was an addict, it would be really hard to kick whatever substance I was on. It would be, for me, even harder to give up my phone. So imagine that, how we're double challenging these poor folks, but now we have a remedy for that. So there you have it. So let's benefit you, your staff, and your facility with LaughMD. I'm Professor Frank Chindamo. I'm ready for questions as they hand out the little pamphlets on this. Thanks very much. I tried to make it the shortest presentation of the day, by the way, because they were only short films.
Any questions for Professor?
Thank you for that talk, Professor. It was very enlightening to actually see what laughter can really do. I mean, 90% efficacy, I don't think any medicine can also speak about. My question regarding is how you exactly are able to monetize this. When you're saying that the insurance companies are going to pay for it, what exactly are they getting?
So what we're researching at this moment are the CPT codes that will work for this. And to be honest with you, we're not exactly sure yet. I started this company over 10 years ago, and it's a developing, evolving company. And it's been very, very, very hard to penetrate the medical system, but eventually we're going to get it. So we'll be finding out.
The follow-on question, is this app like ready to be downloaded on Android and iPhone for anyone, or you are making this for the facilities or any institutions that are interested?
I can give it to anybody here. However, the idea is that it's not for the general public. It's only to be used in medical settings. It's very expensive to employ a staff of people who are collating and curating the videos and then doing the programming and all that sort of a thing. It's not cheap. So this isn't something that you're going to find in the App Store. You won't find this in the App Store. Don't bother looking. It's hidden in there. It's something called the Enterprise Store, and it's intended for use as medicine. Yeah.
I definitely, appreciate the work that you guys have done, and I understand that it's expensive and, everything is evolving and it's fantastic. I really would like to commend you on this work.
Thank you.
My question is, you have seen it working in this environment. Do you have any thoughts on reaching out internationally?
Oh, yes, absolutely. We'd love to. That would be great. Yes. Not yet. It's a little bit more complicated because a lot of the videos come from YouTube or Vimeo or Vine, as you see here. So it's a little bit more complicated to do that, but it's definitely on the roadway. In fact, speaking of the roadway for this, the roadmap for this, right now, a patient holds an iPad and they select the videos that they want, and they also hold the iPad and they answer the question. So that's self-reporting, right? Soon, with a little bit of funding, we're going to be able to integrate with wearable devices. So you'll actually be able to tell from the device what the patient's heart rate was when they started watching, what the patient's heart rate was when they stopped, and other vitals. We're also in talks with a company called Bina in Israel, and they have an even more sophisticated thing where if you are looking at an iPad, well, there's a camera that's looking at you. It's the thing you do selfies with, right? Well, they can actually determine a lot of your, what's that? Micro expressions, exactly, exactly. So they can tell more than that. They can tell blood oxygenation level, heart rate, things like that with just the camera on your device. But it takes over a minute to gather that data. So how do you get somebody to look at a device for over a minute? Show them a video, right? And then we're also working to try and put this not just on these devices, but actually into a virtual reality environment. And I work in VR quite a bit. And so just imagine, you know, it's nice to have it on your handheld device, but when you're in a virtual environment, you can actually be in a comedy club, or you can be at a zoo with funny animals, or you can be at a party, for example, then that's going to be something where I've actually heard of one situation at USC where they're using that instead of anesthesia for children.
He's going far, and I really wish you were very good.
Thank you very much. I'll give you my mom's phone number. One more question.
Thank you so much for your information. It's great. I think this will also be perfect for maybe for a therapy session. Talk to someone. You have someone like you. Or...
We're actually talking. Yeah, we're in talks with a company called Headspace that you know as a meditation app on your phone, but they've come up with this brilliant idea that maybe laughter should be used as medicine, and they found me. So we're talking with them. I hope that goes through. Yes.
I don't have a question, but I'd just like to have a comment. Just to say that you are absolutely on target with what you're doing. And just to say that there was one doctor who had a client who had a medical issue. And when he came in, what he recommended him do is to go home and every evening watch something that was fun. And when he came back to his doctor, his symptoms were gone.
Wow. Well, God bless it. There's about 500 studies that are out there, and they're from everywhere. Iran, from Korea, from the UK, Canada, South Africa, plenty of them in the US, of course, Canada. There are studies done all around the world. It's a universal principle. Not everyone agrees that the earth rotates around the sun, but everyone agrees that laughter is the best medicine. All right, thank you very much.
Thank you, Professor, for sharing your wonderful story.
Oh, one more question. Okay.
For your presentation. My question is, does laughter therapy differ according to the patient condition? Is it standard for all private patients?
So this is not laughter therapy. Laughter therapy, as we know it, is laughter yoga, where you're trying to make yourself laugh. I know that's very popular in India. We have a laughter yoga instructor on the app himself. His name is Renga, and his series is called Ranga Laugh. So we actually do provide that. But the studies of genuine laughter versus artificially induced laughter, like laughter yoga, it's a night and day difference. I'm sorry to say. Making yourself laugh is nice, but it doesn't do what genuinely inspired laughter does. There's things about how it triggers neural impulses, how it goes down the neural pathways in a different way, and all that. So sorry, we can't put comedians out of work just yet.
So I think you are triggering mood change.
Mm-hmm.
Yeah.
Yes, I'm very scared right now. All right.
Wonderful, Professor. Thank you for sharing your story. Really appreciate it.
Thank you very much. I can't not do this, right?
We do have some certificates for you, Professor.
Oh, thanks. No, come over here. I'm tied up on a microphone here. Yeah.
Sitting for the background. You're able to come out from behind the podium.
Sure.
Let's get it here. Or your presentation.
Oh, great. Thank you very much.
Okay. Yeah, that's a for being a chair.
Oh, right. Thanks.
And let's have you by yourself on the.
Okay, great.
Like separately. It's like C-bone.
Oh.
All right. One vertical, one horizontal. Hold them down a little. There we go.
Our next speaker today is actually, we are going to have a workshop by Ms. Karen D. Walker from USA, who is the President and CEO of NLA International, that is Nursing Leadership Academy International.
And I guess I'll just, sure.
Thank you so much. Impressed with what you said before.
Oh, gosh.
Oh, and if you haven't seen it, Dr. Patch Adams and us released that press release, and they're on the tables outside.
Presentation. Oh, I just used this extracting. Oh, this one is okay. No, just keep it on it. And how can I? It's over here, up here. You can use this one. Okay, that's fine. Yeah.
Good afternoon, everyone, and thank you for joining this session. Professor Frank and I have been given the daunting task to follow up with presentations after lunch. So I don't know who to blame for that, but. Today's topic and my workshop is the nurse leader in a new era of healthcare. I'd like to first start off by talking about the national healthcare expenditure. Certainly, we've been really busy over the last 2 or 3 years with COVID and healthcare spending, et cetera. However, within the next 6 years or so, it is expected that healthcare spending is going to consume about 20% of our GDP, gross domestic product. And that's really, really alarming because the health spending equals utilization rates plus the price. And certainly utilization rates are the amount or the types of services that are being charged per capita. And then the price is how much the cost of those services that are being charged. So certainly there's a lot that will be coming forth after the COVID aftermath. However, if you look at Peter J. Peterson's research, you can see here that certainly the red bar, graph bar, is the United States, and the other bars, the gray bars, are other countries, and the blue bar there is represented by the average. The average is the other countries excluding the United States. And so the United States actually is spending about $12,000, a little bit over $12,000 per capita. And remember, healthcare spending is the utilization plus the price. So that's really, really alarming. And as I dove a little bit more into the research on this, I found that the utilization rates really didn't differ a whole lot from other wealthy countries. But what I found is that what was really driving up the healthcare spending was the price, the amount charged per service. And I thought, gosh, well, healthcare spending is really not a big thing. I mean, it's not really bad to spend a lot for healthcare if you have really great healthcare outcomes. However, as I looked more into research, I found that the United States, if you're looking at healthcare quality and healthcare outcomes, we actually score less in life expectancy, infant mortality, as well as unmanaged diabetes. And I thought, gosh, so what's going on here? I found that diving a little bit more into price, if you look at this bar graph on the right-hand side, the same principles apply. The red bar is represented by the United States. We're spending so much money on administrative costs. That's because our systems are just not doing very well at all as it relates to efficiencies of care. It's just, we're pouring a lot into administrative costs where we could really look at trying to correct those inefficiencies. And certainly healthcare, as you guys know, with the presidential debates, right? That's always the hot topic of discussion. But this is really impressive, really, really impressive data that we're spending, United States is spending almost twice as much on administrative costs compared to other countries. And then of course, less in long-term care. Now I'm going to talk a little bit about the impact on the impact that COVID-19 has had on healthcare. If you look here, what happened in 2020, first quarter of 2020, I think I came to California from Chicago, Illinois, around the mid of 2019, we had the great lockdown, and that set fear and panic in everyone. Then people started getting laid off from work. You have people working from home, sedentary lifestyles, people consuming comfort foods and sitting on their couches, divorce rates through the roof, Peloton stock going up. Patients are afraid to go out to the hospitals. And so you have self-cancellation of appointments. There were doctors' offices closed. They didn't want to accept patients in. I work in cardiology. I oversee cardiology at County in San Jose. And we found a lot that certainly not only were the appointments postponed, but elective surgery, which I think someone alluded to earlier, elective surgeries were canceled or postponed. A lot of the units were converted to COVID units. And so the PACUs, where the patients are going after surgery, as well as the holding areas for the cardiac cath labs, were converted to those for patients who were kind of stepped down out of ICU, who did not have COVID. And so 80 to 90% of the ADC in the hospitals were C positives or COVID positive patients. The infrastructure was really overburdened, right? You have clinicians, whether providers or MLPs, burnt out. You had, early retirements. Then you had baby boomers. People were asking the baby boomers to come back, the ones who had retired, to kind of help out. Certainly, Then you have the demand for RNs and physicians. Everybody's running across town, whoever's paying the most, just to try to help out. Hotel conversions. The Marriott converted to hotels for COVID. So that the workforce, instead of going home, they would go to these hotels. Amazing. Hospital closures. For the year 2022, there's been already 22 hospitals that have been closed bankrupt. Amazing, amazing, amazing facts. Not only did it hit in the directly with the healthcare, but it also hit the entire ecosystem for the healthcare. Looking at healthcare providers, we talked a little bit about that. The distributors, I'm still waiting on supplies coming from, wherever. Delay in products that we've ordered. GPOs, looking at Premier and Vizient, collaborating. Government regulators. Of course, the volume to value was kind of put on hold during those years of COVID because of COVID. So they weren't really looking at volume to value. Looking at life science and big pharma, everything was disrupted. The payers just disruption going on throughout the entire ecosystem, healthcare ecosystem. So not only was that going on, but you also saw an increase in your baby boomers and those who are entering the senior years. And again, my specialty is cardiology, and we really have evolved with cardiology and looking at, instead of having complete open heart surgery, you're looking at going minimally invasive for aortic valve surgery. And so the patients that we see are in their 70s or 80s, but that's really your true 60s. So I think people are being more and more savvy as it relates to preventative care. So that's why you see the yellow bars are representative of those octogenarians, and the orange bars are your nonagenarians. And you can see by the year 2030, the population for octogenarians will be almost at 20%. And these are not going to be people that are on wheelchairs or just kind of hobbling around. Because I expect to really be, booming and thriving at 80. But you can see the US population will nearly triple between the years 2010 and 2050. Lots of opportunity, guys, lots of opportunity. And not only will the age of the population triple, but there's also going to be a shortage of healthcare providers, from physicians to nurses. In fact, within the next 3 years, the US Department of Health and Human Services predicts that there's going to be a nationwide shortage or gap of about 100,000 physicians. And 2 million nurses shortage, that's huge. So you got the shortage in the clinical providers, and you got people growing older and very viable, right? So how are we going to bridge that gap? Why did the clinicians leave? Burnout, stress out, all of this documentation, right? In 2008, you guys remember the meaningful use, where you had to comply within the next 10 years. They gave you 10 years to comply to EMRs. So the 3 major electronic medical records, Epic, Cerner, and Meditech. 3 big repositories. That's all that they are. So what are we going to do with all this data that's already collected in these repositories? Certainly can be very, very helpful, not only in the hospital, but outside of the hospital. How can we draw our clinicians and our nurses and physicians back into the healthcare field? I'm a baby boomer. What excites me is innovation. So do you think that we can capture them by introducing innovation into the healthcare arena? I think so. Some people like to think COVID is on the downslope. So we're getting ready to go back to business as usual. No, we can't. We can't. So will the healthcare industry change? That's not the question. The question is, how will the healthcare industry change? It's going to change. You're going to see more and more of telehealth because guess what? When COVID was at its peak and doctors' offices were closing, you had no choice but to do telehealth. And then, of course, CMS said, oh gosh, we got to start paying. Because truly the clinician, whether it's your PA or NP or your physician, they're kind of caught in the middle. They're working at the hospitals. They're getting paid from the government, CMS. CMS is always 18 plus months behind times. So they weren't really paying fully for telehealth prior to COVID. But guess what? That payment increased during the peak of COVID. So as I talked to my cardiologist, I said, how's the telehealth? Just last week, gosh, I need help, Karen. I really need help because the patients that I'm seeing on telehealth, they don't want to come back to the office. They actually kind of like this. And certainly not those types of patients where you really need to not really lay eyes on, but need to palpate or feel or make some type of assessment. And they need to come to the office. But those that are doing like more of a follow-up visit where you can just kind of look at them. So I have cardiologists that are asking for nurses to come and help them out because certainly the doctors are not practicing at the top of their license. So they need an RN or a mid-level practitioner, nurse practitioner to do their telehealth. So how's the volume of telehealth now that all the doctor's offices are open, Dr. Jones? Oh, it's still booming. CMS is reimbursing now. So I foresee that digital technology, and I think Professor Frank alluded to it about health wearables, the Google Watches, they're going to continue. So you got all the data with health wearables. You have all the data in telehealth. How are you going to integrate all that? You got to bring in AI. You got to bring in artificial intelligence. You got to bring in machine learning to get all that data out of your 3 repositories, as well as to collect the data from all of your health wearables. To really look at the roadmap and the precision of care for those patients. I think that's the only way that you're going to be able to attract the clinicians. They even have right now robots. So they're looking at taking that a step further. And I put bots on here because that's the term for short of robots. They're even taking robots now, not only delivering medications, which is kind of what they're doing now in the hospitals. They collaborate and integrate with pharmacy. But now they're looking at you swallowing a pill. You're able to, I'm not going to do that. You swallow a pill, and then you're able to see what's going on internally, and they can kind of work on the computer and say, oh, this is what's happening, and this is what's going to happen in the next 15 or 10 years. But this is what you need to do to correct, to prevent this from happening. I honestly think that certainly your Gen X's were more reactive to medicine, and now I think we're more proactive. We understand that medication, and I'm sorry if I offend anyone, is just not the way to go. Because you're taking a medication to address a sign and symptom, and then you take another one to address the side effect of that medication, and then you come up with polymedication, right? To address these disorders. Why not get to the root of the thing, right? So I think now people are being more proactive. What can I do to prevent this from happening? People are more savvy, I think, now as it relates to healthcare. So I think that certainly by me being a nurse, nurses, I believe, are really on the front line to innovate, to be innovative leaders, And I think they will certainly play a role as we pivot. I think the perfect storm, COVID, but that allowed the healthcare system to pivot. We have to pivot. We can't do business as usual. And I know that clinicians, as well as whether it's, researchers or NPs, PAs, physicians, they want to see the p-value. Is the p-value significant? They really do. Because I say, hey, cardiologists, let's introduce this. Karen, you got any literature on that? No, I don't have any literature. Bring me back some literature. I want to see the p-value. Because if something happens, as the I don't know if he's an attorney or not, but the lawyer, people want to sue, people will sue, right? So we got to come up, those that are looking at and moving forward with innovative approaches, we've got to come up with a significant p-value to present it to our clinicians. So I just think that certainly, like I said, nurses are the key role, and they are the front lines. I think they're the innovative leaders. My business is the Nurse Leadership Academy, where we really focus in on nursing. Now, when I was a nurse and I was in clinical and even outside of clinical when I started, I had the white cap on with the black stripe on the hat. I don't know if you guys remember that or not, but so looking at the nurses now, the critical thinking is not there. They're not critically thinking. And is it because they're so busy documenting in Epic and Cerner and Meditech? Or is it because they have not been learned how to critically think? Probably a combination of both. So what we do is we really try to engage our team, as well as those students that would come to our classes. Our services that we offer are consultants. This is the perfect opportunity as we shift into the new year. This is 2023 coming up. Got to come up with a different strategic plan. We collaborate with the C-suite, the executive suite. We're able to certainly identify inefficiencies, focus in on the triple and the quadruple aim, engage the staff. I'll talk a little bit about the nurse leadership training on the next slide. I'm in the process now of integrating with innovative tech companies to see how nurses can be more innovative, because they're the only ones that know all of the inefficiencies that they have to do day to day, right? Certainly, I think that's the key to bring the healthcare professionals back. Because when I went to school, I really went to school because I love nursing and I wanted to care for people. And then 10 to 15 years after I graduated, people started entering nursing because it was a second job. It helped, ends meet. But I really think that there's certainly the opportunity for the nurses and innovation to come right back into play. And I think that's where you will draw your physician leaders back in as well. So our leadership tracks for nurses, we have track 1, which really talks about from classroom to workplace. We go through effective communication. We go through building teams, classes in efficiency of care, as well as patient experience. From volume to value. Track 3 is all about innovations. And that's collaborating with tech companies to integrate those nurses. Track 2 takes it a little bit further, really looking at budgeting and finance. And that, I think, shouldn't only be left to like your directors and your managers, but I think it also should be geared towards those frontline leaders so that they can understand the financial impact of the decisions that they're making when they're pulling off the shelf 3 and 4 gauze or what have you. Looking at performance measurements as well as data analytics. It's key, and they're not being taught this right now. The power of influence over authority. That's really, really key, really key. And then, of course, organizational culture. And we have some scholarships, and this is post-training that we, offer our students after they've completed our leadership tracks. We offer them, if they can apply for scholarships, if they want to continue on their journey to either become a legal nurse consultant or any advancing, their career. These are just a couple of the consultants that work with me. One is in the Philippines. The other here is in the Midwest. And certainly we're available to consult either by Teams or by Zoom. We haven't gotten into the innovation part quite yet. I'm certainly, integrating with other med tech companies because I have so many ideas, so much administrative waste, and not trying to get people out of jobs at all, but correcting the processes to ensure that those patients' trajectory through the healthcare after they're admitted is done, and that minimizes length of stay. Any questions? Any questions? This is my LinkedIn. If you guys have any, if you want to reach out to me by LinkedIn, please feel free. I have my website there as well, nlainternational.com. Thank you. Yes.
Hi. How are you today?
I'm well, thank you. And you?
I'm surviving. It's
Okay.
Still jet lagged a little bit,
That's okay.
So, telehealth. It's in the UK, the telehealth that's going on over there. It's not really a specific model that I can see that they're following. It's very, right, this person doesn't need to be seen. They've made their decision. The powers that be, give them whatever they need, a prescription, treating drugs, even just for a short term, and so on and so forth. And I was just wondering, is there a specific model? Is there a specific model or dynamic or program or some kind of thing that can be used to better strategize the patient groups that you get within the telehealth to prevent more people from returning back or missing really important and vital things that you've seen or come up with?
Yeah, so great question, and thank you for that. Certainly, I would say that it's not ideal for your those octogenarians or nonagenarians that have polychronic conditions, right? I think they should come to the office. However, what's really alarming, and the research shows that during COVID, telehealth went through those numbers went through the roof. And as I said, I consulted with my cardiologist. I said, how's the telehealth coming along? Still crazy. People are still doing it. I think it's key to probably those that are in their 30s or 40s that's really conscientious to healthcare, to their healthcare, and to be able to reach out to physicians. You've got these great disruptors that are coming into the healthcare, and I know you guys have heard of them, Google, Amazon. I think Amazon is opening up a clinic for alopecia and allergy. And that's going to be like a telehealth clinic type thing. So yeah, I think it's probably good for those non-polychronic diseases and disorders. I think that, certainly there's opportunity for those who don't have multi-chronic diseases to do telehealth. Yeah.
Is there a possible way of getting them to fill out something at the very beginning that could indicate something, like one of the things we saw before, I can't remember which one it was, but when you ask them what's wrong, they can provide more information for you. Is there anything that can be done for the patient when that service is being used at the very beginning that could indicate or change the direction of where it's going to go?
Yeah, it's a great question. I think so. So you're talking more about health assessment. So when you're interviewing, if you will, the patients in the beginning, you can really kind of see exactly, well, you need to come to my office, or I can refer you to my nurse practitioner who can follow up with you. But to have, either a GI physician or cardiologist to do telehealth, that's really not practicing at the top of their license. They can certainly be performing procedures or minimally invasive procedures. Any other questions? Please.
I'm curious, you mentioned that the US, or one of the citations mentioned that the US spending on administrative costs per capita is over $1,000. Curious if, from your perspective or your research, if you had to dwindle it down to say one or two things that are the driving costs or cost drivers, what might those be?
Great question. I think certainly, so I work for a safety net hospital. I work for county, Santa Clara County in San Jose, and I oversee cardiology. And so I see a lot of waste where one department is doing the same thing that the other department is doing. So I've worked for-profit HCA hospitals as well as non-for-profit hospitals. So an example, have you all heard of Chronos? Okay. So, that's right, time management. So an employee swipes in, that same employee will document the time he or she has swiped in on a piece of paper. The employee swipes out at the end of the day. The employee will write down the time that he or she swiped out at the end of the day. Those forms go to a whole nother department to compare with the Chronos swipe in and out. What the hell? What are we doing here? Even for credentialing for physicians when they're the onboarding, right? Lots of administrative waste. Huge opportunity for AI to integrate with that. The process it takes for onboarding MLPs or PAs or physicians, 6 months north of that. What are we doing? What are we doing? Or what are other countries doing that we can adapt? Really, I mean, a hospital in I think it was in Cleveland, laid off the majority of their administrative staff. They can't make it anymore. Healthcare's got to change. It will change in my lifetime. Any other questions? Did you have something? Yeah. Yeah.
Thank you for this wonderful talk. Sure. I have, based on what I saw, so there is an impending shortage of healthcare workers in the coming years. So what role does prevention and health promotion has taken that in?
And I think certainly as we move forward in innovation, and whoever our researchers are out there, please get the research ball rolling so that we can come up with these significant p-values, because I think in order to draw our clinicians back, whether they're providers or our MLPs or PAs, back to the healthcare field, they're going to be drawn back in with innovation. They will be drawn back in with innovation, because that's the generation that we're in. It really is. Great question. Thank you.
Okay, thank you.
Sure.
Yeah, thank you very much for this interesting presentation.
Sure.
My concern is the documentation. The burnout for all the clinicians, I think the majority of the documentation. Prolonged documentation, repetition of the documentation with many different phrases, many different pages. And when we are coming down with the telemedicine, also documentation is coming again with another big story. So my concern or my questions, have a strategy to modify the documentation in the way to become helpful, short, direct for the point, not missing or maintaining the safety, but not to have repetition or prolonged documentation, what we have it now.
Yeah.
Is there any correlated with the accreditation standard? Because again, the accreditation standard, they are asking some documentation to be done in the way. So is there any integrity between all this to have it in a smart way of documentation?
Yes, that's a fantastic question. And as we all know, if you don't document, it means it's not done, right? And we have several physicians that are on suspension list because they haven't documented their charts, right? Everybody knows that. My idea, and I know they utilize a lot of this in the emergency room, is machine learning or scribes. Scribing. So if we had the scribes, yes, that's incurring another administrative cost, right? It is, but at least you would be able to allow that physician to function at the top of his or her license as they're documenting or verbalizing the documentation that would go and integrate into the EMR. It can go really quickly, and that person would not be on suspension. The scriber's taking care of all of that, and you can move forward from there. That's a big hindrance, the EMR, because everything is documenting. I mean, you have, when you go to the units, you have a nurse, and right next to the nurse, right next to her pocket, is the WOW, computer or CAL, computer on wheels. Yeah. And so scribing, I think, is key. And I was talking to somebody earlier, I think back here, she said, they could critically think if we weren't doing so much documentation and writing on the whiteboard, right? Yeah. So, certainly back in the day when I was in practicing on the floors, I was the primary nurse. I wanted to change the patient. I wanted to turn the patient and check for decubitus. They have other people doing that. I wanted to empty the Foley because I needed to see the content and the sediment of the urine. I wanted to change the dressing, and I did. But then they start bringing other, people involved in it. So I think scribes is the way to go, certainly. And that will help the physician, because my physicians are always on suspension because we're still utilizing, they're dictating, but then they're using somebody to transcribe that. Why not dictate, have machine learning, and then that automatically goes into the EMR after the doctor just looks at it and presses a button? So much opportunity for AI and ML. So much.
I'm going to look at it from a different angle.
Yeah.
So patient access is usually looked at throughout the patient journey as the door that the patient goes through to see the physician, be it virtually or face-to-face. Reality check is that we've got pipelines of scheduled appointments. You've got physicians that once they open the encounter and they close an encounter, multiply that by the number of patients they see, multiply that by the days that they work, you can easily correlate algorithm-wise if a physician is going to be burnt out down the road, 2 days down the road, 5 days down the road, a month down the road, so that you can shuffle their schedules and eliminate the preventative aspect of it from physicians being burnt out.
Yeah.
That is the big data we're talking about.
Absolutely. And that's a really super comment. You're talking about interoperability of all those systems. We're so fragmented.
Patient access data is your key to the burnout of caregivers, but nobody looks at it. Everyone wants to know how many patients are we going to see tomorrow? But a week from now, when the physicians that are on the schedule or on the payroll, not on leaves, not on sick leaves, chronos wise, as I mentioned, are they going to be overworking? And for how long can they sustain that?
No, you're right. You're so
where
key.
the exit.
Yeah, that's right.
That week, when they're overworked, that's where the bad ideas come, and they exit the whole industry. So
That's a great comment. And I think with pulling all of that interoperability together, the physician would enjoy saying, oh, okay, so the AI has says this patient has X, Y, and Z, because this platform knows from the time that the patient went to the visit at the doctor's office or telehealth at the doctor's office, right? And the hospital visit, plus the visit that the patient had 3 years ago, right? Plus the checkup appointment that that same patient has. So we're pulling all that together and presenting it to the physician. Then they can make a intelligent decision instead of saying, oh, well, okay, this encounter says that you went here. So what happened there? What's not documented?
I'm actually looking at it even from the fact that the workload balance.
Absolutely. Absolutely.
Here, the doctor has the capacity
Mhm.
to take in that patient and consult.
Uh-huh.
That helps expedite, minimize documentation and make a lot of the paradise. But the aspect that you're overseeing patients is like an engine, is going to eventually burn them out.
It will.
And that is the easiest way to kind of maneuver and change the whole aspect of how do we admit patients through the door.
Yeah.
That preserves the workforce, I guess.
Yeah, I think a combination of all of that. Really, really great comment. Thank you. Yeah.
Yes, thank you so much for what you do. I'm gonna kind of shift gears here.
Yeah.
And the fact that I want to know more about what would the role of unions do? And to add to that piece, how would that affect legislative action? And where does the ANA stand?
Yeah, those are really, really great points and questions that you asked. So certainly the role of unions for the RN, and I've been in the healthcare field, like I said, I graduated in 1984 from Tuskegee Institute. So that kind of tells you it's now university, but I went to Tuskegee Institute. I've never been in a union until I came here to California. And as a director of CV services, I'm in a union. So I'm like, okay, so what are we doing here? But to your point, that's really a great point. I don't know because I've never really been in a union. I have oversaw staff who have been in the union, and I just, certainly pull out my little green book or whatever it is and ensure that we're, complying appropriately. I think certainly that ANA has no choice but to get on the bandwagon. Again, it's not will the healthcare industry change? It's just going to be how. And I think it's going to be a matter of CMS coming on board, reimbursing, right? Because you have health systems purchasing health systems. Common Spirit example, 140 hospitals under their belt. And so they can charge whatever they want to charge for the services per capita. Because there's less competition when you do that, when you consolidate like that. So not only is it hospital to hospital, but it's also health system to health system. But to your point, I would hope that ANA is on the forefront. I don't know if they still have the gentleman who's the president of ANA. I would hope that, he would look into that. I mean, you have the research already with us being in the height of COVID and telehealth through the window because they couldn't, see patients coming to so you have your basic patients coming in through the ER who had COVID, right? During that whole year, 2020, early 2021. So your regular patient that would need emergently, they don't want to come. So what are we seeing? We're seeing patients that should have been more preventative in caring for themselves. We are seeing them come in with severe aortic stenosis or ST elevations through the roof and rolling them in and certainly meeting the door to balloon within 90 minutes. But all of that could have been prevented. So my hope is that ANA will be able to move forward and get on the bandwagon as well as CMS. Because if you are not reimbursed for these services, the hospital, they're not going to they won't be able to embrace them. Yeah, thank you for your question. Yes. Oh.
Yeah, you know what, this is very complex. At the same time, I think it's simple. If we would just look at it from a simple perspective. And I want to ask you, do you think now that health practitioners all over the country and all over the world really like their jobs?
Right now, no. No, I think, I'm gonna go back to what I said. I think if we innovated and integrated innovation in it, I think they would love it. I think they're tired of all the documentation. I think that they're tired of, going back and forth, doing a lot of these menial jobs. Absolutely. I think if we can incorporate bots or some type of robot in the day-to-day care that these nurses are doing, I think they would just be thrilled with that. And I think that will draw nurses as well as clinicians back into the workforce. Innovation is the key. It's just lovely. I love it. Hopefully I'll be able to see it. Yeah.
If healthcare was in the corporate world
Mhm.
and you didn't follow policies and procedures, you would be fired.
Yeah, but you know what? It takes CMS a long time to penalize, if you will, a hospital organization. And so you have a patient that's discharged with HF, heart failure. The physicians, they don't put the patient on the ACE-ARB beta blocker diuretic that they should be on, only because they know that that patient will come back to the hospital and then ka-ching, ka-ching, ka-ching. And the government finally caught up with that. And the way they caught up is they went to Stanford, they went to your Harvards and looked at the research and said, okay, what is it that the doctor says that will reduce morbidity and mortality for your HF patients? Oh, these patients should be on ACE-ARB and diuretic. Oh, well, was your patient on that? No, so you get penalized. So that means that if that patient comes back to either your hospital or the hospital down the street within 30 days, guess what? The hospital that that patient was discharged from gets the penalty. So the CMS was very savvy in doing that and, withholding payments for that. So we're all orchestrated and under the direction of CMS, pretty much, the hospitals are. Yeah. So in corporate, you don't have that. But in the hospital system, we're kind of guided by CMS because they're saying, okay, let's look at quality. We're going to move from fee for service to volume, from volume to quality. How are you doing quality wise with these patients? Based on what you researched, based on your significant p-value. Yeah.
Do you guys take personality tests in your hospital?
Some hospitals do. With my team, just so that I can understand who I'm working with, I do a mini Myers-Briggs. But yeah, I think the Myers-Briggs is 150 plus questions. So what I do is the DISC survey. Yeah, dominant, influence, steady, and conscientious, because I need to know who I'm working with. Who am I collaborating with? And I need them to understand me, because when they're coming to me, I need to know bottom line. I don't need to know the fluffiness. So they know how to come to me and I know how to come to them. If I need a recognition committee, I'm going to delegate that to all of my high eyes. Right? Yeah, because they like to do the parties. I don't, but I need that. And you don't want to have a team that's full of D's like me, because you don't think of the other option. And I tell them that. I say, guys, when I come up with, okay, let's do, I need somebody to say, Karen, what about? Did you think about? I'm like, oh, right. Because I'm like, okay, let's go. Let's do it. Yeah. So yeah, I always do a DISC on my team so that I can know who I'm working with. They can understand each other and they can understand me. Great question. Thank you.
Yes, so all of a sudden as you're speaking, I guess I'm seeing this like epic movie unfold, and it's this human nature for success and greed in the corporate world, and also this dwindling human nature of wanting to care but also being so very human.
Mm-hmm.
And I like your question, how will healthcare change? I think we need to remember the only way it's going to change successfully is if it is in line with we still can't even guarantee it's going to eat during a 12-hour shift. I mean, we need to think, we really need some self-reflection of very high-level leaders. And I think the term burnout, well, of course they burnt out. When do we say we have failed as leaders and the government agencies and the regulators? They burnt out. Well, what have we done? Why have we failed to be able to create a work environment where caregivers can thrive? And I think until leadership is asking themselves that question, it will not be solved.
Yeah, I think that's really a super comment and comment that you made here. I think certainly that sure, I mean it's a big pie to bite, and you have to take little sections. I think as leaders, and me working back in 1986 and 87, when the fee for service was converting to volume to value. You have those people that are very reactive. Okay, the government says do this. Okay, so we need to throw this in. In 2008, you had 10 years to migrate from paper chart to EMR. Okay, we got to hurry up and do this. You've got Press Ganey scores. So let's hurry up and get this done. So we needed to really kind of step back and say, okay, time out. We're running our nurses around on this treadmill and we're burning them out. And then lo and behold, COVID hits. And you've got nurses that are coming from all over the world getting paid 3 times the amount as your nurse at the bedside is getting paid. Did that help? No. Yeah. So it's a huge problem. But I really, really honestly think that it's very hard to bite it off by sections. But I think if we integrated interoperability with all of these different systems, incorporated artificial intelligence and machine learning into a lot of this, I think that the younger workforce would be more apt to come into the healthcare field. Great question and comment.
Thank you for your presentation and your dedication as a nurse and as a high-end innovator. I love the fact that you really infuse new innovation, and I think, even precision medicine and all the things that speak to individual health and genetics is going to be really important moving forward. But taking all of those things into context, along with burnout, along with workforce shortages, along with unions, and along with innovation, where do you see then with the CMS, you mentioned CHI Common Spirit now with having 140 hospitals. So take a look at CMS has 2 rules. They have the 30-day readmission rule, and how is that implicating, adding, lessening burnout and all of the things about innovation. So kind of marrying that. And then the other one, the price transparency. How is that on the hospital websites via CMS impacting everything?
Yeah, it's a great question, and thank you for that. I think certainly CMS, as you probably know, they have a lot of catching up to do. I think certainly price transparency is key so that your patients can make the correct decision and choice of where they want to go. All you have to do now is, go on the website, hospitalcompare.gov, I think it is, or I think one of those, hospitalcompare.gov. You can go on to that website as well as physiciancompare.gov and find out all of the intricacies as it relates to your physician as well as your hospital and where they score out in as it relates to mortality, where they score out related to 30-day readmissions, compliance, morbidity, et cetera. So to your point, certainly price transparency, we've been talking about that for a few years, and it really is not at the forefront quite yet. So that those patients can, make those educated decisions. We're going to have more and more people entering Medicare. So will the risk models change? So that's why I said the aftermath of COVID has hit the entire ecosystem, the healthcare ecosystem. And each one of those facets will play a significant role as we move forward to pivot in what are we doing next in the healthcare arena.
Just punctuate that. Do you think that along
with like the ACOs and all the things that we are calling our nurses and our physicians to do. Do you think the price transparency, the readmission rules, all the things for integrated care, do you think that those are also percolating things, and document and scribe in the EHR is also part of the burnout ratio?
Absolutely, absolutely. And the question becomes, what is it going to take another pandemic for us to move forward in something, right? Because not until the pandemic hit did CMS say, oh, we really need to pay for telehealth. Let's do this. And that's the only way that the physicians were able to get on board. Yeah, I think all of that is contributes to the burnout of the physicians, the mid-level practitioners. They're trying to bridge the gap. Thank you.
Thank you, Ms. Patty, for the insightful speech, and the discussion was great. Thank you, audience.
Okay.
Our next speaker this afternoon is a keynote speaker. Unfortunately, they were unable to make it today for an emergency. We have Ms. Hewitt Vanilla. She is from the United States, owner and CEO of Suicide Care Consulting Services. She will be speaking on suicide care transitions from inpatient to outpatient.
Hello, everyone. So as was already mentioned, my name is Yvette Bonilla. I am from the Northeast region of the United States. I am also the owner and CEO of Suicide Care Consulting. And so my primary focus is to help inpatient hospitals transition from inpatient level of care. And for now, my focus is to outpatient. And I'm going to share my screen with everyone so that you can see my PowerPoint slides. All right. And so this is my contact information. You have my phone number here as well as my email. So say if after this PowerPoint people have questions, comments, or areas of discussion that weren't addressed here, you could feel free to email me directly. And just a little bit about my background. I'll see if I could share my slides as well. Let's see. Okay. So a little bit about me and what actually got me to start this initiative in the first place. One of the things that I have seen when it comes to transitioning someone from inpatient to outpatient, I see that given that there is that gap in care, what can often happen is that it can actually be a very harmful and even a fatal issue that if not handled properly, we find that folks suffer, and not just the patient, because the patient could even die, but also the patient's loved ones, the patient's workforce, the patient's community overall. They could end up suffering some very dire consequences. And this is something that in my 13 years of practice, I would see on the day-to-day working, inpatient working, outpatient working, in community-based organizations and nonprofits, or that whenever there is a suicide, especially when someone is coming from inpatient after having endured a very fragile crisis, you just see even the providers themselves get rattled by a patient's death or by a patient's attempt. And this is something that whenever we are patient facing and trying to keep our cool in the middle of it all can be one of our biggest challenges. And even before I started working in this field, I was a patient myself decades ago. And this is something that when I had my near-death experience, there were people left and right rattled, my family, my place of employment and vocation, and people just were not really sure how to handle it, especially if I was coming in and out of the hospital beds, and it just seemed like I was one of those lost causes, right? So having that sort of lost cause labeled to you can be especially detrimental. And so it has really been my mission to try to minimize and even put an end to this revolving door effect, or readmissions, however you want to call this phenomena, putting an end to it so that people do not get so negatively affected, because this goes beyond the patient. This goes to the communities far and wide. It even goes to the very hospitals themselves that are treating these patients to begin with. And so a bit more in depth about why I chose, in terms of suicide prevention, to do care transitions. My focus being from inpatient to outpatient. I really wanted that focus because as I transitioned into the field of social work, that is my current trade, what I really noticed in that gap being what it is, it can oftentimes make patients feel like they're being left behind, as if when you have someone who is going inpatient, they are learning all of these coping strategies, they're learning all these ways to keep themselves safe. They have all these providers who give them all of this education and learning what it's like about going through what it is that they're going through. They're able to put a name to it. They're better able to understand what it is they're going through. They have people, peers who are able to relate to their experience. And so they feel like they've really connected with folk here. But then when it comes time to discharge, like, okay, you know, they know maybe in the coming days and even hours, they know they're going to go back to the real world. And they might even have a bit of understanding that they're going to leave. But when it actually comes time to go, a lot of times what I have seen in my own personal and even in my experience working with patients is people really feel like, now what do I do? Because then when it comes time to use all of those strategies in the midst of an actual real life conflict going on, whether or not it resorts to a crisis, it can often leave a patient to feel like they learn all this stuff in the hospital, but they weren't able to use it in real time. Right. And so without having someone to be able to guide them through step by step how to navigate some of those difficult communication issues, without having someone to be able to show them an example, like that real life example of how to assert their boundaries, that can be especially difficult. And it could even lead to patients at times over relying on hospitals to help them when that crisis point hits. And even on the flip side, when you have a clinician who is working on the outpatient level, as I had, it can even lead to me and some of my colleagues to over rely on inpatient care to help stabilize a patient when in crisis, and it may not even be necessary. Right. And this isn't just in raw observation. This is also things where I've seen in research where there was someone named Dr. David Jobs, who focuses very heavily on suicide care and helping patients navigate the relationship with their suicidality and how to be able to make it more manageable on the various spectrums that they may experience that suicidality. He also talks about that being a very big point of concern, where so many clinicians just do not feel adequately trained to be able to deal with a patient when they say that they're suicidal. Because, okay, yeah, they may know how to use the Columbia. Yeah, they may know how to do an in-depth assessment. But once they have an idea of what the problem is and they're able to have an idea of where that person lies in terms of risk, knowing what a person's risk level is more oftentimes just the very beginning. what are the next steps from there? And a lot of clinicians that I see, like they're not really trained in grad school, and unless they take this up in some sort of a specialization type of realm, they just feel like this isn't like, especially when it comes to life or death, literal life or death, they panic and just are like, they would just rather feel more comfortable being overly cautious and sending them to the emergency room. And the issue with that is that given how resource intensive a lot of these strategies become for the hospitals, it can oftentimes lead to readmissions even in the ER. And when someone does meet criteria to go inpatient, when you have a clinician who is not all that confident, and then it leads the client to not be confident, and there's that sort of circular loop, if you will, with no one really having the confidence in the community to help deal with a patient. It's taking up all of these resources from hospitals on the ED and on the inpatient unit, and it's costing billions of dollars per year. And it's also causing losses such as in labor. It's causing losses all throughout different areas of society, billions every single year, whenever you have someone going inpatient. And even when a patient dies, then you have to worry about the fact that there's that many less workers to be able to contribute back to society from a service end and from a tax end. And what that can often lead to, as we keep hearing, great resignation, providers' morale, it is plummeting. And even as this previous speaker mentioned, they're trying to get some of the retirees to come back because they are not able to fill these much needed positions. And so that has in fact led to people to be forced to rely on things such as AI solutions, such as AI intelligence solutions, because many of those positions just cannot be adequately filled by high quality nurses and by high quality clinicians and providers. And what this can also lead to is the hospital's reputation plummeting, and it affects them on a wide array of levels, even after having used whatever resources that are at their disposal. Still, they can end up getting sued, as had been previously mentioned. They could even get a loss of accreditation and even risk closure. And then that also resorts in and of itself to layoffs, which even makes the provider shortage even worse. And then trying to get a job after such layoffs, that could even be worse. And as I had mentioned even before, on the receiving end of services, I've seen it go down, and it's gone down pretty ugly over the years. And so to get a little bit more in depth, specific to suicide care transitions, exactly how bad it can be, suicide risk is often highest within those immediate weeks and days, especially those first 30 days post-discharge. And it is known to be higher than 200 to 300 times higher than that of the general public. And 43% of suicides are known to occur within that 30-day window post-discharge. And 50% of those specific suicides, they are known to occur even before they first meet their outpatient provider. And the malpractice costs, per the Joint Commission, they are known to cost about $1.7 billion over the course of 5 years. And so that leaves it even more essential to make sure that people are getting things right the first time around. And it is also known that there are a wide array of risk factors during care transitions that could lead to suicides, but two of the really big ones are poor engagement post-discharge. So where is the follow-up coming, and where is the communication with that provider coming along when it comes time to transition them to the next level of care, which can often lead a patient to feel disconnected. It can lead a patient to feel isolated, like they have no one on their side. And what we are seeing more and more at the forefront is that relationships with patients, the patient-provider relationship is so essential. And it doesn't just stop the moment that we discharge a patient from care, because as the previous speaker mentioned, when it comes time to penalize a hospital, they often penalize the most recent hospital that had cared for that patient. So just because you discharge a patient, you're not off the hook, right? From engaging with that patient and making sure that their care needs are met once they leave. And so that really makes continuing that relationship and enhancing patient satisfaction and enhancing post-discharge engagement all the more essential. And what has also been an area of concern is that there really is no known formal standardized care transition process. And what I see a lot of mental health providers really grapple with is they feel like that everything has to be tailored, because when it comes to a patient's care plan, for example, patients respond differently to clinical treatments. They respond differently to medical treatments, and that is in physical health and mental health. Patients respond differently to interventions. However, one thing that the Joint Commission was very cautious to be sure to clarify was that it is not so much the actual treatment that they want to see standardized and formalized. That's what the interventions help, is like sort of giving an umbrella for how to do just that, and then having a tailored function from there. But it's the actual structure within the hospital system, within the actual healthcare system, of having specified processes, of having specified policies and procedures, specifically mapped out so that you can have a backbone of what are the actual protocols that you're going to embed within your system, so that when it comes time to tailor treatment protocols, you have a certain basic foundation in place to follow that through. Now, when it comes to care transitions best practices, what various accreditation agencies have outlined, and also some of the national leaders, such as the National Action Alliance for Suicide Prevention and even the Zero Suicide Institute, which is under the Education Development Center, they have specified certain processes, such as formalizing the care transfer process, which we talked about, at least on a very generic sense, and also talking about following up with the client once they leave the hospital care unit, and also communicating with providers, right? And so when it comes to formalizing the care transfer process, some simple things that can be done is having a discharge checklist, for example, such as, oh, you got to reconcile the patient meds, you got to make sure they have that clinical treatment plan in place within that discharge summary, and verifying what other kinds of barriers might even get in the way, whether it's transportation or whether it's telehealth access, because telehealth is a resource, but it could be a barrier for some people who may be, for example, lower income and have a hard time keeping up with utilities, for example. So making sure that those simple logistics are in place, and even having a designated staff who is able to sort of help coordinate the entire care transition process from when a patient discharges up until they see that outpatient provider, and then being able to even follow up accordingly, because that relationship may still be there and that patient may still be too fragile to a point that if they don't fully trust this outpatient provider, at least that relationship with the inpatient unit has been established, right? And what they also want to see is to try to minimize not just the length of stay in the inpatient unit, but what they also want to see is minimizing that window from when someone discharges from inpatient. And so the standard had been 14 days, but there had been a lot of issue in terms of patients not being able to make it to their outpatient appointment, either because they attempted or because they died before that first appointment. So they upped it from 14 days to 7 days max to get that appointment in. And when it comes to follow-up, some of the bare minimum requirements are to follow up with a patient anywhere from 24 to 72 hours post-discharge, and having some sort of a plan for checking on the patient's safety, whether it's doing a full-out Columbia or whether it's something as simple as a care contact, whether that's a text to see how they're doing and ask them how they're feeling, whether it's a written card and having a personalized note to the patient like, hey, I'm thinking of you, and checking in, seeing how things are doing, how are things going with your family, how's work going for you, and also making sure that they picked up their medications, so much like reminders, including reminder texts or calls for appointments, and having like a phone tree if needed set up for that purpose, and even following up with authorized supports to see how are they able to assist, whether it's a natural support such as a family or close friend who's the patient said you could speak with them more about their treatment. Right, so those are some of the best practices in terms of follow-up that are recommended. And then communicating with providers, such as what I'll often see is like within the discharge checklist, the hospital might have their own requirements, right? But then also in communicating with providers, they may have their own set of procedures for accepting referrals, certain information that they say that they might need in order to make a good determination to predetermine eligibility before doing a full-on intake assessment. And getting a good idea up front how sessions are structured, whether it's going to be telehealth, whether it's going to be face-to-face or some sort of a hybrid model. What would that look like for patients, or are the patients even going to be more so home visits, especially for those with complex needs? And also communicating what the follow-up contact protocols are like. So if a hospital has a follow-up protocol in place, alerting the outpatient provider of what those contact protocols are and outlining that, for example, in the MOU or with their contract as they partner up together, and what that would look like for information sharing purposes. When they outline that, it could help with not duplicating work on either end. Even still, there are still certain pain points that hospitals and outpatient providers often share, right? With trying to make sure that some of these best practices are in fact realistic and able to put in place. And some of them are clinically based. For example, like the client's readiness to even leave. Do they even trust that they're able to keep themselves safe? Do they really trust that they can follow through with the recommendations that were put in place, such as when they have a safety plan? Do they really feel like that safety plan is something that they can realistically follow through on? Which, when you look at from a systems-based concern, like the provider concern, and even what the hospital concern just as an agency, that could end up leading to a premature discharge. But at the same time, they're also saying, well, this patient no longer meets criteria for imminent risk though. So in order to try to gauge from a clinical standpoint, that could be especially difficult for some providers. Was like, well, we got to make sure that we have these beds open because we're trying to minimize length of stay and have the beds open for the people who really, really need that stabilization support. And another issue is that clients find that they're going in and out of the hospital and having a lot of those similar issues because they feel like some of those concerns are not being addressed in real time. Because again, they learn how to stay safe on the floor. And this was a conversation I had a couple of months back with a psychiatrist who works inpatient, that people feel like they can stay safe on the floor, but when it comes to being discharged, they don't have those same structures put in place that the hospital had, right? So let's say, for example, silverware was taken away. But if that was one of the ways that the client was engaging in self-harm activities, well, now you're going to have to tell, say, if the client lives with significant others, you got to make sure that they have plastic silverware at home. So these are extra steps that they have to take at home. And were they able to follow through? How much of the hospital environment then really needs to be replicated at home when it comes to trying to support the patient and their loved ones at home? And if the patient lives by themselves, that could further complicate things. And also with the constant changes with COVID regulations, as we keep hearing about, and not only is CMS behind on that, so is a lot of the literature. And when I even try to keep up with the literature, what I often find is the literature is at least a year or two behind. And I'll often see a lot of, as the COVID regulations change, whether I'm even like on a month-to-month or a quarter-to-quarter basis, I'm constantly having to go to CDC and seeing how much that matches up with some of the most recent literature that I've found. And in terms of the lack of support on the post-discharge level, there's also the issue where, for example, say when a provider is trying to refer to an outpatient level, they also have to deal with people still having a wait list and no same-day appointments unless they are able to refer to a healthcare center that is a certified community behavioral health center. And in doing so, those folk are able to do things like open access, where they can do same day assessments and even possibly do same day appointments. But for those places that don't have that designation, this is where we end up with the issue of things like wait lists and no same day appointments, because they're not able to hire in real time and work on maintaining the staff that they are able to hire in real time. And as we've said before, in being able to stay safe and the staffing shortages that are going on and navigating funds, if you're not someone who has that CCBHC designation, that can really complicate a lot of things with trying to keep those best practices in play. So not to say that it's all doom and gloom, and what we've even heard a little bit is some of the things that have been done. While there is still work to be done, even on the psychiatric care transition phase, we're seeing some AI that's being done. So for example, what we're even seeing is digital software solutions, and not just in the staff safety standpoint, but also digital software solutions such as different EMR systems, for example, for transitioning care, especially in the long-term care realm, where I've even seen it where they're able to take that digital software solution and be able to integrate it well into the EMR systems that long-term care facilities use. Because software integration is a very big concern, because it's like people feel like they have to learn a whole new system, and if they don't talk to each other, then you really have to learn how to use those things separately. And so having those functions on the back end be able to integrate with other systems is a very big consideration that some places are proactively keeping in mind. What I have seen though is that there's also a focus on the medical needs. And when they do focus on the psychiatric needs, it's about people with chronic and complex conditions, and not just things like diabetes and heart disease, but also things like schizophrenia, schizoaffective disorder, things such as bipolar, those kinds of conditions that people end up living with for life. And what I've also seen is that a lot of the discharge practices in terms of having a process in place for the overarching system is more so for the ER, for the emergency room. So in having those systems in place for the emergency room, one of the things that they're able to do is to be able to screen people accordingly, and also have a clinician who can further assess whether or not someone is eligible for more intensive psychiatric care in the inpatient unit. And for people who may screen negative for that, then they're more able to be in and out of the emergency room and not even have to deal with inpatient care. And they could be able to refer, for example, to those CCBHC designated sites so that they can have that same day care, and then really save those inpatient beds for the people who are absolutely imminent risk, and especially those, for example, who might still want to die and want to try again to die, even after having attempted. And there are different suicide-specific treatments while on the unit. So, and when it comes to care transitioning, I've seen a place called Jasper, where they also use digital software units that when it comes to transitioning, having digital software solutions where they're looking to integrate their software solutions from the emergency room into inpatient, so that those AI solutions can talk to each other. So all of that information can duplicate in the inpatient unit, which really helps minimizing a lot of the risk that comes with having to retell the story over again. So that can be especially helpful with having a lot of those systems talk to each other. So Jasper, what they've done is take how I've mentioned before, a guy named Dr. Dave Jobs. He has a tool called CAMS, the Collaborative Assessment and Management of Suicidality, and they're able to embed that particular suicide assessment framework into the Jasper digital software tool, which actually works in tandem with Epic EHR software. And then all of that information is able to go from the ED over to inpatient, and then they can work on treatment accordingly for people who use this CAMS framework. And then they also are talking more proactively about follow-up recommendations post-discharge. So what talking about that first initial follow-up, whether it's 24 to 72 hours post-discharge or sooner, and then having a lot of those, whether it's a care contact, whether it's an assessment, whether you're talking about with the family reducing access to lethal means even before the patient discharges from home, so then that way they have time to prep and keep the family safe and reduce the risk of another attempt, or even just self-harm, reducing that risk even if it's not suicidal. So as far as what is left to do is focusing on transitioning care for all age groups and for folk who may not have those long-term care needs and who may not have chronic and complex conditions. But also with the focus now about youth suicide prevention efforts, there are also youth who have chronic and complex needs as well. So let's say you have a youth who is a part of the child protective service system or is even in foster care. They have their own set of complex needs. For example, let's say they're transitioning from inpatient and then they want to go over to foster care. There is not a whole lot of systems integration from the healthcare over to a more community-based model. And so there is a model called systems of care that is really in the very beginning stages of trying to have the two systems integrate so that healthcare and community systems can more proactively address all of the core services, and in this case of the youth, core child services, such as social determinants of health with housing and with even food. And even for some of the homeless youth who may be aging out of the system, as far as what is going to be their fate coming out of these units after a crisis occurs. And given the focus on medical needs, folk who have a lot of those chronic psychiatric conditions, such as schizoaffective disorder, schizophrenia, bipolar, they also have a lot of medical needs too. And so that is where they often fit with getting the longer term care needs, but more often than not, those are adults. And so focusing on children with mental health needs, and even just for mental health needs that may not be some of those considered more severe ones, where is the focus there? And so, as I had talked before about the discharging process from the emergency room, there's less of a focus on inpatient, but the need is very much there, as I had spoken about before. And so that is where we're starting to really see the beginning stages of the Zero Suicide Institute, discussing some of the best practices with that arena. And while there is an attempt to address suicidality when someone is transitioning from the ED to inpatient, addressing suicidality from inpatient to the next level of care, and in this case, outpatient, that's where we see a bit of a lag there. And so there are different measures in place to try to see what we can do, especially in reducing access to lethal means and also assessing for risk throughout that transition period, and what kind of measures can be taken during that period. And what I'd also like to see too is structured follow-ups tailored to that specific organization's capacity to be able to have a follow-up a protocol. Because as I mentioned before, in the best practices, they want, like these accrediting bodies and the national institutions, they want you to either have a designated staff, or even like if you have like a care transition department, if you're a bigger hospital system, some places are able to do that, but we also have to look at their actual capacity to do so before we just go and rush in and say, okay, well, here you go, these are the best practices, now do it. And also about what is the client need and the organization's capacity to address that particular client need in each of these scenarios. And so with my organization, Suicide Care Consulting, there are different kinds of things that I do offer in order to try to address some of those gaps that are being discussed. And so in the very beginning, yes, we do try to make sure we educate people on what the best practices are, but it's not enough to just sit there and tell someone, right, that this is what you got to do and now do it, as we've already seen. Like, how can we make this a practical thing for each person? So I do have a care transition framework, which I dub the warm handoff framework, because when it comes to warm handoffs, just thinking in general, it really does talk about how to be able to work alongside the client where they're not expected to just figure out everything on their own. Because I think the concept of empowerment can be misleading in the sense that we just sort of expect patients to say like, oh yes, we empower you to be your own self-advocate and here are the tools for you to go and use, do it. Sometimes some patients who are more knowledgeable about the system, they may be able to figure things out. But for some people, they may need a bit of a guide, either if they are not as knowledgeable about the way that the system works, or for people who may have been in the system for decades, but they are folk who are just used to having things done for them, so to speak. Because if things have always been done for them and you say, okay, go and do X, Y, and Z, they're going to look and say, well, isn't that something that you guys do? And that is something where old habits can die hard. And so we want to make sure that we strike a balance to be a guide, but also consider patient choice when offering a lot of these solutions to people. And so with this kind of a framework, when it comes to care transitions, one of my goals is to help reduce a lot of post-discharge suicides, deaths, and attempts. We try to reduce them by up to 50%. And the research literature does show that is a very realistic goal to achieve. Excuse me. And what I try to do is embed solutions within an organization's existing infrastructure, meaning the resources that they have readily available, because sometimes it's just about getting creative with the resources that you already have, and also giving credit for the work that you're already being done, and making sure that when you're doing things like care transitions, which is something that is just starting to get built out, are we being able to capture that from an insurance perspective? Because a lot of times we may write the progress note and say, okay, yes, we have referred this client to this and that a provider, and we've communicated with the patient from a psychoeducation perspective, we've done this and this and that and that. But then what we'll also often see is that had been considered a non-billable service. But now with the current funding structures available, you can bill for that and you can get reimbursed for that on the commercial level and on the CMS level. So it is very possible that people can recoup some of those costs back. And the research shows that you can do that up to 3 times with both commercial and with CMS. And what I also do, because I am someone that my current license, I am an LMSW. And so for folk who are based in America within this audience, it's understood that I'm someone that I have an associate's license, so I am not able to offer my own clinical training. So I operate more from an operational perspective. So I have actually partnered with an international psychiatrist by the name of Dr. Manon Carre, and he actually has various clinical trainings, such as safety planning protocols, such as being able to help with assessing for risk when someone is suicidal, especially if they're chronically suicidal. How do you be able to determine whether or not someone should transition to the next level of care or stay inpatient, even though the patient is still suicidal? So he'll be able to help navigate people through things like, if someone is acutely suicidal, even though they're chronic, how do you make sure that that is taken seriously versus, you know what, we are actually able to do more rigorous safety planning to keep you safe within the community. And that is something that I offer almost like as an affiliate offering, if you will. And so I want to delve a little bit into this framework that I offer. So my organization, it had been established just last year, so December 2021, but I have been working with like a large inpatient hospital system that employs more than 10,000. And with this hospital, it's been a little bit easier, because just easier in the sense that because it's more resource ready, if you will, in order to try to get a lot of these things in place. But it was a lot more about trying to help organize those efforts and promote a sense of transparency, and also having more of a relational aspect, because oftentimes the bigger you get, the more transactional you get, and people keep on coming back needing care, and people wonder why things went wrong. And what ends up happening is that certain relational aspects of care had not been appropriately addressed. And so people have a hard time then really staying safe in the community, because a lot of those things, like it can be easy to conceptualize on paper, but it can be very difficult to see it through in real time when it comes time to implement. And so this was where I was able to kind of pitch in and make some of these implementation factors a bit more realistic. And so what this hospital system was able to accomplish was having, for example, a care transition department just dedicated specifically for the purpose of transitioning from one level of care to the next, in this case, from inpatient to outpatient. And when implementing this framework, we were able to increase patient satisfaction with care transfers by as much as 50%. And the big driving factor is communication. Where we talk about increased engagement, communication is a very big piece of that. And being able to communicate things in real time, like in layman's terms, what exactly they're going to do. Because I think a lot of times with us as providers, and even for me, like, yes, I was a patient, but I've been a provider for 13 years. When we speak about a lot of the things that we want to do with our patients, using jargon is a very common issue, and being able to break it down into layman's terms, what we're going to do with this next step, like, okay, oh yes, we're going to transfer your care to an outpatient facility. Well, what does that mean? Oh, we're gonna talk with this therapist about what is going on, and this therapist are going to work with you. So making sure that we use everyday language within our messaging to make sure that it is clear what a patient should expect when leaving, and what kind of communication will you have, like, oh, we're going to follow up with you in the next day or so to see how things are going, how are you feeling, and making each of those steps clear. Because especially when you're in a fast-paced environment, it's so easy to kind of feel like you can just boom, 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 here are the steps, this is what you're going to do, read this printout, and then you hand the printout to them, and then they're ready to go. So that being said, we just want to make sure that we keep that communication as transparent as possible. And for the sake of time, the last thing I'm going to say is that even with the providers, it wasn't just patient satisfaction, and it wasn't just with the providers feeling like they were able to do a good job in terms of more so communicating their actual processes that they do, but it also increased the outpatient satisfaction rate in terms of, like, they really felt like transparency was a very big factor that especially helped them with increasing their ability to assist the patient and knowing what to expect from those providers. And so very quickly, I'll talk about one of the things that lies ahead in terms of my thing is that although I've worked with larger hospital systems, I would also like to work with smaller hospitals that are more resource limited, and also working on transitioning patients from a inpatient to outpatient, not just outpatient, but also PHP, and also which is partial hospitalization, and also with intensive outpatient programming, and working with individuals younger than 18, and also expanding community partnerships and really working on getting that integrated care model, that systems of care model into play. That will be especially important. And so these are my references that have informed my framework, as well as the different resources that I make sure that people obtain the utmost compliance as necessary, while also keeping in mind the relational aspect in having a positive alliance with our patients. And that's it for me. Thank you so much for having me.
Thank you, Ms. Emmett, for the wonderful talk. Okay, the next one is we will be heading into a coffee break, and followed by that, we actually have two presentations. For all other presentations presenters who are unable to present today, what we are going to do is we are going to actually have a video recording requesting from them, and then that is going to be shared with everybody. So all of us will actually receive a video recording of all the presenters and their talks as well. Thank you.
Laugh MD reminded us that laughter is medicine. We listened to Karen and the relevance of nurse leadership, from Yvette on suicide case transitions, so relevant in our current healthcare environment. Right now, I'd like to introduce you to Dr. Unagi, who is not in the room. I think he just stepped out. So let's just give it a few minutes to come back in. Yeah, maybe skipping to the next slide. I think she also can come in, which is going to present next. Okay, we'll just give it another 2 minutes and. Hello? I didn't check. I didn't see. And she will come to this house. 1 second. Yes. So, not the last one, but the second last speaker today is Dr. Unati Makuwana. She's a family physician, a mother of 2, and someone who accepts people as they are. She has more than 16 years of experience under her belt, and she is going to speak about technological solutions for gender-based violence and mental health impact. So please welcome Dr. Unati Makuwana.
Thank you so much.
I actually had a nice little video. Amma, can I have that video I sent you, please? It's not here. It's not. I know it's the end of the day. We're gonna go in. This is the updated one. Okay, just leave like this. It's okay. Okay. This is not something. This is a... Shall we go? Are we good to go? Yes. Okay, thank you so much. Can you hear me? Awesome. I actually had a beautiful video that is aligned to what I'm going to talk about. It's too bad we can't play it. I sent it to Amal, probably she missed that. But thank you so much for coming and staying. I know it's the afternoon and we all want to go home. My background, as you heard, I'm a family physician, and my topic today is gender-based violence. And I get this question a lot from my colleagues. Why this topic? Why mental health? And more so, my focus is men's mental health. The reason why I do men is because, one, I'm a mom to a beautiful boy that I want him to feel, right? And it's too bad this video I had this morning was about Trevor Noah. Anyone knows Trevor? Awesome. He talked about nowadays we have men who cannot feel, and the only time they can show their vulnerability,
how they feel to be in that state is when they are doing sex. As women, we have done a good job in that sisterhood where we can share our thoughts, our vulnerabilities. Men, they talk about they talk about cars, even the time they want to feel. They'll talk about, hey, dog, I love you, man. It's jokingly. Men are not given that place to be. And then we wonder why today we are faced with GBV, we are faced with homelessness, we are faced with depression, and it's understated. You look at World Health Organization, who is mostly in jail? It's mostly men compared to women. Who is mostly homeless? It's men. Who is when depressed becomes violent? It's a man. And today also, I want us to talk about gender-based violence. How do we identify just gender-based violence? Basically, it's any harm that is directed to a woman, either physically, emotionally, or sexually. And unfortunately, studies show this. Mostly, this is perpetrated by men. And when we look at the studies, we get all these studies from UN, from World Health Organization. Over 31% of women who are murdered by their intimate partners. So today I'm going to take another route because we've talked a lot about GBV, how to identify it. But then I want us today to talk about where is this coming from? Why are men killing women? Why are children vulnerable? Why are they being victims of all of this? Global stats shows 1 in 3 women experience physical and or sexual violence in their lifetime. Unfortunately, in 2019, global study on homicide showed 90% of all homicides were committed by male perpetrators. What's going on here? An average global homicide rate of 6.1 victims per 1,000 population was estimated in 2017. You heard other speakers here talking about how dysfunctional things are in America. And indeed, look at the stats. In the Americas, 17.2 victims per 1,000 population, they are murdered. Followed by Africa. And this is explained by the fact that where I come from in Africa, unfortunately, patriarchy is what it is. Women, a lot of times, they have no voice. And then, of course, when you look at also the other parts of the world, Asia 2.3, and then, of course, the other Arabic countries where even mental health is a taboo, it's not discussed. Those stats don't make it there. Now, the question is, what is going on in the American space? Can anyone guess? Why do we see all this dysfunctionality? Everyone wants to dream, big dreams. People want to come to America. But then if there's this dysfunctionality, what is it that people are not aware of? This changed my clinical practice. This changed my clinical practice. Between 1995 to 1997, CDC and Kaiser Permanente came together and did a study on over 17,000 people. Interestingly, these people were college holders, certificate holders mostly, and that's 17,000 people. So these are people who have bachelors or in above. And interestingly, 67% of these people had a risk of adverse childhood experiences. They came together and did this study to look at these 17,000. They were looking at all these health determinants. Why do we have chronic diseases like hypertension, COPDs, cardiovascular diseases. Why people are taking all these antidepressants. And when they looked at this on the study, they asked these people 10 questions. In your childhood, between 0 to 18 years, was there any separation between your parents, like divorce or separation? Was there any sexual abuse, physical abuse, emotional? Did any of your family members go to jail, like incarcerated? Did you grow up in war-torn zones? Was there any hunger, poverty, any violence in your family, any drug abuse, any mental illnesses? Many of those people, those 17,000 people, 67% of them at least scored one of those. And unfortunately, on that study, it shows that a person who scores 4 and above has high risk, like 40% risk of developing COPD, the chronic airway disease, because they have a risk of smoking, high risk behaviors. We have all these teenage pregnancies. We have the HIV, the AIDS. We have diabetes. We have obesity. We have all these chronic cardiovascular diseases. You look at America, what is the #1 cause of death? It's the cardiovascular diseases. And these are people that came from all these disadvantaged backgrounds, unfortunately. And unfortunately, that also increases the risk of violence because, like I said, if you grow in such deprived, loveless home, background, shootings, unfortunately, you have that risk. So now today, this has changed our practice. We no longer say to people, why do you eat so much? When we see our patients with obesity or weight gain, now the narrative has changed. We don't say what's wrong with you. Instead, we are asking what happened to you. Once we understand what happens to a person, it changes how you look at that person. You look at that person holistically. First of all, you understand physiologically stress. Look at it as this big elephant in the room you constantly go to as a child. With your growing brain, it takes 25 years to mature our brains. So this child, before he or she turns 18, exposed to this trauma, high doses of trauma every day, going to this dysfunctionality. We look at what happened even during COVID-19. Many children who were vulnerable were forced to stay home in that dysfunctionality. You can imagine what happened to them. Many were sexually abused. In South Africa, where I come from, the youngest mother between 20 to 2021 was 13. In South Africa, we have squatter camps. Your parent has to work. In South Africa, people didn't stay long being locked. There are no jobs, so people had to go back quickly to work. But unfortunately, schools were closed because schools can be protective. These kids were left with no supervision. Some were raped by their neighbors, by their older siblings. So these things happen to people. So you look at all these traumas, and unfortunately, being exposed to such trauma over a prolonged period of time, it increases your physiological hormones. We talk about cortisol levels, the adrenaline. And then we wonder why. If you look at the United States of America, people who have high risk of hypertension, it's mostly people from the Black community. Prolonged levels of stress over time. The post-traumatic syndrome, slavery syndrome. Today, they are reading that. So this is to challenge everyone here who works in the government. If we're gonna continue sending them to jail, sending them or excluding them from schools, the children, we need to go to the well where everything started. Because unfortunately, this is costing the health system for as long as we do not deal with the cause of what happened to a person, this is what people deal with. And then we wonder why people, they are packed in jails. We wonder why people have all these hypertensive states. We wonder why people have chronic heart diseases, heart attacks, the COPDs. These started all from childhood. Things that are left down to. I'm from Canada. The most dysfunctional community we have in Canada is the people, the natives. They also went through trauma, right? So for as long as we don't go back there and deal with the cause, and for as long as we have boy children, if here you're a mother or you're an aunt, because I think all of us are parents, somewhat indirectly or directly, if as long as you have a boy child in your life, when he feels he's shamed, this is what we're going to end up with, the aggression. Many men, when COVID hit, actually this was brought to my attention by the staff in the office. Doc, have you noticed that we have a lot of male patients calling in for help? And indeed, when I looked at my records, yes, there was a lot of drug abuse, new experimentation. There was a lot of asking for prescriptions. By the way, it takes minimum 2 years for men to come for help. During COVID, we were all forced to go within. I started hearing stories about, Doc, I was molested. The one saddest story I had, this young man in his late 40s, where he shared with me that he was molested by his family physician, right in the medical office. First time sharing it. So we have all this anger that men have. No one asks, where is this coming from? We raise boy children and shame them when they feel their emotions. We tell them, a boy doesn't cry. We are raising a false image of stoicism. We want our boy children to be stoic. What happened to the babies that we raise, and we want them to feel we love, but suddenly when they become men, I always say men and women have the same amygdala. We have the same emotions. We all feel. As such, when COVID hit, I started this private group where I have this global community of men. Initially, when they first came in, they were hiding their faces. Some were calling themselves Sam, and that I expected. But in 2 weeks after we started, people started showing their faces. People shared that, I've never even shared this with my spouse. So we basically have a society where even women, us in the men's lives, we do not have any safe, men do not have safe spaces to be. They have repressed and depressed feelings. And unfortunately, depressed men, they interestingly present slightly differently compared to their counterparts. Depression in men, it's usually the spouse that comes first because she wants to divorce that man. Depression in men usually presents as anger and violence. Or sometimes physical symptoms like back pain, headache. If you dig deeper as a physician or any clinician who meets that person, you go deeper there, you'll find that there's some emotional and mental health struggles. So how many we miss when they come to our clinic? Already, men don't come for physical ailments. Like I said, minimally it takes 2 years for them to come out and ask for help. All they do, they will take the tranquilizers. They will say, I'm stressed. They end up abusing things like Ativan, but not going to the bottom of things. So basically right now, as we continue to look at the studies of what is happening, why do people get so aggressive and violent? Studies are coming up now. We have these 6 primitive brain stem parts, the amygdala, reticular activating system. These two, they go hand in hand in how we feel. Our flight, fright, and frozen states, these depend on this. We get activated. Remember I said, you grow up in a violent home, very dysfunctional, high cortisol stress levels, your adrenaline levels are always high. You are in that state all the time. Whatever happens to you now, it's whatever happened in childhood, you are continuously in that hypervigilant state, right? And then of course, aggression and violence has the same reward. You know, when you are excited and craving something you love and the serotonin, dopamine goes up, aggression tends to have that. That's why people, when they are aggressive and violent, they have the motivation of doing something about it. The use of guns and all, because they start real when they do that. Right? So in all our cries, in all our frustration about aggressive men and violence, we need to take time and go back a little bit and look at what happened to men. And this is not to underestimate that there's men that are abused. I do have patients that will report that they are female, their wives are abusive, but also the system and the society, we have created this false image. There's men that will go and report these cases to the police station. Even in the US, you don't really have much stats out there because they're shamed. Men cannot talk. So who becomes their victims? Their children and their women. So we'll go in circles, build all the prisons, incarcerating men for as long as we do not create spaces where men can have safe spaces to vent and talk. And also we look at what happened to boy children from their age, from their young age. Even now, we have actually incorporated the ACEs in our prenatal assessments. We assess the mother, the conditions where she's at, the stressors, the support, is there any support with the spouse, and we extend help to the spouses. But it's in its infancy. A lot of times there's a lot of shame, cultural components too. People don't want to talk about these things. So there's so much that we need to break all these barriers before we can help people, right? And of course, how do we solve all of this? Where everything started. Virtual psychotherapy. Studies show that men now are easy to seek help from the comfort of their homes. Somehow we thank COVID for happening because it has created that transparency. Men can actually text their therapist now. They can speak on the video. At least now people are coming out for help, right? And then of course, there's many modalities we use. EMDR is one of them. Basically, eye movement, desensitization, where basically a person would work with a therapist. This basically resets your pathways where everything started. This is just one of them. And of course, DBT, right? Dialectical behavioral therapy. It's also part of the modalities we use from so many. And then of course, hotlines. This one is less utilized. Again, there's a lot of cultural component. Many people, they don't want to talk about this thing. Some cultures, mental health struggles doesn't exist. There's so many things that we still need to do a lot of work in the campaigns and education. Texting, we find that texting, younger people, they utilize a lot of texting. And I was happy. I have a group on Facebook where there was this young woman who doesn't really have support coming from high ACEs background and was ready to end it. And she said, I just need help. Anyone can help. And also she was struggling also with very autistic struggles. And fortunately, we asked her to contact EMS and she kept in touch with us. And indeed, EMS was there. So technology. I always say we need to use things like Facebook, like LinkedIn with intention, because there's a lot of help from that. And of course, medical devices nowadays, we have all these devices where people could ask for help. Right now, I'm actually at the end of the device I'm developing. Love to work with people that would love to end this and curb this giant, where we're basically working with an app developer and of course with an electronic device where you connect those two. If you need help, you press that, it goes straight to your SOS. It goes to, you basically put the people you trust, like your parents or your friends, trusted member, and then you can get the help you need. So we are seeing some changes in countries that are doing it. It's been beautiful, but of course, a lot of times the governments sometimes are not as supportive to these things. We're hoping that a place like Canada, I'm excited to I'm just about done doing this, and I'll be basically working with the government. There's been good reception there. And of course, the women's shelters, they were very receptive when we brought this to their attention. So we're hoping this could be part of the solution. There's many, obviously, but we think that more especially in countries where there's no problem with telecommunication. Like I know that in Africa, it's a struggle with electricity, but so far, at least we'll start in the North American space, Europe, and hoping everything could go well and we could actually reduce these amongst other things that are done. Of course, there's research also that's ongoing. The governments are putting a lot of funding, more especially in Canada, where we have a lot of women that we are losing, like the First Nations, the natives, they are dying in their community because, again, there's no communication. Recently, there was a mass death of this man who just came and shot all these 13 people. So these things are happening. And for as long as we are not working together to curb it, and until it happens to a person, and someone said something powerful this morning that sometimes, a lot of times, women who are abused are powerful in their workspaces and they have an abusive spouse and they have nowhere to share these things because they're quite powerful. They are respected. And a lot of times, narcissistic men, they target powerful women. It feeds their ego, yes, their amygdala too, right? So it becomes that physiological. So thank you so much for staying. I know it was afternoon. I'm challenging each one of us to do something about gender-based violence before we start blaming men. Yes, of course, men have to be responsible, but we need to create these safe spaces for our men in our homes. Actually, since I started this work, my husband said, "You've changed, you're more nicer." I've become very humble and also created that safe space for him to feel, right? And to share his thoughts and to share his heart, to be vulnerable. So I really wanted to share that video when Trevor Noah talked about how men, they only find themselves vulnerable when they're in their sex states, which is unfair because they have nowhere where they could say, "I need to be held. I really want to be held. I want someone to listen to me. I want someone to hear me." There is no such space for them. Thank you so much.
Thank you, Dr. Makiwane.
Makiwane.
I'm sorry, I apologize for the pronunciation, but thank you for this really insightful talk. Does anyone has questions?
Hi there.
Hi.
Thank you for the talk. It was really interesting. I recalled when you were talking about it that there wasn't text service used during COVID. In the UK, volunteers were utilised in that service, and it was for all people who were struggling during the lockdowns and whatnot, because that really raised mental health quite drastically. It raised it up, I think 140%, they said in the end, or something like that, if that's even possible. But it was quite high, nevertheless, and when that happened, there wasn't much services out there to support, like there was before. I came up with the idea of a mental health A&E for people that were suicidal and whatnot, but they kept going about funding with that and et cetera, but I figured that if they made it part of another hospital, like a hospital already has like mental health wards, then maybe that could help and people staffing and whatnot as well. But going back to the texting, so I'm not sure if anyone else here knows if it was utilized in their countries or their places of work, but I don't know what happened, but they debunked it in the end. So it was utilized, it made a massive difference from what I hear, good results. And then it was sucked. As soon as COVID started to calm down, they didn't really carry on using it the way they were. And it wasn't even like it was costing that much money. It was volunteers doing it on the side in their own time. So there wasn't many resources used or anything like that.
You're right, yes. They are always looking for volunteers, but the issue is mental health is hard, right? It can be very debilitating even to the healthcare worker herself or himself. So those volunteers were also depleted by the stress, and unfortunately, there was just high turnover. Even now in Canada, they are always looking. Right, yes. But the other thing that actually I'm hoping to raise in the meetings that are upcoming for me, where I come from in South Africa, we invest in something called DOT, the direct observed treatment. You saw that, right?
The tuberculosis in India.
Yeah, absolutely. So I was going to use that because when we, and those people that do that, it's just the regular community people. Of course, you do need to compensate those people. Now we're talking mental health. So the other thing we struggle with in places like Canada, which is a diverse community, there's a language barrier, right? So even if they were to text, who are they texting? Right? So I think if we could invest with, there's something called, what is it called now? I just forgot this concept of you go to a community and ask, what do you need? Right? When we do that, we invest in not just because some people, HIV when it first, like the America coming to Africa, bringing ARVs and all that stuff, they do all these research. It was benefiting their researchers, but did you really do research and brought antivirals to these people? Right? So we need to bring what people need. The language, compensate people that are working in this because it's quite hard.
Could we work with the local authorities to do that? Could we support them?
Absolutely.
Go through it that way, because there are quite a few local authorities, charities that can cover those things, but is that what's going to be, is that the plan moving forward?
Part of the solution? Part of the solution, but there's so many things that would happen, and also sometimes not to wait for the government. I find a lot of times, more especially in smaller communities, they start all these projects. They do their own pilot programs, and then by the time they reach, its maturity, they just approach the government. So do what works in the community and they must get you going.
Makes sense.
Right?
I wish you all the luck.
Thank you.
Another one, thanks.
First of all, I just want to say that if it was a man giving the speech, it wouldn't have that effect. Thank you so much for doing what you're doing.
Oh, thank you.
And we were earlier speaking about the power of laughter, how, all those aspects come into play, but we really forget the power of crime. There's a reason that we have that ability. And men have weaned off that power, even to our own groups. We cannot do that because it's an absolute sign of weakness.
Yes.
And thank you so much for what you do.
Thank you. And it's therapeutic. Tears are therapeutic, absolutely.
We need someone like you in the business.
We need more women in the space.
Yes. Yeah.
Right? I always challenge other women. We birthed boys. What happens to that love? And then we complain about how aggressive in our men, how many marriages end because we say men are closed and dry. I see a lot of couples, I counsel a lot of couples where women are telling me that he's dry. But then if he never saw his dad cry, how is he gonna do it? Right?
I just want to add that a true feminist is the one fighting for the emasculated male.
Yes, I'm the healthy feminist, right? You're welcome.
Thank you, Doctor, for that outstanding presentation. And it's hard to follow a man giving first voice on that. So that's a great testimonial right there. I had two questions here, and actually maybe they're observations. I know you talked a lot about tribal and the Native Indigenous communities that are out there. And I'm just thinking outside the box again. We're all brought here for a reason, and I hope the takeaway is to stay connected and to build some collaboration. But I was wondering if you've given any thought from a psychological perspective of sacred circles, the healing circle, the talking circles that help men really be that first voice, and how I see telehealth. We're using it within our tribes, but we're trying to cross the border, so to speak. And, there are language differences, but there's still a lot of the same post-traumatic stress disorders. So healing circles, talking circles. And the other one is there are some great classes that are taking place that are called Sacred Men that help them to be better parents, especially those that maybe their kids have ended up in tribal courts and they have to demonstrate how and why they should be parents again. So I was just wondering in Canada if that's a part of that. If not, I'd love to be one of the first ones to bridge that gap.
I love that because thank you so much actually for your comment. I just did actually a short course on this lady who was working with the Mandela Foundation in South Africa. She was given a project in this really poor community where women were abused. There was a lot of GBV, teenage pregnancies, and these women were scared to leave their marriages. And this lady is a social worker. She came with a talk therapy and that shared pain. Today, these women have children that are social workers, that are teachers, and they have strength to leave because there was that shared community of sharing the stories. I'm not alone. So that's a good one. It's a matter of really to start it. Like I said, in my own community, I had to stop because I lost my dad in May, but otherwise it was going so well. It was a global community, and I honestly think if men could see also us women in their spaces, you'd be surprised the things they share and the things they don't necessarily share with their spouses, and would want to get them to do that. So thank you. That's a good point. And actually another one, I was going to work with this organization where they are doing the intergenerational sharing, where even now, the co-living. There's that concept now that's coming into Canada where seniors are living with younger people, they're sharing all this wisdom, so I'm hoping things like that could actually improve, and people, they are dying from loneliness, right? I mean, this side of the world is compared to where I come from, where we have that extended family unit. Unfortunately, people, they have this individualism, this side of the world. So things like that would actually improve even the mental health, right? Yes.
Awesome. Thank you so much for. We have a certificate for you.
Nothing like you, really, let's be honest.
Okay, so we reached our last speaker. And she is none other than Anhar Ali Al-Her. And with a nursing background, she is also the Director of Training, Research, and the CME Department. She's the President of Creativity in King Faisal Hospital in Al Hassa, Saudi Arabia. She is also a member of the public relations team in the Saudi Journalists Association. So you have someone who's really multi-talented. She is going to present a case, complicated COVID-19 infection in pregnancy, a case report with cardiac arrest and brain damage. So let us welcome Anhar Ali Al-Harris.
Thank you so much. Actually, it's a great introduction for me. I know this late time for you, but I try as much as I can to finish very early, in 10 minutes, because you have a trip. Okay, my name is Anhar Al-Hirz. I am a bachelor degree. I'm now I'm master nursing in community health nursing, and working as she said, a training director in King Faisal General Hospital. Today, I will present for you most interest case reports about the pregnant women with brain damage and cardiac arrest. I hope to be interested. Don't hesitate to ask me any question if you ask. Just to stop me because it is like a story. I will tell you as a story. My topic is complicated COVID-19 infection in pregnancy, a case report with cardiac arrest and brain damage. The content, it will be, I'll talk briefly introduction about COVID-19, case description, case outline, discussion summary, recommendation, finally conclusion, and I will talk briefly about the Vision Saudi Arabia 2030. The introduction, over 600 million people worldwide have been infected with the coronavirus disease pandemic, with estimated death of more than 6 million patients. Evidence has indicated that COVID-19 is not just respiratory condition, but is also with severe vascular disease that affect many organ system, include brain, heart, and kidney. Cardiac arrest is common in critical illness patients with COVID-19 and is associated with poor survival. As we know, most of here is a woman, must have know because of hormonal, there is a lot of changes during pregnancy. The immune system undergoes relevant changes. During pregnancy, the immune system of pregnant women is characterized by anti-inflammatory immune tolerance, like multisclerosis and cirrhosis and SLE, which result in many autoimmune disease. Go into remission only to flip up again in the early postpartum period. Only a few cases reported are available in the neonatal and maternal outcome of a pregnant woman with COVID-19. Although many pregnancies infected with COVID-19 have a good outcome, actually, we still need to learn how COVID-19 presents and progresses during a pregnancy. My case is about, now we will talk about my case report. It's attended to King Faisal General Hospital, actually, before 1 year. This is my case timeline. We will start from May 21 to June 30. My case description is the patient with 37 years old, pregnant, healthy woman with 35 weeks of gestation, with no medical history, 1 week history of fever, 40 degree, shortness of breath, and productive cough. The patient actually not immunized against COVID-19 because, as you know, during this time, there is we cannot, still insufficient of disease of studies that for pregnant women. During routine COVID testing in anticipation of hospital admission screening, the patient tested positive. The hospital initially placed the mother in the airborne infection isolation room under negative pressure. Prenatal screening test and examination were performed. All the results were within the normal range. Medication were administered to the patient according to the protocol of Ministry of the Health in Saudi Arabia. She was on a high flow oxygen 8 to 9 liter by a face mask respiratory distress. On May 29, after 1 week from she is coming to the emergency, the patient was admitted suddenly to the ICU because of acute hypoxic respiratory failure. To protect her life, the obstetrician consultant determined that
terminating the pregnancy would be appropriate procedure to her case. Now, after 1 day, and intrauterine fetal death and spontaneously delivery occurred. Neither bleeding nor infection was observed with after the delivery. The uterus was found to be fully contracted. Her condition worsened actually, and she was asked about her baby, and she is crying a lot of time. Blood and urine culture were taken this time, and normal findings were obtained. Here in June 1, the patient condition deteriorated, and her oxygen saturation was 84%. Intubation and mechanical ventilation were performed on this time. After intubation, lab results were normal, and the patient was hemodynamically stable. The patient was extubated on June 5, but failed because the patient agitates, and because she is conscious, and she removed the tube. And the patient, but failed and had to be intubated again. On June 6, the patient extubated and was fully conscious and hemodynamically stable, and her oxygen saturation came back to normal within 94% on a high flow nasal cannula. During this time, she experienced postpartum blues. Okay, we are on June 12th, the patient suddenly collapsed. I think it's a critical point here. And CPR was performed performed for 12 minutes according to the ACLS protocol. The patient was revived on mechanical ventilation with the Glasgow skills score of a 3 out of 5 without introbus and was hemodynamically stable. Chest X-ray were performed on this the same day, revealed bilateral infiltration. You can see the infiltration. It's appear here in chest X-ray actually. You have any question here? Okay. It's like a story. I think you are so interested to know what's the end. On June 12, the CT pulmonary angiography did not reveal any evidence of the pulmonary embolism. The brain CT was suspected to be infarction, and the radiologist advised repeating it after 24 hours. On June 30, repeated CT on the brain showed the brain edema after 24 hours after repeat this. After 3 days, a neurologist examined the patient and diagnosed anoxic brain damage. Actually, it's a bad story because the deterioration has come very fast. Tracheostomy was performed on the 21 June, and the patient was placed on the high flow oxygen. On June 29, the swab for COVID-19 was performed, and it's negative. During her stay in the ICU, she received multi-courses of antibiotic targeting multi-drug resistant organism, Klebsiella acinetobacter. Upon suspicion of concomitant bacterial infection was suspected. And additionally to the broad spectrum antibiotic administered, she received a lot of antibiotics like Clexane, salbutamol for bronchospasm. The patient was treated according to the Saudi Ministry of the Health Medications Protocol. At the end, the patient was discharged from the ICU with the brain death. Lab findings were generally accepted at that time. On August 30, patients get severe sepsis with picture of septic shock, not response to any antibiotic or any treatment in this time. The death was declared on August 31, actually. It's a bad story. In summary, here, after finish this case, we present a case of maternal COVID-19 during pregnancy, combined with cardiac arrest and brain damage. Why you are sad? Very sad. She is dead. Okay, so our recommendation after this this case study, the American College of Obstetrician and Gynecologists recommended that all eligible persons, include pregnant and lactating individual, receive a COVID-19 vaccine. Pregnant individuals are encouraged to discuss vaccination consideration with their clinical care team, with possible documentation of such discussion. Such a discussion should not be required prior receiving a COVID-19 vaccine. Further, pregnant individuals should not be denied COVID-19 vaccine because of their pregnancy status alone. COVID-19 vaccine sites should be considered to recommend the recommendation regarding vaccinating pregnant individual. So, in conclusion, pregnancy and COVID-19 infection, cardiac arrest, and intrauterine fetal death were factors contribute to poor outcome. Pregnant women should be recognized as vulnerable group during the current pandemic because evidence suggests negative outcome of COVID-19 infection during the pregnancy. This makes dealing with a pregnant patient carry COVID-19 extremely very challenging. I'm so sorry about that. Okay, let me talk briefly about the vision of Saudi Arabia 2030. I would briefly discuss how Saudi Arabia government responds to corona pandemic successfully under the leader of King Salman bin Abdulaziz and Prince Mohammed bin Salman, our successful leader. Quite not working. Saudi Vision 2030, targeting to putting a strong strategy to promote health and prevent disease against any kind of pandemic in future. Also, Saudi Health Institution for 2030, targeting to promote the preventive and public health against any kind of pandemic disease by putting strong healthcare planning and pandemic emergency preparedness to control the spread of virus and prevent the negative health complication and the outcome in the future. At the end, I just want to very thankful to my team work in this case presentation, Dr. Ula Al-Musa, Dr. Nasser Al-Abbad, Dr. Adib Al-Mubarak, and Mr. Bishair Al-Jafar. Thank you so much. Do you have any question?
Hi,
Hello.
how's it going?
Fine, good.
Good, good, good.
We want to go to travel.
I'm gonna be good. I'm gonna be good. I want to go too. It's not just you. We're on the same.
So good.
I recall when we were rolling out the vaccine that obviously to begin with the government in the UK said, you know, don't vaccinate the pregnant women to begin with. And then they said vaccinate the pregnant women. And it was very, very hard to get them. And I don't blame them at all. They're trying to protect their baby. They didn't know enough information.
Yeah, there is not a lot of information about the vaccination. That's why we have to make a lot of researches and case reports to improve our care providing. As the doctor said, we have insufficient research center in Saudi Arabia to report these cases. That's why we have to focus and make a lot of researches and case reports to know how the vaccine affect in the pregnancy actually.
Definitely. And that was for us, I don't know when that was, it must have been about a year ago, something like that. So since then, there has been a lot more literature on it. and a lot more people that have been pregnant that have taken the vaccine. But obviously now we're at a point where people relaxed a bit more,
Yeah.
and a small percentage are taking it anyway, whether they're pregnant or not. But I just wanted to know how you were going to tackle the, you've already told me, but okay. Thank you, Penelope. Really appreciate that. Thank you, everyone.
Thank you very much.
Thank you.
Actually, it's not a question, it's a comment, since we are from the same country.
Yeah.
I would like to say Saudi Arabia and the United Arab Emirates is one of the leading countries in the world in regard for saving people in terms of COVID-19.
Yeah.
And you can go back to the records and find out exactly this information. So don't misunderstand this story as a background for the whole situation in that region. So hopefully, I mean, if we go back to the internet, we will see the records about these informations. And I'm saying, or I'm meaning what I'm saying about that. Saudi Arabia is probably now the second country in the world in terms of leading of the experimental done in terms of COVID-19. So hopefully things will improve in the future in
Yes.
saving people in terms of COVID-19 like pandemics.
Thank you.
Maybe vaccination or treatment.
I'm talking about how to deal with COVID-19, not in vaccination. Vaccination, you can buy it from anywhere.
Yes, good evening.
Hi.
Actually, yes, true. What he said about the pandemic about COVID recently, I think UAE, I was involved in the program for COVID for treatment and giving the vaccine and everything. So the system was really strong, really, and they did very great job in controlling the endemic of COVID-19. I just want to say thank you very much, Shirley, for the job.
Thank you. Thank you so much. Thank you.
Any other question? Actually, it's another comment. I just want to say thank you for sharing this information. This is my day two here, and I just learned that Saudi and UAE, it seems like we were really, really looking into the patient safety and health practices. And thank you for sharing the culture with us and information. And I would love to visit UAE.
We hope that, yeah, for sure.
Thank you for your information.
Thank you so much. Thank you.
Any other question?
Yeah.
Anhar, it's always good to know what other countries are doing. You know, having worked in a maternity hospital for a number of years in the UAE, I understand a lot about the safety that goes, the research and the safety implementation that goes on. But like every other country, we have challenges, and during COVID, we all, experienced that. Thank you very much for your talk.
Thank
We
you
have a
so much.
certificate.
Thank you so much. Thank you.
So everyone, we've come to the end of our session today. So I think people are waiting to run. So thank you everyone for today and for listening patiently to everything. Have a good evening.
Let's go. Have to change our approach to it. I don't know.
Where can I see what you did? I mixed my own water in now you're not as much. During your place. Where am I? I'll ask chairperson. Very good.
دكتور وليد ضيفي بدنا إياه. One second. In this flash, Dr. Walid's presentation or where?
No, this is not Dr. Walid's flash.
So what is his flash?
It is for this one. I
Yes,
think see, he got it. It's flash.
I think that because I didn't saw any flash, okay, we have to make leave.
Yeah, we need to leave the meeting.